Good morning, ladies and gentlemen. Let's get started. We are running a bit late. My name is Magda Rubal. I'm the UHC co-chair, UHC 2030 co-chair, and it is a great pleasure to welcome you this morning for this event on the central role of social participation and multilateral cooperation in advancing health sovereignty. Without further ado, I would like to invite Madam Fernanda Magano, the President of the National Health Council of Brazil, to come and open the event for us.
Olá, bom dia a todos. Estou aqui para que a gente possa fazer esse momento importante dos 2 anos da nossa resolução de participação social. Quero saudar e agradecer a todos os colaboradores do Brasil e da OMS, mas os nossos parceiros que ajudaram a construir todo o trabalho aí com a Tailândia, a Eslovênia e a França, a Noruega, a UHC-2030 e a CSEM. É muito importante.
Good morning, everyone. I'm here at this very important moment of the 2 years of our resolution of social participation. I would like to acknowledge and thank all the partners from Brazil and WHO that have helped build this important work together with Slovenia, Thailand, France, and Norway for the HC 2030.
É muito um momento feliz e de continuidade dessa construção. E queremos agradecer o ministro da Tunísia e também o ministro do Brasil, Alexandre Padilha, que está a caminho.
It is a moment of great joy to celebrate the continuity of what we have built so far. I would like to thank the Minister of Tunisia and also the Minister of Brazil, Mr. Alexandre Padilha.
Esse evento, esse café da manhã, tem aí o tema central da participação social, a soberania sanitária e o multilateralismo.
Well, this event during this breakfast we're having together has a couple of central topics: social participation, health sovereignty, and multilateralism.
A contribuição do Brasil para os mecanismos de participação social e a construção da reforma sanitária. E comemoramos este ano os 40 anos da conferência de número 8º, que foi a conferência onde se iniciou a participação social no Brasil.
We're also touching on a very important topic of the contribution of Brazil for social participation mechanisms. And we're also here to build on the health reform that we need so much. It is also the celebration of the 40th year of the 8th conference, which was the beginning of the social participation mechanism in Brazil.
Queremos destacar a importância que foi a presença do Coral Group na nossa 5ª Conferência Nacional de Saúde do Trabalhador e da Trabalhadora, para avançar nos nossos compromissos com o multilateralismo.
We would also like to highlight the importance of the presence of the Coral Group in the 5th Labor Health National Conference in order to move forward with our goals.
A soberania sanitária e a construção com os nossos pares no mundo ajudam a enfrentar toda a situação complexa da geopolítica atual.
Health sovereignty and the work that we've built so far with our peers all over the world help us face this complex situation in terms of geopolitical challenges.
Por isso, queremos destacar a prioridade política do Brasil na construção da participação social. Temos o nosso livro contando a história da resolução e aqui no marcador o livro em inglês no QR Code.
Therefore, we would like to highlight the political importance of Brazil social participation. We have presented here the book that shows the history of social participation in Brazil. It includes a QR code that you can scan in order to access it.
E para finalizando, quero destacar a construção que estamos fazendo para a 18ª Conferência Nacional de Saúde. E queremos construir a possibilidade de que vocês possam estar conosco em julho de 2027.
In order to conclude, I would like to highlight the importance of the 18th National Health Conference that we are organizing, and I would like to invite you to consider the possibility of joining us in July 2027.
E, para finalizar, a nossa alegria de que no relatório oficial foi citada a nossa construção do Corel Group e a presença dos representantes no Brasil na Conferência de Saúde do Trabalhador e da Trabalhadora.
I would also like to state that we are very glad that we were mentioned, the Corel Group and the presence of their representatives in Brazil in the resolution.
Muito bom, vamos construir aqui uma boa manhã debatendo a continuidade da participação social no mundo. Só com a presença dos cidadãos e cidadãs conseguimos defender as políticas públicas de saúde e a garantia sanitária.
Very well. I hope we have a very fruitful morning together, discussing the continuity of social participation. It is only with the participation of citizens and civil society that we will move forward defending this important cause.
Obrigada.
Thank you. Thank you very much, Fernanda Magano, for those inspiring words as we start this event this morning. I would like to take a moment to warmly welcome the Honorable Minister of Health of Brazil and the Honorable Minister of Health of Tunisia. Thank you for joining us. So we are going to continue our agenda today, which I have the pleasure to moderate. We are here this morning because we are asking a question that goes to the heart of why multilateralism do matter. What makes health policy legitimate? That's the question we are asking this morning. And our answer is embedded in the resolution WHA77.2, where social participation for universal health coverage, health and well-being is framed. Not as a consultation exercise, but as a governance function that connects populations to the decisions that shape their lives. Our program this morning will move from around 3 steps. The first step, we will hear from 2 speakers who have worked at the intersection of social participation and health systems. Then we have 2 ministers who will address the high-level political dimensions of this agenda, and we will close with a multi-stakeholder roundtable posing one central question: how can social participation strengthen health sovereignty from below and rebuild trust in multilateralism from within? We are running late. We are 15 minutes or somewhere around there late. So I will really be counting on the collaboration of the speakers to help me manage this event. I'm pleased now to give the floor immediately to Dr. Calypso Chalkidou, the Director of Performance, Financing and Delivery at WHO headquarters. Calypso.
Thank you. Thank you, Magda. Thank you, everybody. Excellencies, distinguished delegates, colleagues from civil society, partners, and friends. It's a great pleasure to welcome you to this side event of the 79th World Health Assembly. I would very much like to thank the co-sponsors, Brazil, France, Norway, Slovenia, Thailand, Tunisia, UHC 2030, and the civil society engagement mechanism for bringing together such a broad and powerful coalition. We come together at a time when health sovereignty has re-emerged as a defining objective for governments and societies alike, in a world shaped by geopolitical rifts, steep cuts in development assistance, rising debt, inflation, food poverty, social unrest, and growing inequalities. Against this backdrop, the implementation of the resolution on social participation for universal health coverage, health and well-being is of critical importance. The resolution affirms a simple but powerful idea that health systems are the strongest, most resilient, most effective when people are meaningfully involved in their governance. It's not about participation as consultation. It's not a tokenistic box-ticking exercise. It's not about a single meeting where others are invited to speak. It's about deliberation, when judgment has to be justified and reasons for decisions given. It's about the institutionalized process of participation as a core function of how health systems are governed. In the current context of shrinking development assistance, constrained fiscal space, and increasingly difficult trade-offs which have to be made, the choices made by decision makers require social participation. And this is a tool for grounding these decisions on lived realities of those affected by them, for prioritizing fairly, and for maintaining trust, especially given how hard these choices are. And in this light, social participation is the foundation of health sovereignty. Health sovereignty is discussed often in terms of production capacity, technology transfer, regulatory autonomy. All of these matter. But the hardware, that's the hardware of sovereignty. The software of sovereignty is the people, and it's social participation through institutionalized mechanisms. Who defines priorities, how these priorities are defined, and how legitimacy is ultimately built. So, institutionalized social participation strengthens transparency, accountability, and public confidence in the reforms and the choices made. Now, the resolution gives WHO a very clear mandate. Member states have asked us to facilitate learning and exchange across countries and regions, support the institutionalization of social participation, and help translate political commitment into durable governance arrangements. In response, we at WHO are working with countries to integrate participation into national health strategies and plans, to link participatory processes to priority setting, budgeting, and monitoring, and to ensure that participation is inclusive, equitable, and safeguarded against conflicts of interest. For us at WHO, this is not a one-size-fits-all model. It's country-led, it's country-sensitive, it's context-sensitive. It's rooted in context, in fact, in history and constitutional arrangements. We're here to convene. We're here as a technical partner and a custodian of shared learning. We're never here as a prescriber of what is right. Today's dialogue brings together ministers, member state representatives, civil society leaders who are actively shaping this agenda: Brazil, Thailand, Europe, Africa, and beyond. The experiences you will hear demonstrate that social participation can and does strengthen policy continuity, it protects equity, and it reinforces sovereignty. For WHO, this discussion will directly inform how we continue to support the implementation of the resolution and how we embed social participation more systematically in health system strengthening processes. And this includes the analytical normative work we're doing, and it also includes the journey towards the United Nations high-level meeting on universal coverage in 2027 in New York City next September. We're very much counting on your support, on your participation, on your leadership to shape the post-2030 agenda on universal coverage. So I very much look forward to the discussion ahead. I very much look forward to working with you, and I'm very thankful for your attention and your time. Thank you.
Thank you very much, Calypso, for setting the scene and then framing how and why the resolution is so important. What we have just heard reminds us that social participation is not a soft add-on to health system design. It is what makes health systems work for the people they are meant to serve. Implementing universal health coverage commitments becomes more effective, equitable, and grounded in reality when communities help shape how global commitments are put into practice. It is now a great pleasure for me to call upon Ms. Nanut Maturapote, Director of the Global Collaboration Units at Thailand's National Health Commission Office, whose country has built one of the world's most distinctive models of participatory health governance. Thailand has also been one of the pen holders of the resolution, truly a champion in this agenda. The floor is yours.
Thank you. Thank you very much. Distinguished delegates, excellencies, colleagues, and friends, good morning, and it's an honor to join you today on behalf of Thailand at this important side event. I would like to express my sincere appreciation to the government of Brazil, particularly the National Health Council, for its leadership in advancing social participation both nationally and globally. And I also wish to thank you for hosting this important side event. However, we are meeting at a time of increasing global uncertainty and challenges, and this widening inequalities. And in this context, trust has become one of the most critical foundations of resilient health systems and effective multilateral cooperation. Our Deputy Prime Minister and the Minister of Foreign Affairs stressed the importance of an effective and impactful foreign policy. We are advancing what we call Diplomacy 2.0, a pragmatic, multi-directional, and partnership-oriented approach to multilateral cooperation. He also underscored that a policy must begin at home, driven in unison for the interests of Thailand and the Thai people. Thailand values health sovereignty, the ability of each country to shape its health policies according to its context and priorities. We believe that when people are meaningfully involved in shaping policies that affect their lives, the policies become more responsive, legitimate, and accountable. Therefore, social participation is not simply consultation, it is participatory governance. Our universal health coverage is grounded not only in financing and service delivery, but also in social participation. We organize a public hearing annually to improve benefit package of universal coverage scheme. Moreover, a participatory mechanism as the National Health Assembly, where government, academia, civil society, and youth come together, is organized annually to deliberate on national priorities and develop policy recommendations for health and well-being. It is worth sharing that last year, one of the resolutions of our assembly focuses on the impact of geopolitical turbulence on Thai health systems. The National Health Assemblies allows societies to navigate difficult transition based on lived experience and technical evidence. And this timely resolution was submitted to the National Health Commission. Excellencies, we have also applied the principle of social participation beyond domestic health policy. For more than a decade, Thailand has maintained regular informal dialogue between health actors, international trade negotiators, and civil society organizations. This multi-stakeholder engagement has helped build mutual understanding, reduce distrust, and create more balanced approach between trade and health interests. Excellency and colleagues, at a time of geopolitical instability, true health sovereignty does not come from isolation, but from trusted institutions, empowered communities, and strong multilateral cooperation both nationally and globally. Thailand strongly believes that the countries become stronger externally when they are more united internally, and social participation helps create that unity. And we will set up the WHO Collaborating Center on Social Participation to unite everyone to advance this agenda. And we look forward to working with you all. Thank you.
Thank you. Thank you very much, Ms. Nanut Maturapote, for sharing those insights with us. What we are hearing is a consistent message. When communities help define health priorities, governments are better equipped to defend those priorities nationally and internationally, aligning their interests from home to global levels. Regular and meaningful social participation is necessary to ensure the accountability and legitimacy of health system strengthening and universal health coverage efforts. We are now moving to a high-level segment of this conversation, and we will hear from two leaders who can speak to the political weight of this agenda at the highest level. I'm honored to invite His Excellency Dr. Alexandre Padilha, the Minister of State for Health of Brazil, the country that is graciously hosting us today, to address us first.
Distinguished Minister of Tunisia, esteemed colleagues, representatives of civil society, and partners. Good morning, everyone. It's our profound honor to stand before you today as Brazil reaffirms its unwavering commitment to the principles of health sovereignty, social participation, and multilateral cooperation. I extend my deepest gratitude to the co-sponsors and collaborators of this pivotal event, and to the architects of the WHA79.2, Thailand, Slovenia, Tunisia, France, Norway, the CSEM, and UHC 2030. Your leadership has turned a shared vision into an actionable policy, and Brazil thanks you. This parallel event is not merely a forum for dialogue. It's a catalyst for systemic change. At its core lies a simple truth. Health sovereignty cannot be a top-down process. It must be a bottom-up construction through the active, protected, and meaningful participation of the people. In Brazil, this is not an aspiration. It's a constitutional and legal guarantee. Our unified health system, SUS, is anchored by the National Health Council and National Health Conference, where civil society, workers, marginalized communities co-decide on policies, budgets, and priorities. In August 2025, the international delegation of our core group witnessed this democracy in action at the 5th National Conference on Workers' Health. That visit was not symbolic. It was a commitment to translate global solidarity into local empowerment. Today, we navigate a world of intersecting crises: climate shocks, inequalities, geopolitical fragmentation, and the lingering aftershocks of pandemics. In this landscape, health sovereignty is our collective shield. States are responsible to define their health priorities, protect their populations, and negotiate as equals on the global stage. But sovereignty without solidarity is isolation. True health security thrives on multilateralism, on sharing data, technology, and best practices, and on ensuring that vulnerable populations are never left behind. How do we advance this agenda? First, governments should institutionalize social participation, not as consultation, but as co-governance. Protect the legal frameworks that give civil society a seat at the table. Second, align national health plans with priorities identified by communities themselves. especially those in informal economies, indigenous territories, and peripheral urban areas. Third, leverage multilateral platforms to exchange models of participatory governance, particularly with local governments, scale up South-South and triangular cooperation, and ensure that WHA 77.2 is implemented with urgency and accountability. The Brazil of President Lula's government stands ready to share its legal frameworks and its conference methodologies. In line with this high-level political, we will invite every Minister of Health, every civil society organization, every local governments, and every international partners to join us in weaving participation to the fabric of global health governance. Let us move from rhetoric to practice, from promise to protected rights, from national agendas to a truly sovereign, equitable, and multilateral health future. Brazil is ready to share its experience on building its health system in an inclusive and democratic manner, envisage a better world with health for all. Thank you.
His Excellency Professor Dr. Mustafa Ferjani, Minister of Health of Tunisia, to address the gathering. Thank you.
Excellencies, Mr. Minister of Health in Brasilia, distinguished ministers, dear partners, ladies and gentlemen, let me begin by thanking Brazil and all co-organizers and sponsors for creating this important space for dialogue. The question before us today is simple, but decisive. How can countries strengthen health sovereignty while remaining fully accountable to their people? For Tunisia, the answer is clear. We cannot separate health sovereignty from social participation. Health sovereignty without social participation becomes mere administration, and social participation without real national ownership becomes symbolic consultation. The two must go together. For Tunisia, health sovereignty doesn't mean closing doors. It means the capacity to define our priorities, to protect our population, to mobilize our institutions, and to build partnership based on our national needs, with citizens not above them. This is why Tunisia has invested for many years in participatory health governance. Through our health district model, local health councils bring together public authorities, health professionals, civil society, and community representatives. They are not simply observers. They contribute to decisions that affect people's daily lives. Our National Health Policy 2026-2030 was also built through a broad societal dialogue involving citizens, civil society, experts, professionals, and region. It was not written behind closed doors, and because participation must not stop when a policy is adopted, we established a dedicated participatory governance committee with the Ministry of Health. Its mission is to make participation structured, continuous, and meaningful, not ceremonial. We have also integrated accountability into our national health calendar with national evaluation of health policy based in citizen consultation. because real participation means accepting to be evaluated by the people we serve. Our recent example is particularly important. Tunisia has signed formal partnership contracts with civil society organizations working in HIV prevention. This organization now have an official role in the National Health Program and recognized mandate and access to public funding. This means that civil society is no longer only consulted, it's helping to deliver public health alongside the state. This sends a strong message. Social participation is not only about having a seat at the table, it's about having a real role in steering public health action. And this for Tunisia is health sovereignty in practice, a state that governs with its people on its own terms while remaining open to international cooperation. This is also where multilateral cooperation becomes essential. Good multilateralism should not replace national priorities. It should strengthen the ability of countries to define them, to own them, and to be accountable for them. Resolution of the World Health Assembly 77.2 gives us a shared framework. Tunisia contributes to this momentum and remains committed to its implementation. But frameworks alone don't change lives. What changes lives is political will, the daily decision to govern with people, not only for people. At a time when civic space is shrinking in many places and when civil society organizations face financial and institutional pressures, defending social participation is not technical detail. It's a political choice. It means recognizing that the people most affected by health decisions must have the right to shape them. Tunisia is committed to this path and to welcoming it with all partners represented in this room. Thank you, and I hope you understand my English.
On a bien compris votre anglais, Monsieur le Ministre. Merci beaucoup. I want to thank both ministers and for the experiences they have shared with us. We have heard the political case for social participation both in Tunisia and Brazil, and they clearly indicated that social participation is a pillar of health sovereignty. The Minister of Health of Tunisia reminded us that it is not a technical detail, but it's a political choice. We are now going to move to the next segment of this event. We are going to listen to practitioners, tested practitioners, civil society, and those who live with the consequences of decisions made with or without them. I want to be clear about the framing for this roundtable. We are not discussing participation as consultation. We are discussing it as a governance function, one that legitimizes health policy and builds sustained political will for universal health coverage, both at home and internationally. Our panelists bring 5 very different angles to this, and I will briefly introduce each one of them, invite them for a short statement. I'm feeling lonely over here, so I hope you can come and join me. And then, unfortunately, you will only have approximately 2 minutes to make your case, to make your points, and then we'll open the floor for dialogue. I want to invite Dr. Natasha Azzopardi-Muscat. Dr. Natasha is Director of Health Systems at WHO Europe. She will show us how participation is embedded in the work of the WHO regional office in Europe as a health system function, not a political afterthought or a technical detail. Priscilla Torres is a national health counselor of Brazil and a representative of the Beer Red Brazil social movement. And she will speak from inside the system and tell us what genuine participation looks like when it works and what threatens it when it does not work. I'm also inviting Stephanie Sargent, a Global Youth Champions Coordinator at Act for Food and Gain and a member of WHO Youth Council. Thank you for joining us. She's joining us from Kenya. She will bring a youth perspective. What does health sovereignty mean to the generation that will live longest with the decisions being made in this room by those of us who have reached a certain age? I'm also inviting Ali Asnain, a policy specialist at United for Global Mental Health. He will challenge us to think about who is still excluded from participation processes and what health sovereignty and participation really mean for communities that have historically been left out. And then last but not least, Vesna Kerstin Petric, head of office for cooperation with WHO, Ministry of Health of Slovenia. And then she will speak to the member state perspective. How does social participation to build legitimacy at home and credibility in multilateral negotiations? Ladies and gentlemen, the floor is yours. I will start with Dr. Natasha.
Thank you very much, Dr. Magda. Good morning, everyone, Your Excellencies, distinguished guests. And it's a pleasure for me to be able to talk to you very briefly and touch upon some of the because we had a large-scale consultation, we really opened up to everyone. Today's technology permits us to do this. But more importantly, and this is an appeal that I have, as we are working with countries who are now going to start thinking of their national health strategies beyond 2030, this is really the time to make sure that we are listening and engaging people. Why? Because as the ministers present today no doubt will tell you, today politicians engage directly with people, with movements, and listen to people through social media. So unless we as health policymakers work with people, we will not even get through to politicians and make sure that the right policy decisions are being made. This is the reality. The question is whose voices are heard and whose voices are not heard in this process. Because particularly in the age of algorithms and social media, this is where we risk having key voices drowned out. And here is why, for example, in Euro, through the work of the Pan-European Mental Health Coalition, we are working to build the capacity of people with lived experience of mental health, to equip them to see how their voice can matter and can carry such that they have the tools, the skills and the advocacy. The same work we had done with our Youth for Health network in Euro, because this is really key. You've asked me to be short, so my last point will be that, of course, as WHO, we also must stick with the science and the technical excellence. And in this respect, I'm very heartened to see the interest also and the designation of collaborating centers who will help us show through the evidence, through the evaluation, through the measurement, that social participation is not a luxury. It is a necessity. And that when social participation fails, policies fails. This will be very, very clear in our forthcoming second health equity status report for the region. You will see that some countries have managed to reduce health inequities, in others health inequities have grown. Where they have grown, the decline has been largest in the social inclusion domain, a domain where social participation can make a huge difference. So if we care about reducing health inequities, let us mainstream social participation.
Thank you very much, Dr. Natasha. Let me now move to Brazil. Priscilla, Brazil's model was built over decades. What is the minimum viable version for a country that is just starting? What should they do first? Thank you.
O mais importante da participação social é quando os nossos governos, a gestão pública, ouve a necessidade da população do seu território. E podemos dizer que o Brasil, a soberania nacional se fortalece.
The most important thing to be considered for social participation is when the governments and the partners in government society hear the needs of the population of their territory. When it comes to national sovereignty,
a soberania nacional se fortalece quando o país investe em ciência, produção local de medicamentos, vacinação, vigilância em saúde e políticas públicas capazes de enfrentar com equidade e autonomia tanto as doenças infecto-contagiosas quanto as doenças crônicas não transmissíveis.
National sovereignty in Brazil will only become stronger if the country starts investing in science, local manufacturing of medication, vaccination, health surveillance, and public policies that are able to face with equity and autonomy both infectious diseases and chronic non-communicable diseases as well.
O primeiro medicamento utilizado no tratamento da HIV/AIDS no Brasil foi o AZT. Aprovado internacionalmente em 1987. No Brasil, ele começou a ser distribuído no Sistema Único de Saúde no início da década de 1990.
The first medication used for treatment of HIV was AZT that was internationally approved in 1987. In Brazil, it started being distributed by our universal system called SUS in the beginning of the 90s.
Já a produção nacional do primeiro medicamento contra HIV aconteceu no ano de 1993, quando o Brasil passou a fabricar o medicamento em território nacional e foi um marco para a saúde pública brasileira.
The national manufacturing of this first medication for HIV started in 1993 in Brazil, when it started producing AZT in national territory. This was a historic milestone for Brazilian public health.
Isso ajudou a enfrentar o enfrentamento da epidemia da HIV/AIDS no Brasil. E esse avanço foi fundamental para que, alguns anos depois, o Brasil se tornasse referência mundial para garantir o acesso universal e gratuito aos antirretrovirais no Sistema Único de Saúde.
This has helped us expand the access to treatment and reinforce the policy of facing the epidemic of HIV through SUS system SUS. This progress was crucial so that years later, Brazil could become a world reference in ensuring universal access and free access to antiretroviral medication through SUS, a policy that was consolidated through the legislation 9.313 in 1996.
A participação social efetiva ela é concluída quando a gestão, o Ministério da Saúde dos nossos países permitem que pessoas com doenças crônicas, com doenças incuráveis, possam viver com qualidade de vida sem nenhuma característica de suas doenças. Eu sou uma pessoa que convive com artrite reumatoide, uma doença que o nosso país produz inovação tecnológica, fornece as maiores inovações no Sistema Único de Saúde, o que me permite viver como se não tivesse uma doença degenerativa, totalmente deformativa, porque o Sistema Único de Saúde cuida da população brasileira, ouvindo a necessidade social do seu povo e a necessidade do nosso país.
Social participation can only become effective when the ministers of our countries can hear what we need, can hear the needs of patients who live with chronic diseases and can improve their quality of life. I am a person who lives life with rheumatoids, and it is only through the innovation and the medication available through our universal health system that I could, as a person who suffers from a degenerative disease, have quality of life enough. And it is only governments who care for the needs of their population, as the government of Brazil cares for the Brazilian people, that we can truly meet their social needs.
Thank you. Muito obrigada, Priscila, por esse testemunho e esse exemplo que acabou de partilhar conosco. I want to find out whether the video is ready. Can we join Rosemary Mburo, who is the Executive Director of WHA Health, and she's joining us from Kenya. Rosemary.
Friends, greetings. Colleagues, partners, and friends, greetings from Nairobi. Thank you for the opportunity to offer a civil society perspective on the role of social participation in advancing health sovereignty, particularly in the African region. And I would like to ground my reflection in two realities. First is the conversation about social participation is fundamentally a conversation about equity. At its core lies the uncomfortable truth that more than half of the world's population still lacks access to essential health services. And in that context, social participation cannot be treated as a procedural exercise or a checkbox within health governance. It is fundamentally a leadership issue. It requires leadership that can translate a resolution, a WHA resolution, into strategy, and a strategy into action. Leadership that can move political declarations beyond paper and into the lived realities of people and communities. And the second reality is that countries, particularly in Africa, are becoming increasingly assertive about health sovereignty. Our governments are speaking more clearly, more confidently, and more intentionally about the need to shape health priorities in ways that reflect national realities and aspirations. Initiatives such as the Lusaka Agenda and the Accra Reset actually reflect this shift. And if sovereignty means countries having greater ownership, greater leadership, and greater influence over decisions that affect the health of their people, then we must ask some difficult but necessary questions. How can we call it a country vision without the voice of people and communities shaping that vision? How can we speak of national priorities if communities are absent from the agenda setting and decision making? And how can we speak meaningfully about sovereignty if it does not ultimately reflect the will, dignity, and lived realities of people and communities? So social participation is not peripheral to health sovereignty. It is central to it. It strengthens inclusive governance. It builds trust between institutions and communities. It helps rebalance power. And it reinforces accountability. And ultimately, accountability is the bedrock of health sovereignty. So Here is to making social participation a reality towards advancing health sovereignty. I thank you very much.
Thank you, Rosemary. I'm now turning to Stephanie, and I want to hear from Stephanie. Can you tell us who's still been left behind, who's not at the table? And we have heard that it's not enough to be at the table, but you need to have a role, you need to have a voice.
I certainly
The floor
can.
is yours.
Thank you so much. In 2015, there were already 1.2 billion people aged 15 to 24. And by 2030, this number is expected to increase by 7%. Currently, in Africa, approximately 60% of the population is under the age of 25, making this the largest generation of youth in history. And young people are living through some of the world's most urgent challenges, like climate change, health crises, war and conflict, and social inequities. And we are often among the first to feel the impact, and we will be next in line to deal with the consequences. But we are not only affected by these challenges, we are part of the solution. We represent enormous potential to shape national priorities, strengthen trust in institutions, encourage multilateral cooperation, and contribute to health sovereignty. Yet too often we are overlooked, underrepresented, or invited only after decisions have been made. But it's not all doom and gloom. We have some key successful interventions at GAIN and Act for Food, where we have been developing youth engagement frameworks and creating platforms for meaningful youth engagement in policy dialogues. And today I will focus on one key area of the framework, which is representation. And representation matters because social participation cannot be meaningful if the same voices are always in the room. Meaningful youth engagement requires moving beyond consultation to active participation, where young people are recognized not just as beneficiaries, but as collaborators and partners. In Bangladesh, young people built a relationship with their government through regular and sustained engagement in meetings, which over time built trust and enabled young people to contribute meaningfully to the National Nutrition Policy Review. In Tanzania, youth leaders have participated in various policy processes like ministerial consultations, national and local government budget and policy development meetings, and the National Multisectoral Nutrition Review. These examples show young people, when they are given the structured opportunities to participate, can shape real policy outcomes. And youth-led networks and movements are just as critical. The former Act for Food Nigeria youth leader is currently serving as a food systems thematic lead, heading a national task force to empower young people as changemakers. In the United Kingdom, Bite Back 2030, which was founded by a former Act for Food UK youth leader, has driven regulatory reform, most notably contributing to the UK government's decision to restrict junk food advertising online and on television before 9 p.m. These examples show youth participation is not symbolic, but can influence policy, strengthen accountability, and help governments design health and food systems that reflect lived realities. We need to acknowledge that youth are diverse and their needs vary based on age, gender, and context, because more often than not, when engaging with young people, we reach the most visible, the most educated, those living in urban areas, English-speaking youth, and we completely miss out on young people in rural areas, out of school, displaced, and or do not speak English. And if youth social participation is to strengthen health sovereignty, then it must reach beyond the usual voices. We must commit to institutionalizing meaningful social participation, not as a one-off, but as a permanent part of health governance. And to kind of close, because I know I don't have time, to bring us back to why we're here in the first place and why this matters, quoting the president of the World Heart Federation, Dr. Jagat Nurullah, declarations and resolutions don't save lives, decisions do. Thank you.
Thank you, Stephanie. Declarations don't save lives, but decisions do. And let's not forget the young people in rural areas, in displaced settings, those who don't speak English, Now, very often we think everyone understands and speaks English, and that's not true. That's my case. So remember those left behind and not at the table, and sometimes those pushed behind by our actions or lack of actions. Let me now turn to Ali and then ask, what's the one concrete action you would ask member states, CSOs, or WHO to take before the next WHA?
Absolutely. Can you hear me? Sorry. Can you hear me now? I'd like to start first by thanking the government of Brazil for creating this opportunity, and also briefly just talk about an issue that they've done a lot in the world, probably the most amongst countries in recent times. I know someone personally who was locked away in an institution against their will. She suffered severe neglect, abuse, over medicalization as well. Two of her friends died in that hospital. Both of them were under the age of 20. She herself is a young girl as well, and she was told that she would be admitted in that institution for 2 weeks, but she ended up staying there for 14 months. There are too many others like her, around 8.4 million per year, actually, and to put that in context, that's the entire population of Switzerland. And that's how many people are admitted annually against their will in institutions without even a say in their own care. And the communities have often viewed them as people who would not be worthy of being a part of the community, let alone health governance. That same young girl that I was talking about is now a member of our Expert by Experience Action Group on deinstitutionalization. She was invited by the WHO and paid by the WHO as an expert to give input on their guidance on deinstitutionalization that's coming out in October. They saw the value of having someone who can not only identify gaps in the existing system better than most people, because she's experienced a lot of those gaps personally, but also someone who can speak to prevention and how what she went through could have been prevented, speak to early intervention as well, which in and of itself would save governments enormous amounts of financial investment as well that they otherwise would need to do. So that's an example of why governments should meaningfully engage experts by experience, and that would be the one thing that I would say that they need to do, if that is a priority issue. But an inclusive system that has meaningful social participation for people like her, for people with lived experience, relies essentially on two things. First, you need to acknowledge the expertise that they bring to the table. They have genuine value to bring to discussions from their experience, their practical experience, which I think is as valuable as any book or degree. And you have to respect that experience and expertise, and that has to be the meaningful foundation of social participation. And secondly, you invite them as equals to the policy discussions. And I'll give you an example of this very quickly. In Nigeria, there's a lot of very progressive work happening in Africa, but in Nigeria, there is a technical suicide prevention working group that was established by the government. That working group contains civil society, people with lived experience, mental health professionals, but also members of government. They work together to develop what I think is probably the most progressive suicide prevention act anywhere in the world. It's currently in Parliament as a bill, and that same bill is now being circulated in Sierra Leone, in the Gambia, and is being replicated everywhere. That is a model of true social participation that could change suicide prevention landscapes across Africa. And that's just one example of the power of meaningful social participation. So I think all we really need is openness and respect. We, as civil society, as people with lived experience, are here to help and support governments. Let us help you. Thank you.
Thank you again for that beautiful example of one of the most neglected conditions, which is mental health. Thank you for reminding us how important it is for us to take care of mental health. Let me now turn to Vesna. You represent a smaller, high-income country. What's Slovenia's stake in this agenda, and what does multilateral solidarity look like in practice from your perspective? When I say smaller country, please don't feel offended. I come from an even smaller country. Thank you. The floor is yours.
Thank you very much. Believe me, I really am not offended. I think we are super small but super powerful. When I have a speech, but I don't need to deliver it because everything has been said by previous panelists. So I'll focus more on what needs to be done next. But anyway, I will refer how it all started. When I, as a EB chair in 2023 launched the idea of adopting resolution, there was not even a clear definition what social participation is. We had to work hard with WHO, and I'm here referring to Gabriele Pastorini, who helped us to define what we are talking about. It's not just about taking part in decision making, it's about doing things together, because only about doing things together is the only way that you build trust between the government, the professionals, and the NGOs, so civil society. So, looking at this audience now where all the ministers left, and I don't think there are many representatives of countries either here, at least not of many countries, the usual suspects. I know almost all of you, and you know me too. I would say that what needs to be done next, there are a few things. One thing is getting more countries on board. I'm so happy to see that Kenya is with us now. Let's ensure that there are more countries from all regions with us, not only the usual suspects. That's one thing. I don't know how we are going to do this, but definitely I, in my role, I'm going to push for it in Europe, and the rest of you do it in other regions. That's super important. The other thing we need to do is generating evidence to demonstrate that this really does work. I see here among us also people that are representing institutions that do generate evidence. They come from different countries, from Canada, for example, Antoine seated there. There we have a lady who works worked with European Observatory for Health Systems and Policies. These are institutions that have to support us in generating evidence and proving to our governments, decision makers, that it's worth investing in social participation, that is even worth paying civil society to do the job for the country, because this is what is going on. And you have to know that it's difficult, even at the level of European Commission. We are going backwards. We are giving less money to civil society. We have to fight this. The third thing, I think it's super important, is that we start working together, and we are speaking of multilateralism in a different way. Today in this building, I heard, there will be a lot of meetings and youth representatives will meet here. I didn't even know. I noticed this is going to happen. I want to be there. So civil society, there's a job for you to be done. I want to take part in your events too. It's not just you taking part in the events of the governments, but please make sure that I'm there for you. Invite me, get me there, and the rest of us here. That's super important too. So, just to finish, what Slovenia is doing about to push more for social participation. We just opened, or it's about to be opened, a collaborating center of social participation of youth in Slovenia. We are going to support, first of all, of course, European region, but we are willing to support all of you. You should remember that Youth Health Organization started in Slovenia. So we do have capacities to work with all of you while being small and support you in youth participation. The other thing we have done was the meeting at New York last year. My president with President of Kenya seated there and promoting social participation as one of the ways forward with NCD resolution or declaration, So this is how we are trying to do it. My president did a good job, and I thank her for it. And also, what we need to do, we need to continue to have a strong core group of countries. And for this reason, first, I would like to thank Thailand, that was first offering a meeting in Thailand to see how they are doing it for the core group. Then I would like to thank Brazil, that organized the meeting. I was not attending, but a youth delegate attended from Slovenia in Brazil. And then I would also like to share with you that we are inviting core group to Slovenia in September to see how we are doing it. So
thank you, Vesna.
Can get larger.
Thank you.
Core group is core group, but it can get larger.
Thank you very much. Small is beautiful, small is powerful, small can become large. Thank you very much for sharing with us and inviting civil society to also invite governments to their gatherings. I want to thank all the panelists for a very rich and frank exchange. And I really want to share a lesson with you. When you are invited to moderate a session, you know you are going to be in trouble with the panelists, with the public, because you don't give them enough time for conversations, with the organizers, because they see that you have gone over time. So please forgive me, but it is difficult to moderate such an important topic with so passionate panelists. Thank you so much. I am going to open the floor for only 5 minutes. Please don't make statements. Just ask questions, short questions, to give them the opportunity to answer before we get into the final segment of this morning's. 2 here, that's enough. Anyone from here? 1. Thank you. Yes.
Sorry, Milka Sokolovic, the European Public Health Alliance. A very concrete question. Tomorrow at noon, at this very room, we will have a discussion organized by the WHO Civil Society Commission on the engagement strategy between the WHO and civil society. Who among you at the panel
You. That's
and
an important announcement.
will join?
A question there, please. Thank you. Thank you. You are all invited tomorrow.
Thank you. Hello, my name is Jakub Biller. I'm from Global Mental Health Action Network, Universal Health Coverage Working Group Co-Chair. And my question is that to all panelists, how do you think if universal health coverage, well, it needs to be universal. Well, what about those millions of excluded people who have no access to healthcare, who live in conflict zones especially? Because now we are facing huge number of severe conflict zones, including Sudan, Gaza, and other African countries, and Ukraine, of course.
Thank you. 4.6 billion people without access to basic health care. Who wants to take that question? How do we put the U to make it universal?
Buenos días. La pregunta también va a toda la mesa, que quien pueda contribuir. ¿Cómo podemos asociar la experiencia que es la participación social y la equidad, sobre todo en las diferencias étnicas existentes en los países?
A quick translation.
How can we make sure that we have true social participation, including those who are usually excluded in ethnical issues?
Final question, yes.
I don't know. Okay. I'm Silvana from the Brazilian Health Council. I'd like to ask if you have some experience on how to prevent that the social participation should be captured by private or business interests instead of the population health needs actually needs. Thank you.
Thank you. Final one. Please, quickly.
So in these turbulent times and the global health architecture reform, my question is, how do we make sure that the mechanisms like the WHO Youth Council and the Youth for Health Network don't break down with the lack of funding?
Thank you. I will start from Vesna and then move this direction. You answer one question each, the one you feel more comfortable with. Thank you.
Okay. Yeah, let's go through all the questions super fast. Ukraine, do you know, and other places, do you know that there are hundreds of NGOs already working there? The magic is that we make government support them. The magic is that WHO is enabled to support those NGOs. This is happening in our region in Ukraine. The WHO works with 200, I think, NGOs on the field, and they are trying to strengthen the health system while the war is going on. So there are ways. Equity is the essence of social participation. So what do we need to say here? We need to get people on board when they are organized. organized youth, organized patients, organized people in philanthropy, and so on. And that is ensuring equity, and I can prove it later in discussion. In my country, it does. And then how to reach those that are excluded. Health sector can actually not reach those that are excluded best if it doesn't work with NGOs in the community. That is how you do it. Social participation is an answer, but we have to institutionalize it. We have to support NGOs, pay them. And private business, I have to say something about private business also. If the government supports NGOs and also if it introduces criteria that they should not work with business who has vested interest, that is how you do it. You know, private business will always try to pay civil society.
Allow other people to contribute as well. Stephanie, please.
Thank you. So I will definitely be answering the youth question. Yeah, and I would say like the WHO Youth Council is a fantastic example of, you know, a youth kind of council that is engaging, you know, with WHO and across like other NGOs, international development partners. They have the model WHO, which actually like simulates the World Health Assembly. And one of the key outcomes of that like simulation is actually like a resolution that is under, you know, one of the priorities. And I think to answer your question and how they don't get left behind, how it doesn't, you know, fall apart. First of all, youth networks, youth movements, just youth programming, youth priorities should be prioritized in budget and funding, not as an afterthought, not after the, you know, decisions have been made, but it should be prioritized in the first place. And also to link to, I think, the question on like, you know, involving private sector, you know, we should be taking advantage of private, public-private partnerships and funding opportunities. I think we should be expanding our bases of funding and not just, you know, looking at our, I guess, traditional forms of funding and ensuring that youth are placed as a priority within those like funding.
Thank you, Stephanie. Natasha?
Thank you. So just to assure, of course, that as WHO, we are very careful with our processes also with business interests. But we do understand that at this point in time, we try to make a voice also for member states to support and international organizations to support civil society, whilst avoiding capture. This is always very much the line to tread. Second point, we need to make sure we don't create inequities also when consulting with civil society. And this many times also requires funding. So absolutely, this comes to the point, how do we make sure that when there are less funds to go around, civil society engagement does not become that optional extra? And this requires us to have a very strong and collective voice. And as WHO Euro, we have encouraged all member state delegations, for example, to involve a youth member in their delegation. So it's a tough and uphill 12 months ahead of us with the global health architecture. It's not just civil society, it's small member states, like the co-chair is I am, Vesna is from a smaller member state. Many constituencies can risk being left behind, but this is why also it requires us to be vigilant, active and smart.
Thank you. Thank you very much, Natasha. Priscilla?
Como ampliar o acesso equânime à saúde, ouvindo a sociedade civil e trabalhando com a necessidade das pessoas nos territórios. Precisamos levar a saúde onde vivem as pessoas.
So how to expand the access to health by listening to civil society, by listening to the needs of people. We need to take health services until those who need the most.
Isso somente é possível quando podemos escutar, avaliar, permitir que todas as pessoas participem das tomadas de decisões em saúde e, sobretudo, do direcionamento do financiamento para a saúde.
It is only possible by listening to those who need the most and allowing them to take part into the process of decision making and also the allocation of funds, how to decide how the funds will be allocated.
Porque a participação social, ela somente é efetiva quando podemos ter a sensibilidade de analisar as pessoas que representamos, analisar a necessidade da população que representamos e assim, com equidade, diminuir as dificuldades de acesso à saúde, fortalecendo a base da saúde que deve ser a atenção primária à saúde nos territórios onde vivem as pessoas, onde tem a necessidade diferenciada de cada uma das necessidades territoriais de onde vivemos, dos países onde vivemos, e a necessidade deve ser pautada onde estão as pessoas, segundo todas as suas especificidades e diferenças culturais, de territórios, de regiões.
Social participation can only be effective if we consult those that we are supposed to represent. Equity can only be reached by including those different needs and strengthening the base, which is basic care for the specific needs, taking into consideration differences in culture, in territory, and according to each country that we are talking about.
Porque participação social é cuidar do povo, é cuidar das pessoas e participação social é não deixar ninguém para trás.
Social participation means caring for people and not leaving anyone behind.
Thank you, Priscilla.
I'll just briefly address the question on. Sorry. Keeps happening. I'll just briefly address the question on preventing social participation being captured by private sector interests. So I think the thing to say on this is that generally civil societies have a very strict process of registration, which involves them having to declare to the Charities Commission who exactly is funding them. So it's very easy for governments when they're partnering with civil society to just check who the donors and funders are. And if it appears in those background checks that this is a organization that's being funded by a private sector company that is driving interest very hard, you don't have an obligation to work with them. But in a lot of instances, civil societies themselves also try to steer clear from private funds that are driving specific agendas that don't necessarily align with the health agenda. So I think it's a very easy problem to be able to vet and fix.
Thank you. Thank you, Ali. Thank you all for very inspiring and again down-to-earth conversations around how do we make social participation meaningful and contribute to achieving universal health coverage. Before I hand over the floor for the closing remarks, I just wanted to say that three things have stood out for me this morning. The first one is that social participation is not a technical detail. It's not a problem to be solved by a resolution, and it is a permanent institutional investment that requires legal protection, requires resources, and political will across election cycles. Secondly, the link between domestic legitimacy and international credibility is real. Countries that have built genuine participation mechanisms negotiate at the WHA from a position of democratic mandate coming from their people, from their communities, not just technical expertise. And the third is that the most important voices are still not in enough rooms. That is the implementation gap that resolution WHA 77.2 asks us all to close, but we will not close those gaps in Geneva. We are going to close those gaps in rural areas, in our communities, in countries like Guinea-Bissau where we don't speak English, where most people don't even understand Portuguese, which is the official language. And it is in those places that we need to bring people, not just to sit at the table, but to have a voice and to have a role. It is now my great pleasure to hand over back the floor to Fernanda Magano, the President of the National Health Council of Brazil, for her closing remarks before inviting you to stay over for an informal exchange, coffee, tea, etc. I thank you for your patience with me. Thank you.
Quero agradecer a todos, todas e todes presentes aqui por esse momento tão importante de marcar a resolução 77.2.
I'd like to thank you all, ladies and gentlemen, for being here, sharing this very important moment of this resolution 77.2.
Foi muito importante as falas aqui e o destaque que a participação se faz com o povo.
The contribution of everyone in the panel was crucial, and the fact that we were able to highlight that social participation comes through the people.
Com a juventude, com a luta pelas questões de acesso a medicamentos,
with the youth on our side, keeping fighting for better access to medication,
com a saúde mental. Sem saúde mental não se faz saúde.
and also including mental health. It is important to acknowledge that without mental health, we cannot fight for health in general.
E principalmente pela condição de darmos continuidade à implementação da resolução 77.2.
And above all, the condition of giving continuity to the implementation of this resolution 77.2.
A cooperação entre os países e o convite da Eslovênia nos anima à continuidade.
The cooperation amongst countries and the invitation of Slovenia gives us hope for this continuity.
Continuaremos as discussões no Corel Group e queremos agradecer esta Assembleia Nacional por esse evento paralelo, pela possibilidade de construção, de fato, de uma saúde equânime para todos.
We are going to continue with the discussions in our core group, and we would like to thank the Assembly for the organization of this side event so we can continue fighting for this important cause.
E convidamos a todos a estarem no próximo ano no Brasil para a nossa 18ª Conferência Nacional de Saúde.
We would also like to invite all of you to come to Brazil to join us next year for our 18th National Health Conference. Thank you.
Muito grato a todos. Queremos também convidar aqueles que puderem a permanecer aqui para uma atividade que dá continuidade a esse debate da participação da IAPO.
We would also like to invite those who have the possibility to stay with us this morning. We're going to have an activity that is very much related to social participation organized by IAPO.
E convidamos a todos para uma foto em conjunto.
And if you can please join me for a group photo.
Podemos deixar aqui, ó.
A bandeira tem que estar na. Você não vai ver.
You're gonna just, you have your script written there?
It's not a script.
I'm gonna have to read it from.
Can't even like see my face. I know. I was like, okay, this is also good for me. Doing the presentations as far as I know.
Yeah.
Fantastic. But will they be able to see them on their little screens here? Yeah. When your presentation's on the screen, for example,
Yeah, you can.
they'll be able to see it on here. It's all one deck. But are we okay? No, it's totally fine. Yep. Oh. You're gonna have to do that. Good morning. Hey, can I have the roving mic? Hi, everybody. Good morning. Come on in. I love a packed room. We are ready to get started. Welcome to our event, the Social Participation Village. The village is filling up. The village has had coffee, which is great. Thank you all for being here. We just had a packed room before this. That's 2 back-to-back sessions on social participation. So we're going to name it one of the most important topics of this World Health Assembly. It's great to see you all this morning. My name is Amy Baldasser-Bush. I'm a senior director at Management Sciences for Health, and I'm very proud to co-host the Civil Society Engagement Mechanism for UHC 2030. I hope many of you are already CSEM members, but if you don't know, we're the civil society constituency of the global UHC 2030 movement. And on behalf of our 1,700 members in 130 countries, welcome to our house, this civil society networking space, an initiative of our partnership with UHC 2030 to make sure that it's not only governments and private voices who have a place to gather and share their messages, but also civil society, communities, and patients' organizations. So we're here today for this session on the Social Participation Village, where every voice shapes health governance. I'd like to recognize our co-hosts, including, and you'll be hearing from many of them in a moment, our colleagues at IAPO, at Save the Children, the Global Health Council, the George Institute, where the Sphere Project is hosted. I'd like to thank all of you for your collaboration in building this village and bringing it together. The resolution on social participation, which is what sort of kicked off these conversations 2 years ago, was adopted by the Assembly, not by accident, due to the concerted advocacy of many of you in the room, pushing for the importance of communities, civil society, patients, people with lived experience, young people, peoples in all their diversities, in shaping the health systems that are meant to serve them. And since that resolution, we've kept up the push, the advocacy to ask for implementation and making those commitments real, not talking about participation that is, thank you, not talking about participation just in name, but deep engagement in shaping health systems, and this week in shaping the global health architecture reforms and financing. This year is the first year that WHO has had to report on the implementation of the social participation resolution, and so you'll be hearing about that today as well. We're also going to be sharing some resources with you if you feel excited to join us in this advocacy. We at the CSEM have a social participation advocacy toolkit, and our colleagues at IAPO have a wide range of tools that you can use. At the end of the session, for saving paper, we'll provide you with QR codes that you can scan so that you can take those messages and tools with you going forward. So to get us started on the conversation about the village, I'm really pleased to introduce my partner, Danny, who is the CEO of the International Alliance for Patients Organizations. Neither of us are standing at the podium because we're too short. Stand over here. You literally can't see us. We want to make social participation visible today. So please join me in welcoming Danny and thanking you for your partnership.
Thank you so much. Is this working? Can you hear me well? So it's a huge, huge pleasure to be here with CSEM, but also our other co-hosts, because this is a moment where we want to bring more voices for the discussion. There is a whole reason behind the social participation village. And IAPO is very committed to this agenda because we are an alliance of patient organizations and we represent people with lived experience and patients who are living with conditions, and we work across all disease areas and regions of the world. And why a social participation village? We believe that health, it's something that it's so complex that we need an entire village to address what we need to build as a health system, and a health system that truly serves the people that they treat. And when we talk about a village, we also want to bring a space where we can share our views, and it's a space where we trust and acknowledge these different views and different perspectives. But more importantly, we think about how we can act upon it. So it's about learning, but also let's take it to another level and act upon it. We had a session just before this one talking about we need to generate evidence. Civil society, let's first give visibility to what's happening on the ground. Let's support this agenda as much as we can. We have been doing this for a long time. We have a lot to share, and let's partner with the right partners to turn this into evidence and turn this into a way of holding our governments accountable to advance social participation in our countries. The idea here today is to, with this brilliant set of speakers, to set the scene and put you up to speed with where we are at the moment with social participation, what has happened, what we learned so far, and we'll have different perspectives here.
Recording in progress.
And then we'll have a moment where we'll have a discussion facilitated for us to address a few questions that we'll put forward for you to reflect upon. So now moving to the moment where we would like to share with you where we are with social participation. I'm very happy to be here with these four brilliant speakers because they have been working with social participation from the beginning. They are here not only because they are now working with it, but if it's this agenda has advanced so far that long, it's because of these people. And there is another other people as well, but I really would like to acknowledge this. So let's start with the perspective of member states and a representative of the core group who puts the resolution forward in 2024. And I would like to invite Nanut Mathurapot. She's worked for the National Health Commission Office in Thailand, and she'll share Thailand's work so far in this agenda.
Oh, thank you very much. And good morning, everyone. It is wonderful to be here among like-minded friends and colleagues who believe in the importance of social participation. And first of all, I would like to sincerely thank IAPO, CSEM, the George Institute for Global Health, Sphere, and Global Health Council, and Save the Children for inviting me to attend this meeting. Today, I come with two hats, one as a representative of Thailand and the other as part of the core group on social participation. The core group is made up of 6 member states, Brazil, France, Norway, Slovenia, Thailand, and Tunisia. I hope that we can have a slide on. Together with civil society partners, including CSEM, UHC 2030, and WHO Civil Society Commission, and the WHO Youth Council, and of course, the WHO itself. The group was formed after the adoption of the WHO resolution on social participation. But in reality, many of us already been working together long before the resolution, advocating, negotiating, exchanging ideas, and sometimes struggling together to bring this agenda to World Health Assembly. And honestly, after the resolution passed, we all realized that adoption is not the finish line, it's just the beginning. So the core group continues working through 3 things: advocacy, knowledge exchange, and collaboration with partners to prove social participation is benefit to health policies, governance, and health sovereignty. One good example was the side event hosted by Brazil early on, the central role of social participation and multilateral cooperation in advancing health sovereignty. The event brought together 2 health ministers from Brazil and Tunisia, representatives of stakeholders from WHO member states, including Slovenia and Thailand, civil society organizations, youth representatives, and many partners. What I found powerful was not only who attended, but the shared understanding that social participation becomes central to how we govern health. So let me leave with you with 2 key takeaway messages from the discussion. The first message is that health sovereignty is legitimated by social participation. Health sovereignty is about ability of countries to define and govern health priorities based on their own context, values, and people's needs. And this is exactly where social participation matters. And because when policy are shaped together with people, especially vulnerable and marginalized groups, governments gain legitimacy, trust, and strong public ownership of health decisions. And the second takeaway is this: sovereignty and multilateralism reinforce one another. Sometimes people think national sovereignty and multilateral cooperation are in tension with each other, but actually they reinforce one another. When governments meaningfully listen to the people. National priorities become clearer and more legitimate. And when countries come to global platforms, with that legitimacy, multilateral cooperation becomes more meaningful, grounded, and sustainable. In other words, strong global collaboration starts with strong participation at home. Thank you very much.
Thank you, Nanut. And I couldn't agree more how much collaboration is and it's a core issue with regards to member states and how you can learn from each other. But also, I think what Gabriele will bring now to the table and the work that the WHO is doing to guide member states, but also understand what they are doing and being there to share with the others. So, Gabriele, I'd love for you to talk a little bit about the work of the WHO so far.
Thank you very much. And I would also like to start by really thanking the civil society organization that organized this side event, really for the leadership, because it takes a lot of effort from everyone to move this agenda forward. And this discussion is important. And thank you for keeping pushing for that. So I have a couple of slides, which let's see if it's going to work now. Yes, it does. So I won't take much time, but basically I just would like to give a little bit of an update of where we are, because actually this year, actually on Friday, we're hitting one milestone. It's the first interim report on the implementation of the resolution that is officially presented as part of the Director General report to the World Health Assembly. So on Friday, under agenda item number 22, the report on the implementation of the WHA resolution on social participation will be presented to member states, and a discussion will follow. So important moment. It's not working. Can I have the next slide? Thank you so much. So as you know, the resolution have two operational paragraphs. One actually asking, committing member states on a number of action, and another one committing WHO to deliver a number of action. So the report that is going to present on Friday is actually covering this second part. So it's about what WHO has been delivering. And as you know, the commitment as part of the resolution is really around documenting and capturing best practices in countries, keeping the global advocacy, producing new guidances and tools, and coordinating and supporting this report progress. And of course, also training member states on best practices. Next slide, please. I mean, I don't have to repeat why social participation in health really matters, but we know that it's really central to achieving our path towards universal health coverage. It's core to a well-functioning PHC system and PH Pro for health system. And we heard again this morning, we cannot really foster trust, inclusiveness, and health system resiliency if we don't have participatory governance at the center of how the health system functions. So there are many reasons why this agenda is more important than ever. And if we can move to the next slide, I would like to share really a little bit of what has been happening in the last 2 years. So first and foremost, you all know that the implementation of this resolution unfortunately started through a very turbulent times for global health. We are seeing, and this is also mentioned in the report of the DG, shrinking civic space, of course, deep cuts in ordinary development assistance, and many health systems, particularly in low and middle income countries, really being under severe pressure. This constitutes a challenge but an opportunity as well, because we also know that there is a growing demand for more legitimate decision from governments, more trust and people-centered governance. And I think what we heard this morning from Brazil and Tunisia are really two striking examples of what this means in practice. So it's a challenge, but there is also an opportunity, because we know that many of these systems, because of all these challenges, need transformation. We talk about health sovereignty this morning. Countries want to take more ownership of their own health system. They are allocating more national core resources to that. And it's a time of shift where actually to guide these reforms and make them more legitimate, social participation really can play a core role. As I just mentioned, the political milestone of this year is this initial report, which has limitations because it's a very short report. It's only 600 words. It really captures high level what has been done. But because of that, our friends and colleagues have been stepping in as part of the core group with CSEM and others taking really the leadership as pen holder for an additional reporting that really try to capture better the nuances and the richness of what has been done at country level, both in member states, but also led by civil society. And the last point I wanted to touch upon is the work that we in WHO are doing to try to build this global architecture. I would say that the center of the solution of many of these problems is partnership, partnership, partnership. So we always wanted to work in partnership, but now it's more important than ever because we can't really progress without that. And part of this effort, beyond working within the core group, the member states and civil society organization, is also establishing collaborating centers that are going to support WHO work in this area. The director for health system of the European region, Natasha Zopardi-Muscat, mentioned early this morning that the first collaborating center on social participation has been established in the European region at the National Health Institute of Austria. We have launched last week another collaborating center based in Norway, which is actually for the well-being economy, but they have a commitment to work on social participation as well. And we are currently starting the establishment of a third collaborating center led by Thailand with the National Health Commission Office. So things are moving, but we need more to join this journey. If we can move to the next and last slide. So you will hear on Friday, as part of the report to WHA, the first interim report. It really talks about what we have been doing in terms of expanding the coalition, because as you know, the core group actually started including civil society organization 2 years ago. After WHA, we got the WHO Civil Society Commission on board, CSEM and UHC-related force, and then the WHO Youth Council. So civil society is core part of the implementation. And it's important to say that we have been working across the house to really embed social participation in technical WHO work stream. So you will have seen, as mentioned in the report, a number of publications on primary healthcare in many disease programs, urban governance, health planning. We're really trying to capture this because we know it's a cross-cutting team. It's not something that should be a standalone. It's something that has to be integrated in the entire policy cycle and in different technical work stream of WHO. A lot of country-level momentum and exchange. The Thailand, Brazil, and Slovenia exchanges have been mentioned this morning. This is really important because it's where country meet and actually show how they do it for real on the ground. And this is really important, something that WHO is very happy to facilitate. And of course, scaling knowledge, tools, and capacity. We have held already 2 of our global webinars, reaching over 86 countries. And we have released the first 3 modules of the WHO Academy e-course on social participation. So things are progressing, maybe more slowly than we would have liked, but things are progressing. And mostly, very importantly, in terms of strengthening measurement and accountability, we have a dedicated GPW14 indicators in WHO, and we have also included in global survey metrics like the PHC surveys that our department regularly does. It features some questions on social participation. So we're really trying to embed it in our core work. And I stop here, probably already taken too much time, but this is a bit of an overview of what has been done so far. Thank you.
Thank you, Gabriele. And I really wanted to acknowledge how much work Gabriele has been doing. The context within his team has changed dramatically, and he's been really holding the fort in a very difficult situation. So I really wanted to acknowledge and continue to support you as much as possible, Gabriele. And I loved what you said about the importance of member states visiting other work on social participation, because that just reinforces how lived experience is important, how how a country delivers social participation and use social participation in their country really helps others to learn. And with regards to the report that has been is being developed by civil society. I now would like to invite Waiswa Nawanga. He's from CSEM, and he's going to share the preliminary results of a survey that was put together to help us develop this report.
Thanks, Danny. So social participation is a very simple concept, and yet it's also quite challenging sometimes to get for people to get their heads around. And for those of you who were here earlier, you've heard quite a bit about it. But yesterday I was chatting with an advocate, and they were asking me about what this really is and what's this resolution. So in the next few slides, we will walk you through some of the basics. Let's start from the basics so that we're all starting from the same place, and then get into share with you some of the findings that we, preliminary findings that we have prepared from our civil society-led global multi-stakeholder survey that we did earlier this year. And that survey definitely was meant to really complement what Gabrielle has been sharing about the WHO reporting this week. So let's kick off, next slide, please, with so basics. So in 2024, member states adopted the resolution on social participation for universal coverage, health, and well-being. And they defined it as empowering people, communities, and civil society to participate meaningfully in decision-making processes that affect health across policy cycles and at all levels of the system. And at the core of that is placing social participation as a core function of the health system. And the resolution draws on previous commitments from ATA and also the Astana declarations on primary health care, and goes beyond that by basically mandating countries' governments to not just institutionalize, but also finance and report on progress in practice. And right now, as we're here, we realize that this is a very important moment, in part because this marks the first cycle of reporting, but also because we are looking toward next year, the high-level meeting on universal coverage that will also set the agenda for 2030 and after. And so really critical moment for us to build on the discussions today, but also on the materials that we have put together as CSEM, as other partners, to make sure that we amplify these voices across our engagements, to make sure that we push countries to go from making commitments to actually implementing social participation. Next slide. As we're saying that WHO is putting together the first report, it's been 2 years, and looking at the role of WHO in driving this agenda forward. So we, civil society and CSEM and partners, thought that it would be helpful to also try to assess what is happening in the countries to complement this reporting. And so we quickly put together a global survey earlier this year in March that we disseminated widely to try to capture what the progress on implementation has been or is happening right now. And we used the analytical framework that draws upon the 7 commitments that are in the resolution for member states, not WHO. We only looked at the member state commitment areas. And we received quite a bit of responses, especially considering the very tight timeline we had. We received about 138 responses from across different regions. And we also reviewed other resources to make sure that we're capturing as much as we can. So we looked at the UHC 2030 report and dashboard, where you can actually look at what countries, specific countries, and what they're doing on social participation. We looked at data from the high-level political forum, reporting from last year. And we also looked at some of our selected peer-reviewed sources to try to tease out what's happening in the countries, but also what are those lessons that we can take with us. And next slide. So in the next couple of slides, I'm going to walk you through what we heard from some of you here, but also others that are not here, about what they're seeing, what they're observing at a country level in their regions. And this also went beyond civil society. We also had member states feed into this survey. We had other stakeholders also feed into this survey. And what did we hear? What we heard was that, and again, these are the commitment areas. So on public sector capacity design and to design and implement social participation, and also on enabling equitable, diverse, and inclusive participation, we heard that the public sector capacity to design and sustain participation remains weak in many settings, and that this is limiting effective implementation, even in places where participation formally, they have formal structures for participation. We also heard that participation is often project-based and also tokenistic. And we heard about this also earlier in the first session here, and the need for us to really push for meaningful engagement. And we heard that the mechanisms intended to enable inclusive participation are limited and inconsistently applied in practice. So, again, we are giving you top-line messages, but we will have a resource where you can go and read more about the preliminary findings. And then on next slide, on influence of participation on decision making and also institutionalization through policy and law, participants reported that participation is predominantly consultative with limited influence on the final decisions, and that communities and civil society actors are invited to provide input, but have little or no influence in terms of influencing policy priorities, budget allocations, or implementation decisions. We also heard that from several participants that participating structures lack effectiveness and authority. Next slide. On financing of social participation and capacity of civil society to participate, we heard that there's a lack of dedicated financing for participation. And obviously, this creates a lot of other problems downstream. 80%, approximately 80% of those who responded reported no or minimal government funding for social participation. And they also reported that consistently that the ability to participate meaningfully and consistently is widely constrained by limited institutional support, unpaid labor, and lack of predictable resourcing. And so, as you can see, this is not a sustainable situation that we're dealing with. And then next slide, on monitoring and evaluation and learning, it was very clear across the board that there's weak monitoring, and this really limits learning and transparency and accountability. And so there you have it. We are not doing great on implementation, but that's not to mean that there's nothing that's being done, because this is preliminary look at this. It's been only 2 years. Also, this is depending on this on a very short or small group of participants, but really gives us some insights into what's happening or not happening in terms of implementation of the commitments. So, I would like to leave with you with some very specific things that we want to see this assembly and member states do this week and beyond. And one is to really, if we can have this assembly help us to get member states to commit to meaningful participation for civil society and to ensure that they really have influence, not just checking the box. Will be great for us to reiterate that throughout this week, and also to ask the Assembly, really to frame institutionalization of social participation as a governance reform that requires formal mandates and continuity across the political cycles, and also integration into the health structures, rather than as a series of pilot projects that and activities that sometimes we see. We would hope that you can also get the message about really reinforcing the need to reinforce inclusion as a minimum standard to promote accessibility, representation, and also safe spaces, and also for member states to commit to the dedicated allocation of resources to support civil society and community engagement. And lastly, let's try to get the Assembly to really support integration of social participation indicators into UHC and health system monitoring aligned with WHO reporting. As we mentioned before, we have some resources that would like everybody here to help us amplify throughout the week and beyond. Thank you.
Thank you, Wazla. And just to reinforce, this research will continue. We'll talk more about this at the ending, but we'll invite you to fill in the survey and share it as widely as possible so we can capture more. And of course, a lot of what we heard today is about the gaps and the challenges that we are facing, but I'm happy to invite Nina Joshi from the George Institute for Global Health, who also talk about some learnings and how evidence is showing good practice as well. And over to you, Josh.
Thank you. Can everyone hear me? Perfect. So I just want to start by saying thank you so much for having me here today. I feel so lucky to stand between two of my Sphere colleagues. So it really shows that all of us are working together to advance social participation for health. So as mentioned, oh, can I have the next slide? Oh, I don't know if I did that or if you did that. Okay. So as mentioned, I'm Nina Joshi, and I'm the Senior Project Manager of the Social Participation for Health Engagement, Research, and Empowerment Consortium, or SPHERE, at the George Institute for Global Health. And today I'm going to speak a bit about a model of collaboration that we have used and we're trying to understand and to see if does it actually advance social participation for UHC? So we're in the crux of conducting the evaluation on this, and as we start to see some emerging findings, we're happy to share them with you today. So for some background, could I have the next slide? SPHERE is a multi-country collaboration model of country-level CSOs and research institutions, as well as global-level diplomacy and research institutions who are all committed to advancing UHC or SPH for UHC. From 2022 to 2026, SPHERE has brought together CSOs and research institutes in Argentina, Kenya, and Vietnam, along with CSEM, UHC 2030, the WHO, and the George Institute for Global Health, where the Secretariat is anchored. And all of us are working together to advance SPH. Okay, here it is. So the way that SPHERE has worked and the collaboration model that we've used, and as you mentioned in your talking points, there's a lot of collaboration going on and a lot of institutes are being created, but what what does that look like, right? And how are we actually going to advance SPH? And what we adopted is an academic practitioner interface. And what this means and why we chose this is we wanted to leverage the expertise of each partner and advance the group's mutual interests. And as you probably have gotten by now, the mutual interest is to advance social participation for health. And what that means is that global diplomacy actors were really focused on shaping the agenda of Sphere and facilitating institutional uptake. Our civil society organizations were focused on leading community engagement and focusing on advocacy efforts. And then last but not least, the academic and research institutions were very much focused on generating rigorous evidence. So now that we're coming to the end of the project, what we're trying to see is, was Sphere and this model of collaboration able to do this? Were we able to, in some way, advance the documentation of social participation for health? So to conduct this evaluation, we used a narrative evaluation approach. And we chose this specific methodology because it mirrors the Sphere collaboration model. It emphasizes co-production, it's highly reflective, and it's context specific. So I'm not going to spend too much time here, but I do want to briefly go over the different ways that we collected the data and then what the evaluation results are going to look like. So we revisited the theories of change frameworks that each country partner created at the beginning of Sphere through a workshop, and we worked through what actually happened, what were they able to do, and what changed given the socio-political context that they work in. We also conducted 15 key informant interviews with most people involved in the Sphere project. And then we invited reflections and learnings from not only the country partners, but everyone involved in the project. And this was done over a series of workshops over the last 6 months. From these 3 data collection processes, we're going to result in kind of 2 forms of findings. So the Sphere evaluation is going to result in credible stories of participants' lived experiences, as well as priority good practices that fit for diverse contexts, which actually advance social participation for UHC. So getting into some of our emerging insights. At the global level, so in the 3 countries that we're working in, our emerging insights are revealing that the Sphere model of collaboration, so this academic practitioner collaboration, reshaped actors' view of social participation for health, of UHC, and the role of research in advancing social participation for health. We're observing that Sphere facilitated the introduction of WHO's definition of social participation in UHC, to country-level partners, and also supported their use of the WHO Handbook on Social Participation for UHC and the Civil Society Advocacy Toolkit on SPH. We're also seeing that Sphere created linkages between global diplomacy and country advocacy. And last but not least, we're seeing that Sphere innovated modes of collaboration between advocacy and research activities, specifically adapting research methodologies to reflect and document social participation for health. Next slide. Thank you. So here, I just wanted to share 2 quotes from some of our interviews. These quotes are from 2 different participants. And here in the first one, the quote reads, "Previously, when we talk about participation, some staff would think, oh, participation is inviting the community people. Some of them think that participation means that you engage them in all steps of the project. And some of them think that we engage them in the policy process only. But I think we now have the same understanding about social participation." And I'm sharing this quote with you today because along with the introduction of WHO's definitions of SPH and UHC, we're also observing that Sphere and the collaboration between global diplomacy, institutions, and country partners may have had a broader organizational impact. And the second quote here is from a different participant who states, "I usually hate focus groups. But Witness Seminar flipped around the project. This change in the perspective where everyone has to present their voice, everyone sitting will tell you what they feel, And we're not going to confront, we're not going to see who's right, who's not. We're just going to hear everyone. It was really a change of perspective and an opportunity to understand a complex concept. And I'm sharing this quote because I think it does a beautiful job of exemplifying how the sphere model of collaboration, which connected researchers across countries and research institutes across countries, not only introduced methodologies to document social participation for health, but it's also reshaping participants' perceptions. Next slide. Thank you. And I wanted to also share some key insights from each of the Sphere country partners. So in Kenya, through the Sphere collaboration, the collaboration between global diplomacy actors, the CSO partner, and the country level research institute contributed to the CSO's partners' engagement with the National Public Participation Bill discourse. Here, a participant from Kenya said, originally, we looked at health forecast bills like maternal health and immunization, but public participation is cross-cutting. If we had not been doing this Sphere project, we may not have thought to push for public participation. Because we were in the throes of looking at the research findings and seeing that community awareness is lacking, we said, how do they get involved? For me, I can relate Hennet's engagement with the bill directly to the Sphere project. Next slide, please. Thank you. In Vietnam, we are seeing that collaboration with a country-level research institute enabled the CSO to become a research-grounded advocacy partner within health governance spaces. Here, one of our Vietnamese colleagues states, we, as in the CSO collaborator, carry out our own research, but sometimes our data was denied by the policymaker because of lacking the appropriate methodology. Some government agencies or policymakers will deny using our data because they say we made the data for policy advocacy, because no one checked it and it does not follow a professional methodology. They go on to say, from there, as in the social or the policymaker's perspective, the evidence or the voice from the university seems neutral. You can have the next slide. Thank you. And lastly, in Argentina, collaboration among country-level research institute, a CSO, and local community groups facilitated communities' assertion of ownership over their data, claiming power in their relationship with CSOs. Here we have a quote from one of our participants in Argentina, which reads, when the situation was getting very difficult with police violence in Argentina, a demand came from Ada and Amar saying, can you please put in a report everything we have on violence and health? Because we've been talking about advocacy, how to get advocacy, and what advocacy is for, it actually made the click. When we prepared that report, it was beyond what we had been doing with Sphere. It was a recollection of everything that we had done. There's something about Sphere that is materializing things. Could I have the next slide? Thank you. So in summary, what we're seeing from the Sphere model of collaboration, which is an academic practitioner interface, is that first, global advocacy exposure helps shape local advocacy and policy influence, that co-production strengthens evidence legitimacy and uptake, and that through academic practitioner interface or collaboration, communities become active agents in evidence and advocacy. We also saw or are seeing that academic practitioner collaboration drives conceptual alignment and policy coherence. Next slide, please. So with that, I want to say thank you. Thank you for your attention. I also want to take a moment to thank the Sphere team, some of whom are in this photo when we were all in India in March playing Holi, and also the Sphere evaluation team who has been instrumental in making sure these results, our emerging insights, were ready for you today. Without their guidance, leadership, and expertise, I wouldn't be up here today. So thank you.
Thank you, Nina. And I hope with these interventions now you have an overview of where we are with social participation, what each stakeholder group has been doing and can do, and inspired you for the next section of our event, where we'll now have a facilitated conversation about how we can take this forward, what is happening around the world, what each one of us is doing, but also are there any opportunities for us to work together, to collaborate, and to advance this agenda further. And to do this brilliantly, I would like to invite, well, before, I would like to thank you so much for the speakers in the panel. And I would now like to invite you to join everyone in the arena that we are going to start. And to facilitate the discussions, I would like to invite Ravi Ram. He's from MedWise Solutions, but also he's the co-chair of the WHO Civil Society Commission. And he will make this conversation very lively. Thank you, Ravi.
Can you hear me?
No, but
let's first give a round of applause to Danny Nanut.
All right. We're going to get started with an interactive session. This is where we really become a village. So to get ourselves set up, we have a little bit of work to do. I want you to stand up and take your chair and just rotate it so that we all face the center aisle. We see each other. This is looking very good. And while we're getting organized this way, we're going to keep 4 chairs in the middle, and we'll keep them empty at the moment. And it's an invitation to others to come and join, for all of us to come and join. I think we're largely organized this way, and I'd like you to stand up again, not just yet, for those of us who bring lived experience to the room, patient groups, working with others, caregivers, health workers. Let's stand up if you feel you fall into any of those categories, any of these people. Anyone with lived experience that they bring to social participation. If you have working with patients, you are a patient, you're a caregiver, you're a health worker. Let's see you. So we have a good number that way. Thanks very much. I want to see the diversity in the group. Can you hear me okay? Okay, good. I'd also like to just recognize that we have Nanut with us, representing a government perspective. We had Brazil in this meeting this morning. If you represent government, policymakers, decision makers from the national authorities, please do stand up because we want those perspectives coming as well. Good. No. We're happy to have you here, so don't hide. Okay, so we do have a few voices. We're going to look to you. Who is here from the advocacy perspective? And you may overlap. Working in advocacy, working to bring the large number of people. Good. Very good. And others of us in civil society, maybe working in research. We heard from Nina, yes, working on evidence, working on bringing points forward. Very nice. And then can I ask those of you who have not yet stood up, stand up and just yell out, who are you? No, yes. No. If you've not yet stood up, stand up now, please. Yeah. Okay. There we go. Yes. Thank you very much. And Gabriella, do you want to stand up and with with Ida? Yes. Okay, good. What we're seeing and hearing is that we have a large number of people from different parts. And can we turn to Laura also? I think we're hearing a little bit from those who are online, right?
Can you hear me now? Yes, just to make sure when you take the front stage to also speak in the mic, we have over 65 participants online who are also participating in the chat. So yeah, make sure it's inclusive until the end.
Thank you very much, Laura. Now, what we want to do is to get perspectives out. And as Danny introduced the session for us, we know that there are several different pieces. We want to hear actually what's happening, right? A little bit of feedback about I tried social participation or I was part of it, and here's what worked, here's what didn't, right? And then we'll move on to a few other questions looking at who's actually participating, what's being left out, and then we'll try to conclude by what do we do next? And I think some of the points that came up, Nina was giving us some very critical feedback from the survey that Sphere has conducted. So are we together? Any questions? Suggestions from the group? What do you want to hear? Disculpe, yo no hablo portugués, pero hay muchas personas que pueden sí. ¿Estamos juntos? Sí. Okay, so let's get started. A few people, let's hear from you if you have experience in working in social participation in your home context. Something that you've seen, I'd like you to come and take 3 of the 4 chairs here. ¿Sí? Siéntate.
Hello.
Okay, yes. So let's hear from our people here. Now the structure here is that we have 4 chairs. We have 3 people seated. As you hear what they're saying, thoughts may come to your mind. It may trigger something. Let's have you come up and take the 4th chair. And when one of the speakers is done, they will go back and sit down. So we're always rotating and we're hearing from different people. We should be in motion. We're a very active group here. All right? So let's hear from our first speaker.
I'm just going to translate.
Of course.
Tá. Uma experiência de participação social só acontece com conquista de democracia e soberania nacional, no diálogo multilateral das agências e das instituições de saúde.
A social participation experience only happens when we have multilateral cooperation, health sovereignty, and collaboration between health agencies. And democracy, of course.
Okay, thank you. Yes. All right, let's pass the microphone to the next person.
Hello. I'm Antoine. I'm from Canada. I was super struck by all the presentation. My experience from Canada of social participation resonates very much with the findings of the survey that has been done by CSEM. What strikes me also right now, 2 years after the adoption of the resolution, is that WHO is accountable to member state, but member states are not accountable to each other and to their people. I think we need to hear these voices very much, to bring them back. I was also struck by us talking about bringing people at the table. I think we need to talk about tables. There's many, many tables, and we need to multiply these tables. The third thing that struck me is the role of research for creating new tables. Stable tables where we can bring different perspectives of people who don't necessarily work together already and who can align their powers actually for change. And I think that's an important contribution of research moving forward. So thank you very much for the presentations today.
All right, thanks very much. We've heard from a brother from Canada, a sister from Brazil, I believe, right? Let's have more voices coming up. We do have empty chairs. And I very much encourage those online, please do type in the chat. We're looking for your perspectives as well. Let's turn to Sarah.
Hello, I'm Sarah. I would like to share an experience we had in Madagascar in a project that I supported. So it's right, you need to have the right people around the table, but you also need to make sure that these people are actually empowered and have the right capacity and understanding to meaningfully engage and contribute. So this is something we learn very strongly with the processes we try to support it there. So it means that people need to have the capacity to speak the same languages. I mean, really speaking the same languages in practice, but also being able to understand each other and to respect each other. It also brings to my mind the fact that this social participation needs to be in what we can call a safe space, because you are bringing around the table people that can have different hierarchical level, that can feel pressurized because they have this and this authority around the table and they are accountable to them or feeling under pressure. And this is also something that should be addressed in practice when the social participation mechanism or process is thought through. This is a very practical issue, but this is actually the main barrier we encountered in the project we supported. And I think it's also something that should be thought through at the beginning of the reflection, and that should be institutionalized, etc., etc. Thank you.
Thank you very much, Sarah. We do have a comment online. I'm encouraging people to come up and sit in the chairs. We're hearing a lot. The conditions. Our sister from Brazil talked about what's required to make social participation happen. We're hearing about accountability, multiple tables and fora. Let's turn to Ritu, and then I'm going to turn to Laura to hear from our people online.
Thank you. I'm from Singapore, and I hope we're not going to be quoted on what we say here. I think social participation works well in regions, in countries where people feel safe to speak, where they know that participation or intention will not translate to censure. And I looked at the numbers that were shared in the report. My region, Western Pacific, has 2% of the total respondents come from Western Pacific, which has close to 2 billion population in a global population of about 8 billion people. It's 25% and 2% representation. I mean, not a response, not representation. This is perhaps the region where in many countries social participation is not encouraged. And that to me is telling that we need to put in effort, no matter how difficult, in creating safe spaces, in creating, what did you say, stable tables, Antoine, where people feel safe to participate. And fortunately, I also come from a university. I work in a university, and I feel that's a great space that cuts across and enables a safer space, a neutral space, which also was shared in the report, that we need more of these spaces. So perhaps that's some food for thought here. Thank you.
Thank you very much, Ritu. At this point, I want to hear from our people online. Laura from CSEM is going to read out one of the comments that's come out.
I'll pick your mic for a second. Yes, we have a strong participation online too, and great comment from several people online. Apologies if I'm mispronouncing any names here. We have Nadia Latif, who wanted to highlight that it just not build a new, be at the table, but build a new seat at the table for civil society, and highlight the need for intergenerational participation and voice. And she was rightly highlight that children and adolescents and older people are facing the same issue in terms of, or similar issue in terms of regimes. And she is working specifically to ensure that people are not discriminated based on their age. We had other comments. Sorry, I'm going to pause my computer over here to read it too. Thank you. Other comment from different region, great comment from the setup and people who would have wished to be here today with us. We have comment from Malaysia, also on exclusion of people living with rare disease and the importance to make sure that this is comprehensive to everyone, and how do we make sure that we include everyone and make UHC and social participation while not excluding also a specific disease area in the process. Good, and we have also a comment about the question online here, about the question featured, and a particular interest about hearing more about the biggest challenge to make social participation a reality in the different contexts, and your advice in your advice to ensure social participation. So one challenge and an advice. Thank you.
Thank you, Laura, and thanks to those online. Very much appreciating your contributions. And let's keep in mind, we're not just having a one-time session. The questions we're talking about, the ideas that are coming forward, are very much linked to the survey that was conducted. Nina's presented the interim results, and we want to take it forward. So we'll get there. We've got several people in the middle of the room. Let's hear from you next.
Yeah. I'm Fernanda from Brazil, but I work with international organizations around the world. And what I've been learning is that if we are not seated around the table, we are going to be in the menu. Mm-hmm. And I think we don't want to be in the menu. And what I think is missing is more young people discussing with us. It was nice to hear from the online participation, because we are always putting the hope on young people, but we are putting a lot of pressure on their shoulders as well. And how could be more easy for them to do the changes that we are looking forward. And also we are talking about democracy that she mentioned, and the political will is not from people that there is nothing to be with us because we vote for them. So the political will comes from us, not from other person that there is nothing to do with our decision.
Great, thank you.
Thank you. This is Valentina from Humanity and Inclusion and World Rehabilitation Alliance. I really appreciated some comments regarding the conditions that need to be in place to have social participation. And I would add there that it's even more than conditions. It's really about also intentional measures to make it happen. And I'm thinking in particular about the participation of specific groups, including persons with disabilities, where often spaces that are created to facilitate social participation don't take into account specific barriers, whether they relate to stigma and discrimination, or also barriers that relate to communication, physical accessibilities, access to information. And that's true that this requires extra steps, intentional steps that need to be made, and organizations of persons with disabilities can be there as allies when social participation processes are in place to advise which are the actions that need to be taken to include persons with disabilities in the conversation. Thank you.
Hi, my name is Nicola Bedlington and I'm working with patient organisations at European and at global level. And I just wanted to give you a quick example of where social participation worked well in a European context, but where there's some significant unfinished business as well. So we're looking at the cardiovascular health space as a great alliance of organisations working on cardiovascular health, and they pushed very heavily at European level for a European-wide, robust plan on cardiovascular health. And the voice of people with lived experience was absolutely vital in encouraging a positive decision. So the EU institutions said, yes, we now have a great plan, the Safe Hearts plan, but unfortunately two problems persist. The first problem is there is not a sufficient budget to fund an ambitious plan that will actually look at reducing mortality by 30% in the context of cardiovascular diseases, but no funding for civil society to play a meaningful role. That's the first big problem that we need to overcome. And the second big problem is that there's no people with lived experience representation from civil society in the governance of the plan moving forward. It is governments, it is researchers, it's officials, but the voice of civil society is not there. And we've seen this before. A previous European plan on beating cancer had exactly the same problem at the beginning. Civil society in the cancer field fought hard, fought strongly and won, and they were in fact part of the governance. People with lived experience also part of the governance, and that has resulted in a very, very effective plan with real impact on the ground that actually responds to the needs and goals of people with lived experience, people living with cancer and their communities. So that's a really, I think, interesting example at European level of getting so far, so well, and then still having problems and challenges to overcome. And while I still have the micro, I just wanted to do a big plug for the fantastic work that IAPO has been doing and some of the resources and tools that they are co-creating with communities across the globe. And on the theme of leaving nobody behind, really checking in with communities that are perhaps most left behind to make sure that those tools are fit for purpose. So those will be shared after the meeting, I understand, and certainly they are very, very applicable in a European context and elsewhere. Thank you.
Yeah, thanks, Nicola. And it's worth noting there will be QR codes that come around so you can download documents, you can carry material with you as you go back home. All right, let's hear from our next speaker.
Bom dia. Vou falar em português porque eu não falo inglês, mas Nath está aqui. Bom, eu sou Janaína, sou secretária executiva do Conselho Nacional de Saúde do Brasil, né?
Good morning, everyone. She didn't speak English, but I'm here to translate for her. She's Janaína Salles, the Executive Secretary of the National Health Council of Brazil.
Bom, a experiência que eu queria trazer aqui é uma experiência de participação social relacionada à incidência política e de atuação na formulação das políticas públicas de saúde do Brasil e na implementação das políticas.
The social participation experience I would like to share here today is on the incidence, political and action incidence of the social participation in the public health policies in Brazil.
No Brasil, nós tivemos já há 2 conferências uma experiência importante, que é a formulação de propostas na área da saúde a partir da comunidade, e não após a formulação pelos gestores, mas sim a partir do território.
In Brazil, with the national health councils, we have national health conferences. We have an important experience of having the social participation active before the policies are implemented and decided, but participating during the entire process.
E essa experiência ela traz a incidência, né, das comunidades, dos pequenos locais em que a sociedade participa da saúde, propõe ações para melhoria da qualidade de saúde no seu local, e que incidem nas 3 esferas de planejamento do governo, né? Então, esfera municipal, esfera estadual e esfera nacional.
And this experience brings voices from people, from communities, from territories, from small places to the public health policies and to the national decisions.
E essa incidência, ela faz com que a gente tenha propostas que sejam avaliadas pelos gestores, compartilhadas e implementadas posteriormente de acordo com a coerência e a necessidade da população.
And with this experience, we share our expertise and our knowledge and lived experience with the managers from the health system, so that it can be incorporated into our national policies and can influence in all the context of the country, in the municipalities, in the cities, and in the national level.
E na prática, isso se reproduz como não só propostas, mas incidência no planejamento orçamentário e financeiro da saúde, né? Então, a gente tem, a partir das conferências municipais, estaduais e nacional, a proposição e a previsão de recursos de acordo com aquela realidade que está sendo proposta, né? De acordo com as propostas que vêm das conferências. E isso tem tornado as políticas públicas mais próximas da realidade que a população brasileira tem.
And the proposals that come from the conferences, they are also influence on budget and resources, and so that the budget and resources allocations can be more close to what the society and the civil society needs.
E por fim, essa incidência, ela também ocorre na fase de implementação dessas políticas, né? Em que os conselhos de saúde, a sociedade participam do monitoramento de como acontecem essas políticas, né? Se elas de fato estão mudando a realidade social, se elas de fato estão alcançando e ampliando o acesso à saúde das pessoas. Então, essa é uma boa experiência que nós temos no Brasil.
And to close, we would like to also share that the civil society, the social participation is also present at the implementation of policies. So not just in the construction, but also in the implementation, the monitoring, the evaluation, and the follow-up on the policies. Thank you, everyone.
I think this is great. We're hearing a lot from a range of questions. Examples of where things have worked or not. Who's involved? Let's get a little bit more on that. Who is actually socially participating? Who's invited? And who's being excluded? And then also, let's hear a little bit more about what's next. We're hearing a lot of critiques, some are good examples, some negative, but what do we need to do next? Because we don't pretend that we've worked it all out right now. We need to think about what are our next steps. But let's hear from the next round of speakers, and then we'll check again online and encouraging more people to contribute on the online chat.
Am I audible? Yeah, great. I am Mani Chandana. I am from India, and I'm here as part of NCDA's Our Views, Our Voices fellow. I am one of the selected fellows to advance on my advocacy goals. I am here also sitting in this chair as a person with lived experience. I face the double burden of living with chronic asthma and a chronic neurological condition called multiple sclerosis. And thanks to all the speakers earlier who talked about safe space and not just providing a table, but tables, and then the importance of collaboration between member states. On that question of who is being excluded, I think exclusion is being done it is being done very strategically. I would say gay men and any queer community, and sex workers and the poorest of the poor. I think their voices are not being heard yet, and uh, and also like I have had an experience of being on a consultation call as part of a focus group discussion, but then where did my input go? What happened after that? I was not being informed on that, and whom do I reach out to once the call is over, right? And if I am not part of these decisions, then it is not true social participation. Access is not being given to me to sort of like understand where the information that I am giving is going and what kind of a difference is it making. And only when I know that kind of a input can I talk about the importance of it to my peers, to my community. And also, I think the biggest challenge is stigma. Like earlier, someone said, my mom asked me the question, "How did you get into the fellowship?" And I told her, "I exactly did what you asked me not to do." Right? She asked me not to talk about my condition to anyone. Right? So that's the kind of rooted stigma we have, and we all have to tackle that stigma in order to make people empowered to speak about what they're facing, not just in their day-to-day lives, but also what kind of difficulties are they facing in their interactions with the primary healthcare systems. Yeah, I think this was what I think would help all of us to come on the same page. Thank you.
Thank you very much.
Hi, everyone. My name's Bethany. I'm Australian, but I'm currently based with the Harvard Medical School's program in global primary healthcare. And I work on a commission for people-centered care for universal health coverage and have some allies and colleagues in the room on that. So the experience I want to speak to is based on that commission. And the commission is really, I hope, helping to advance this agenda in two ways. One is that one of the core objectives of the research is to demonstrate practical ways that we can create people-centered health systems. And for that, there needs to be voice, individual voice, collective voice in design of those health systems and policies. And the second for us is that the way we're doing this commission, the way we're doing the research has to be about meaningful engagement. Ultimate failure mode for us would mean to not do that well, to fall into any of the traps we've heard today around tokenism, around voice without influence. And what triggered my thought was this talk about multiple stable tables and being in motion. And I think some of the tensions we've experienced have been because in our attempt to create safe spaces where lived experience can come and share, we end up creating silos that where that experience is not actually it's remaining in an echo chamber. And so that tension of the safe space, but also the integrated space. I think another tension has been, although we were very intentional about seeking out lived experience, there's 40% of our commissioners identify as people with lived experience. They also identify as researchers and policymakers, and that none of us are actually wearing one hat. And so being able to get up and move to the other table and for that expertise to be recognized on equal footing. And the third tension, I think, is that despite our best efforts, again, to bring in multiple diverse voices, we recognize that the people who have the capacity to be involved in initiatives like this, they may be from different countries, different gender identities, other different demographics, but they're still generally amongst what we would call the global elite. They're people who can afford to be in these rooms, can afford to do work for free. We try not to do that. We do pay our commissioners, but and so one of the things we're trying to do is to reach, quote unquote, the margins, to do focus group work in areas that are not otherwise reached in many virtual forums. Sorry, not virtual forums, in-person forums in settings like Geneva and New York. So, but that takes time, that takes trust, and equity is expensive. And I think we need to, we need to acknowledge that, and policymakers need to acknowledge that and need to front the resources for that and pay what it takes. So there are a few of the things we're doing in research, really inspired to be among you. I think we need stable tables in motion, maybe like a sushi train. I can't think of a better analogy right now, but there's something about that, tables in motion. Thank you.
Thanks very much. We're going to be wrapping up soon. Very soon you'll see the QR code on the screens in front of you or online, and that's to enable you to contribute further ideas or to capture what you've heard today or said today so that it can be in the report. We are sharing ideas openly right now, and we want to build on that. We've got 3 speakers left to conclude with us, and then I do know that we have a few member states, looking at 2 of you, and then also a few people from WHO. We may hear just a few brief words as we conclude, but let's go to Amanda next.
Hi, everyone. My name is Amanda Buck. I'm here representing the Global Patient Movement Catalyst. I also work for the Synergists. Many of our partners and allies are in the room. I so passionately agree with everything that everyone has said. Equity is expensive. I think that's a beautiful way of saying the resourcing. Nicola, you made this point as well. In Europe, we're even losing ground on that, especially the resourcing, less for service delivery and co-delivery and more for the governance, co-decision-making piece. The safety element that Ritu brought up, the stable moving chair idea, table idea of Antoine. Not to repeat everything that everyone has already said, looking to the future, I challenge us to think about the next hurdle. And I think we need to be connecting the stable moving tables. And I'm just going to say sustainability. We're not connected to the sustainability agenda. We see wonderful theoretical connections. It was great to see the health action plan that came out of Belém in Brazil, notably mentioned social participation. That's wonderful. But even amongst civil society, I would challenge us to say that not all civil society is equal. And what some civil society can do, especially in the environmental field, is far more powerful than what the patient part of civil society can currently do. And as you know, we're working on that in the Patient Movement Catalyst. But the idea of if we're not at the table, we'll be on the menu is absolutely true. We're already seeing that those that are very powerfully moving the sustainability agenda forward are not realizing that that's going to come at a cost of their health. We have the PFAS agenda, we have the chemical agenda, we have a lot of decisions that are being made without people with health lived experience. That will affect their treatment products, that will affect what they can have access to or no longer have access to because it has too much of a carbon footprint, because we within civil society have not connected those dots. So as we are doing a great job in Sphere and other places to connect academia with policy, connecting the global diplomacy with the local work, let's also connect the environment agenda with the health agenda and help lived experience voices have the same resourcing as others in civil society.
Então, bom dia, sou o Fernando Pigato, eu estive presidente do Conselho Nacional de Saúde do Brasil até o final de 2024 e agora estou aqui hoje a convite do Conselho para essa avaliação dos 2 anos da nossa resolução, porque a gente ajudou a construir.
Good morning, everyone. His name is Fernando Pigato. He was the president of the National Health Council of Brazil until 24, and now he's here invited by the National Health Council as a consultant.
A gente fala no Brasil que precisávamos agir local e pensar global. E a gente passou por um momento que a gente precisou resistir muito, né? E isso coincidiu também com a pandemia. E a gente não deixou de investir no local. A gente tinha conselhos locais de saúde e a gente, a partir de 2023, como tivemos a democracia voltando ao nosso país, nós inclusive deliberamos numa conferência de saúde que essa seria uma prioridade, fortalecer e criar conselhos locais de saúde nos territórios.
Pigato mentioned about we need to think globally and act locally, because in Brazil we've been doing it, especially since 2003, when you have a democratic government back, and we've been working hard in the local health councils in Brazil to do this kind of job, acting locally but thinking globally.
Outra questão que a gente fizemos como prioridade foi formação para as pessoas atuarem no controle social, na participação social. Lideranças de movimentos, de entidades e conselheiros, inclusive, de saúde. Então, estamos esse ano completando 10 anos num projeto chamado Participa Mais, que teve um momento difícil, mas que a gente continuou fazendo e que agora, com o governo democrático, multiplicou em 3 vezes os recursos para esse projeto ser implementado. Hoje são mais de 50 mil pessoas que já passaram por esses cursos de formação.
There's something really important for us in Brazil about social participation that is regarding formation. We've been working on a project for 10 years called Participa Mais, that we work with counselors, stakeholders, people from the territory to bring the information about social participation in the policies. And we had like 50,000 people being formed by this movement, by this program in Brazil, especially in this democratic government now that we had funding for it.
Foi somente com o governo democrático que a gente pôde fazer parte, né, da construção da resolução a partir de 2023, aprovar a resolução em 2024 e agora ajudar a implementar. Mas a gente precisa escrever essa história e a gente precisa fazer com que ela seja contada depois, para ela não ser esquecida e para que a gente não tenha retrocessos como vivemos até um tempo agora há pouco. Eu hoje estou fazendo um mestrado, né, de participação social, saúde pública, que inclusive é um mestrado hoje organizado pelo Conselho Nacional de Saúde, o Ministério da Saúde e a Fiocruz do Brasil.
Great. This process we've been doing since 2003 is just possible because you have a democratic government who is pushing us to do it, especially because we have now masters in social participation in Brazil. This is a kind of new thing that we are doing. He's a student of this masters in social participation in Brazil, and we think we need to keep telling this story. Need to tell to everybody how we can improve it and keep moving forward to do it. Thank you.
Okay, I will keep it briefly. Thank you. Okay, I'm a physician in internal medicine, and I'm from the invisible country during WHA. I'm from Taiwan. Nice to meet you. No pressure. Yeah. And I just share one point is that because I'm also the influencer in my country and also have a collaboration and the advocacy within the civil society, have some recommendation to the government. And maybe somebody here know we have the national health insurance to have the coverage, to have the 95% care service to the all our citizens. And but there's a problem. We have a comprehensive services, but when we discuss something based on some truth, so what is the data? The data is not transparent. So when we do a civil society discussion, everybody is not on the same page. So one thing is very important is that to have the data to be comprehensive and be transparent to the civil society to do the further discussion, and we will have all of us on the same page to have a good social participation to the government for further discussion. Thank you. This is my point. Thank you.
Thank you very much. Our last speaker is from Brazil. We're very honored to have so many speakers from a dynamic country, and I believe you're speaking about health workers.
Hi, I am Ana Carolina Freire. I am a psychologist at the Federal Council of Psychology in Brazil and council member at the National Work Health Council in Brazil. I'm here to represent the health workers. I'm in the social control with the Brazilian unit, the health system. Participation is organized in the three-part system with manager, health workers, and service users take part in councils and conference. This structure support shared decision-making in public health policies. The participation of health work face challenges such as unequal power in decision-making, difficult work conditions, fragmented representations, and gap between decision and the implementation. There are also territorial, social, racial, and gender inequalities that shape how workers' participation. Even with the challenge, the involvement of health workers is essential. They bring direct experience for daily care and service organization, make social control more grounded in real rights needs. Strategizing their participation means improve the quality and fairness of health policies in the SUS.
Let's have another round of applause for all our speakers. We heard quite a lot. And very relevant for social participation, we're hearing about the tensions between those who have power, whether it's financial, technocratic, political, and those who are struggling to get their voices in. I think that's the reason behind the social participation resolution and where we need to go next. Fantastic session. I'm going to turn it back to Danny. She's going to lead us to the end and show how we can continue to contribute to this dialogue. Danny.
Thank you, everyone. Thank you, Ravi, for this excellent facilitation. But thank you, everyone, as well, for bringing your experiences and insights. And also thank you for staying till a little bit later than expected. I just wanted to draw your attention to a few resources that are available right now. There is the CSEM toolkit on social participation, kind of unpacking what's in there in the resolution, what civil society can do. IAPL also developed a resource with our patient community and WHO, CSEM, other strong partners, unpacking the resolution, social participation through the lenses of patient organizations and how they can move this forward in their countries. But also, remember, we talked about the research that started and we presented a few preliminary results. This will continue to be available because we want to continue learning what's happening on the ground and resharing with everyone who's working on this for us to learn and build evidence that it's much needed to inform member states. But also we started an effort to create a stakeholder map where I hope when you registered for this event, you were offered the opportunity to share an initiative that you are doing on social participation and where you are based, the name of your organization. So I hope the map will pop it. Yeah, so we started populating this so we can have an idea of who's doing what and start to create more connections, more collaborations, and more learnings for us to move forward together with this agenda. We'll be in touch, sharing the link for anyone who wants to be included in this map. So please share this widely. And also, one big idea that we are discussing, should we continue with this social participation village? Is this a good space for us to continue this conversation? Is this a good format and so on? So we'll also be bringing back this question to all of you because we believe that there are a few voices missing. The space is here. Let's bring these missing voices and let's think what we can do to act upon all these learnings and these insights that we have been sharing here. A big thank you for everyone, for the speakers, for the facilitator, for the participants, but also the co-hosts that did this event with us today. And I really look forward to continue this conversation, but also what we can do in practice to really advance social participation in our country. Thank you so much.
maybe those of you online can just give me a sign that you can hear us. Yeah, great. Okay, thank you. Sorry about the delay. We faced some technical challenges here in Geneva, but hopefully things are now working. Welcome to this side event at the World Health Assembly entitled Connecting for Change, Integrating Disability Equity Across Global Health Agendas. This is an event that's been organized by the members of the WHO Disability Health Equity Network and the International Disability and Development Consortium. We are, as it were, a broad range of different organizations, and not just organizations, but also member states, academic institutions, all interested and concerned by the question of equitable access to healthcare for persons with disabilities. So not disability as a medical issue in itself, but the breadth of life, the breadth of our whole existence as persons in our experience of the healthcare system, how the healthcare system welcomes us, adapts to us, understands us, and so forth. So my name is John Coughlin. I'm the Secretary General of the International Cerebral Palsy Society, and I'm the parent of a young man with cerebral palsy. So this is about the day-to-day living and the way that we experience hospital visits, clinics, going to the dentist, to the ophthalmologist, all of those day-to-day challenges, which we understand that in our case, for example, is a lot more difficult for a person in a wheelchair. So we have a wonderful panel with us who are going to be talking. First of all, we're going to have some background on the issues, some framing, and then we're going to have the voice of lived experience. And then we're going to have go a bit more into depth into the issues, the challenges, and how this network can address those, working together to make the healthcare system more inclusive for persons with disabilities. So to begin, I would like to invite Sarah Collinson from Sightsavers, who is one of the drivers of the network and of the initiative, to give us some background.
Thank you very much, John, and hello to everybody. It feels like a very important moment for this agenda and for our network, and really pleased to see so many people have joined us online as well as in the room to hear from our all of the panel today. What we know, am I able to move the slides on myself? No, thank you.
Sorry, I just realized now that sorry, in all of this, I missed the housekeeping.
Yeah, I was
beginning.
actually thinking that.
Yeah, okay, sorry, I'm off script. Let me just go back. For those of you in the room, and this has been part of the challenge for us today, we need Wi-Fi because we were going to participate in this interactively with all of the participants we have online, and we have many more people online than we do in the room. Those are the codes. They'll be up in the corner as well for you. To warn everyone that the meeting is being recorded, and to invite you also, if you wish to use the interpretation that's been offered, or rather live captioning with translation of the captions in the 6 official UN languages. You can do that by scanning that code or clicking on Interprefy, and the token you need is there, WHO May 2026. And from there, we'll pass into Sarah's presentation.
Thank you. So just to kick off with some of the background to this agenda, I think often disability is thought of as something of a kind of niche issue in the health sector, perhaps relating to providing specialist services for people with disabilities like rehabilitation, assisted technology, very important service provision. And I think there's a dedicated, there are some side events dedicated to that this week. But as John was saying, the challenges around disability in the health sector go way beyond that. And just looking at some of the data that we know about the inequities that people with disabilities experience in their health and in the health system tells quite a problematic story, really, about inclusion and equity and what that means for universal health coverage. It's not a minority agenda in the sense of the number of people who may experience disability or someone close to them in the family or in close friends who may experience disability over their lifetime. But at any one time, we're talking about 1 in 6 people globally who on average have much poorer health and poorer health outcomes than the wider population. 2.4 times higher mortality rates and missing 10 to 20 years of life expectancy compared with the wider population. Women with disabilities are 3 times more likely to have unmet healthcare needs than men, and we'll be hearing some more about that from Alessandra shortly. Children with disabilities are 5 times more likely to be reported as having been seriously ill than other children. And we see the exclusion and marginalization of people with disabilities in health systems reflected in much lower levels of healthcare coverage than should be the case and is the average for the population as a whole, as you can see from this slide. If we could move on to the next slide. There are many factors that contribute to those inequities. Some of them are in the sort of wider society. Structural factors such as stigma and discrimination, and the determinants of health, social determinants of health, higher rates of poverty, lack of access to education and employment, poorer living conditions, exposure and risk to violence, and increasingly more exposure to the impacts of climate change. All of those have an impact on the health of persons with disabilities, in addition to specific disease risk factors, often for many people related, for example, to lower rates of physical activity, the lack of access to public health interventions and so on. But also really important in this mix of factors and barriers are within the health system itself. So we have right across all the health system building blocks, we have issues with health workforce, lack of knowledge and skills and competencies, and poor data disaggregation. Sorry, I just got my warning about time, so I'm going to speed up a little bit through the slides, so apologies. So what we're trying to do in the network and in the wider movement to improve health equity for persons with disabilities is to integrate disability inclusion in all aspects of the health sector and to provide quality health services for everyone and access to quality health services for everyone, including persons with disabilities. We have commitments from governments. We have a WHA resolution which on the highest attainable standard of health for persons with disabilities, resolution 74.8, in which member states committed to strengthen disability inclusive health systems. And on the basis of that, the WHO has produced a global report on health equity for persons with disabilities and guidance for governments, ministries of health and other stakeholders in how to bring about the changes that are needed to address those inequities and to improve inclusion of people with disabilities in health services and systems. And that guidance goes right across all, as I said, all the building blocks, which is where action is needed right across the whole breadth of the health system and sector and at every level, in fact. So we have the guidance, we have the rationale because we know a lot about the extent of those inequities, and we also know that if we embed disability inclusion in primary healthcare, that will improve coverage for all underserved populations and deliver value for money. So as we're looking at the reform of the global health architecture, we need to be sure that disability inclusion is designed in from the outset and not just left as an afterthought. This affects a really major proportion of the global population and is a sort of key indicator, if you like, of whether we are progressing towards universal health coverage as fast as we need to. And at the national level, there are all sorts of entry points because it's a cross-cutting agenda. When we look at what's going on in specific countries, there may be a whole range of health policy reforms and opportunities, not just challenges, but opportunities to embed the actions that are advised by the WHO and its global report and the other normative guidance that we have to turn those commitments into action at all levels. So I think that's my last slide, and I will pass back to John. Thank you very much.
So, thank you, Sarah. I'm afraid I wasn't clicking through the slides as I should have been.
That's okay, don't worry.
So, but I hope that we'll be able to share those afterwards, of course, as well. Now, we have a little exercise, and this is going to be the big challenge for the technical setup for us. We wanted to, involve you and hear from you. So we have a little Mentimeter exercise for you, a little polling exercise. And for this, I think we need to share the screen. I know that the participants online can see the room, but maybe not the slides. Yes, we've been having big problems with Wi-Fi this morning, I'm afraid. You can't connect. So if you can't connect here in the room, then just shout out your answers, okay? And we will. You have that option, whereas the ones online, they don't, and they will be able to participate online. But for them to be able to see the screen, we need to. Just a moment. Great, thank you. Okay. Can we? Can somebody who has the? Yeah, that's a good idea. Somebody has to put the Menti link in the chat. That's a very good idea. They see now? I don't think that they see online the slides. They see us? No, somebody switched over because apparently it was too small. So that needs to be restored. Yeah, I can see people online can if we got the link. That's what they see. They're not seeing because we're not sharing the screen. I'm not allowed.
No, we can't hear you.
Because Angela needs to promote you.
Angela, I think you have the solution to the problem.
Geneva is not
It's
Can one of the colleagues online, so Faith or Mel, can you make John a presenter? Otherwise, I'll go to the hallway.
But make it the Geneva room, not my own profile.
D'accord. Mais en tout cas, c'était bien visible.
Ça ne marche pas avec.
Ça ne marche pas avec quoi, pardon?
Ça doit marcher avec la version en
D'accord. Vous arrivez. La personne qui partageait avant n'arrive plus à partager, c'est ça?
John, do you want to just read out the questions and have people we called on?
Yeah.
Pour la presse, c'est bon en tout cas. Sorry again for this, but I think now it's working. You can see you've got the code, you've got the, yep, great. Some people are joining now. So our first question, just to get you going, just to make sure that it's all working, is in which country were you born? I'm going to start. So I'm just, I will, yeah. What did we have from the room? We have India. I had Bhutan, Nicaragua, US, Italy, Sudan. Okay, great. Okay. So that's getting us started. Now we're getting to the really important questions. First of all, do you identify as a person living with a disability?
Yes.
Yes, we had loud yeses here in the room. Maybe. But we see that indeed there's a majority who don't themselves identify as being a person living with a disability. But maybe we encounter disability in a different way. Do you know someone living with a disability in your family, community, or work? Yes, says everybody in the room.
Yes, is it?
Yes. And really no exceptions whatsoever to that. And that's really, well, almost one. You know, it's really the importance of understanding, as Sarah was saying in the introduction, that disability is not just a small portion of the population. It's really a significant number of people. And a healthcare system that isn't adapted to the needs of persons with disabilities is probably not a healthcare system that's adapted to everyone. And that's what we've got to be thinking about. Okay, that's going to bring us into our panel on lived experience. And we have, and excuse me, I'm switching between slides. You feel free to go back to the other presentation now if you want. We can have a break from Mentimeter for a bit. We'll come back to it later with some more meaty questions. And our panelists, we have here in the room Pearl. We have two panelists online who are Joseph and, excuse me, Smitha. I hope you can all connect fine. We need to maybe switch back over so that we can see the online panelists. And I would like to invite you to share with us a little bit your own experiences, demonstrate how failures across the healthcare system are undermining the concept of universal health coverage being truly disability inclusive. Pearl, you go first.
Cool. There are around 1.3 billion people with disabilities in the world. Hi, my name is Pearl Luti. I am 23 years old and I am just one of those 1.3 billion people. I have been a self-advocate for several years and am the ambassador for Switzerland with the Down Syndrome International. Down Syndrome International is a global network that works more than 120 countries for people with Down syndrome and their families. Today, I've been invited to speak here at the World Health Assembly in Geneva to talk about the need to provide universal health care for all people, including like me. I want to share my personal experience of the health system. At the time when I was very sick and exhausted for a couple of weeks, and my parents took me to the hospital to find out what was wrong. A couple of hours and a lot of blood tests, a nurse came and lifted my hospital gown and injected me in my stomach. When my parents asked what was happening, the nurse gave no information and said that would be my life now and we all should get used to it. She didn't talk to me at all. I was mega shocked and felt very scared and sad. I would have liked it if she had at least introduced herself and explained what was happening, so that I would have understood what she was doing. And now I wonder if she would have treated me the same if I didn't have Down syndrome. Unfortunately, my story is not unique. Many people with Down syndrome have had experience like mine. Doctors often talk to the person next to us, not to us. They use language and that we don't understand, like my experience. Things are often done to us without asking. Doctors make decisions for us. Last year, DSI had a big report called Our Say in Our Health. DSI asked people with Down syndrome and intellectual disabilities and their families all over the world about their health. There were a lot of stories like mine of people being treated unfairly when trying to get health care. Here's what DSI found. Around half of the people said that doctors and nurses treated them unfairly. Only 29% of the people said the doctor talked to them in a way they could understand. Only 38% said that the doctors were helpful by doing things like giving more time in the appointments and or using easier words. Why does all of this matter? People talk a lot about universal health coverage. That's health for everyone, right? But health is not universal if it leaves some of us out. If the doctor doesn't talk to me, I can't say yes or no. If I don't understand, I can't make a choice about my own health care. If nobody asks me, I'm not part of my own health care. That's not health for everyone. That's just health for some people. To me, health is about being able to do this, being able to do things just like everyone else. This includes knowing if I have a problem with my health, that I'll be safe and respected and informed and treated fairly, just like everyone else. So, what needs to change? I have two changes to recommend to you today. At first, train health workers. Doctors and nurses need to learn how to talk to people with disabilities. They need to use easy words for us to understand. They need to give us extra time. They need to ask us, not the person next to us. And based on my experience, they need to ask us before they do anything to our body. Second, include us when making decisions about our health. When you make a plan for health, ask us. When you write a policy, ask us. When you decide what training health workers need, ask us. There is a saying we use a lot: nothing about or without us. It's simple. If you're making decisions about our health, we should be in the room. Thank you.
Thank you, Per. And those words about the language that medical professionals use, the way that they talk to, I get talked to, but not my son, for example, that really strikes me. And I was just once in a situation with a doctor who explained everything to him in his language, and it was so striking. And then I realized how unusual it is, unfortunately. Thank you. Thank you. Our next speaker is Joseph Etiang, who is the Disability Program and Inclusion Officer for the LVCT Health Organization in Kenya. And Joseph is joining us online.
Pin him. All right. Thank you very much, dignitaries, as well as ladies and gentlemen. My name is.
You can. I think that somebody else.
From here. I'm at I work at LVCT Health as a disability program officer. I'd like to share my experience as I address individuals. I don't know. You can hear me?
Joseph, we don't have audio for you yet. I'm sorry to interrupt. So give us just general, and then we'll ask you to start once we've got the audio set up in the room. Sorry, Joseph.
Angela, do you have the name of the interpreter?
The interpreter is in the room with Joseph, so we just need to have video and audio from Joseph.
So one of our technical support staff online needs to unmute Joseph's interpreter.
They're using his computer, his laptop.
Online, they were able to hear Joseph and his interpreter is silent, so it is an online in-room tech situation.
Is the interpreter speaking right now? Is
No.
she speaking?
No, we asked him to stop so that we didn't miss the
Yeah.
You speak now?
You can hear us? Can you hear us?
Yes, we can hear you now. Thank you.
Yes. All right.
So
Thank you.
Go ahead.
Thank you very much. Yes. Yeah. Let me share my personal experience as a deaf individual or a deaf man. Yes, lived experience from a deaf person. We face a lot of issues, especially here in Kenya, and I can say in Africa. I like to highlight here from my experience. One, the communication barriers that we face. Two, limitation of awareness in terms of, and then policy gaps that are there, including the attitudes attitude and stigma that we face. So as a deaf person, faced health services. As a deaf man, I've had problems. I'm married, my wife is hearing, and what happens is that as a deaf person, when you go for antenatal care or at the hospital or the clinics, many times you'd like to accompany your wife. But now what the doctor does is that they do not speak to me in case there are things that I need to support my wife with. They speak directly to my wife, and now my wife becomes my interpreter. So they ask questions, and my wife will now have to become the interpreter. And sometimes, even during labor pains, it becomes difficult. You want to support her, you do not know what is happening. Now, when it comes to dual power of attorney, consent, operation that has to be done, as the husband who's deaf, I need some support. What do I make decisions on? They are thinking of cesarean. We have not discussed, or I was not aware. I'm just forced to do things that I was not prepared for. So now you have complications that are there. And now it becomes also stressful for someone like me, a husband, and it affects me as a husband that I have a wife and yet I cannot get clear information from healthcare providers because they do not know how to respond to a husband who's deaf. So attitude and stigma is what is there from the healthcare workers, and they do not give us information that is needed. I also remember a deaf woman I had seen in one of the hospitals as a healthcare worker to just supervise some of the programs that we do. And in the clinic, what I saw is that the nurse using a card to call names of the patients or clients who were there. And there was a deaf lady, pregnant and in pain, who needed some services. So she was served at the end of the day. She came early in the morning for services, and at around 3 or 4 in the afternoon, that's when she was getting treatment. Lucky enough, I was around for supervision in that area. And what happened is that I told the lady, the nurse in charge, there's someone here who's deaf, and he has been here for a long time. So by the time the lady was going for delivery, was getting some support, it was too late. Things had become worse. So while I'm talking about also awareness, it's from my experience as well. I do remember during COVID, the information was not there for persons with disabilities, especially deaf people. We use our face to communicate, and we were told to wear masks. And now we used to wonder, why is this information coming to us late? Because we do not know what is there. Now, imagine with the current cases of Ebola, Mpox, and others, we do not understand what is happening, and we usually get last minute or after losing loved ones or friends. That's when we come to realize what's an epidemic that we are facing. So we are not looking for equality, we are looking for equity, where we are treated well and we are able to understand what is happening in the health sector. When it comes to policy, it has been mentioned by my colleague, is that the implementation is not there. The implementation is not there at all. I remember in 2 scenarios, I remember 2 things that I'll mention. We talk about equality and equity. In our republic, like in Kenya, we will say we have ramps there for persons with disability. At least there are things that will help them. But this type of disability is one that is supported. Those who are physically impaired and they are using the wheelchair. How about sign language? We do not have sign language interpreters, but we are providing equality to all persons, including persons with disability. Missing equity, where all of us are treated and given the dignified respect we deserve. When we meet hospital services, as mentioned before, they usually say a deaf person does not need a lot and they're expensive because you need an interpreter. Or sometimes they judge us because of cultural issues. They may say, because the sign language is like a madman, then this is a madman who's come here for support. They even ask us, do you have sexual appetite? Do you have a wife? So it is intrusive also to our dignity when we seek reproductive health care, especially in health, they do suffer a lot when they seek reproductive health services. Now, how can we be able to solve this barrier? We can focus on some of the problems. For example, accessibility. We need someone in the healthcare system, for example, who understands basic care, basic sign language to be able to help. When it is an emergency, imagine, how do you provide support to this individual? We need also someone who understands very well the language, technical language in the medical field to be able to break it down and simplify it to us. Not to use jargon as been mentioned, which becomes harder for us. Because many times here they'll say if we need an interpreter, we have to pay for that interpreter. So good systems where they take care of the nurses in terms of providing quality healthcare, confidentiality is there. Also, if there is none, then interpretation services need also to provide confidentiality, where we also have things like good translation services or interpreting services for deaf persons. It is very important, as has been mentioned, to provide training to healthcare workers. Healthcare workers, because doctors deal with individual or hard cases, while we have, like in our cases, community health providers. They should be champions in terms of being trained on disability. So when they meet a deaf person, they can be able to deal with it. If it's a blind person, they can be able to work with them without stigmatizing. So the training itself needs to be wholesome, where you start with the CHP or community health workers so that they can be able to help. Sometimes you just find a CHP or community health worker who has come, they want to provide services, but they are stuck. They cannot provide the basic healthcare service in the basic lower tier healthcare service for us, persons with disability. So when it comes to policy, I'll reiterate what has been mentioned again. It is always critical to have good policies and implement them. And I'll say true, we need to be involved when you're making decisions or policy that include us. So issues of persons with disability vary. For example, for someone who's blind, there are issues when it comes to health vary from someone who's deaf, someone who's autistic as well. So asking them what they need, then it becomes easy. Because most of the time we find someone has studied issues of disability, they are not which are not lived experiences, therefore their theories do not actually help us as people are living with the disability. So we need to understand, train persons with disability themselves. Like, for example, I, Joseph, have been trained. I do know, for example, in your meeting, we have an international interpreter, but you see, we cannot be able to stand because we have signs depending on the culture or where we live. So that means we need to be sorry, you're saying something?
A bit of problem here, hearing you here in the room. There's a bit of interruptions, but I could also ask you just to wrap up so that we can move on with the next speaker. Thank you.
So my point has been, sorry for the internet, at least for policies, let's make sure that we include persons with disability there, various persons with disability in the policies. We build capacity of healthcare workers, and then use the technology that is there. When we use the technology that is there to be able to help. However, remember, AI does not work for everyone. For example, for us deaf individuals, AI does not work for us. So we can use technology well to support persons with disability. So always remember that healthcare service or UHC needs to be to cater for everyone, whether you're blind, whether you are deaf, It needs to cater for everyone. It starts with you, World Health Organization. When we start, we know everyone will follow. Everyone will follow. If you do not do, then it becomes harder for people to implement what is not there. So people will follow you. So as we start, we hope that everyone will embrace it. Thank you very much.
Thank you. Our third speaker with the perspective of lived experience is Smitha Sadasvisan from India. She's a disability self-advocate and an accessibility and inclusion consultant for Disability Rights India Foundation. Smitha, over to you.
Thank you very much for this opportunity. I am Smitha Sadasivan. I am a person with lived experiences in multiple sclerosis, which is a neurological condition, and as well as an autoimmune disorder. I have been living with this condition for the last 25 years, which means that I am having healthcare needs for every day, on a day-to-day basis. And in addition to that, I will require any comorbid conditions management and also rehabilitation, mental health interventions. And when I get into a relapse, then everything holistically I would have to start from scratch. So I just want to share my experience from my recent relapse, a flare-up, which happened in November, December. And the first step was I had doubt, I had all the symptoms, and I had to go in for diagnosis process. And it was multiple diagnostic aspects which would fall in different places. And I don't have one place where everything is put together. And if such a place is there, then it would be more expensive. And the community health center close by doesn't have an MRI diagnosis or high-end blood tests. So I have to go to different places, and obviously I had to spend from pocket. After the diagnosis comes the treatment. I had to get admitted in a hospital, whereas my medicine, when I had a discussion with my doctor gave me a few options. The basic minimum, which is a steroid, will be available in public hospitals, whereas when I wanted to go for the next level, not a much higher end, but then the next level of basic treatment, which I chose, was not available under the UHC program. So many of our medications, which we need for quality healthcare, are not available under the UHC programs. This is a reality in many of the global South countries. And I had to spend from pocket, and I had to go to a private hospital and take my injections. Then after that comes the rehabilitation part, the physiotherapy, the vision therapy. I had issues with my vision, and I had issues with my balance and mobility, and also bladder. So this time, additionally, the bladder had a lot of issues, and a lot of residual urine was there, and which had to be emptied, and it has to be done by intermittent catheterization, which I have to do every day. And for that, doctor suggested to myself to learn, which I am not able to because of my finger coordinations and the instability of my legs and all that. So I had to approach a nurse, and which is again much expensive. Nurse coming in every day and doing the intermittent catheterization at least once. I have to get all the disposable kit for the ICC. So all this is a burden for people with disabilities, for people with multiple sclerosis or any other condition who are looking at quality healthcare on a day-to-day basis. If it is just once in a while treatment or once in a while intervention, then it is okay. Like we can somehow manage. When it becomes a day-to-day exercise for persons with disabilities, starting from rehabilitation to palliative care to any such interventions, then it is such a huge expense out of our pockets, and the UHC programs are not really catering to these kind of very nuances, very specific requirements of persons with disabilities or people with neurological conditions like multiple sclerosis. And next is the mental health. When I go, I feel low, and I don't have a mechanism to let out, or to break out, or so. What is the intervention through the UHC needs to be worked out. Everything is available under UHC, but everything is in silos. Like mental health program separately looks at mental health issues, and other doorstep medication programs like look into the interventions of diabetes and hypertension. Whereas, what about people who use catheterization, or people who need palliative care? So, or people who need physiotherapy, vision therapy, we need to go a huge distance for taking these therapies. And additionally, the transport system is also not accessible. So we have to pay more for the transportation also to ensure convenient and or accessible transportation. So all this put together, it is a huge burden on persons with disabilities. My suggestion is how UHC should look at the healthcare of persons with disabilities. It should be a holistic healthcare management, starting from nutrition to diagnosis to medical interventions to rehabilitation to mental health, and everything should be available as a core at the community level, so that I don't have to go from hospital to hospital or diagnostic center to therapy center to take the services. Whereas if I can get all these services at the primary healthcare center in my own community, then that will be really great. And in addition to that, the person-centered care, where when I need a caregiver, if my caregiver service can be provided by the government, then a huge cost is cut off from my out-of-pocket expenses. So it has to be holistic, and the mental health aspect should, I'm just finishing.
Yep.
The mental health aspect should also be part of the community program, where the people living in the community in my neighborhood should understand me and should be able to support me, whether it is mental health or taking me to hospital, these kind of stuff. I stop here, and I will be happy to answer any more questions. Thank you.
Thank you. Thank you so much for that. I think given the technical challenges we've had and the time is running over, we're sorry for that, but we have to be conscious of the fact that participants will have other engagements afterwards. Then we should move on at this moment, and we'll save the discussion for one round at the end. And so with that, I would like to pass over to two other perspectives coming from organizations and indeed from a government working to promote greater disability inclusion in the healthcare system. And the first person that I will call upon is Alessandra Arezzo from Humanity and Inclusion. Thank you.
Thank you, John, and good morning, good afternoon, and good evening, everybody. I'm Alessandra Arezzo, Director of Health and Protection at Humanity and Inclusion, and I'm very, very happy to bring this conversation towards one of the core aspects of health, that is sexual and reproductive health and rights. We know, as you have heard from other colleagues, that 16% of the world population experience disability. It is important also to highlight that about 20% of the world female population has a disability. This means 1 in 5 women has a disability in the world, and a large portion of them lives in low and middle income countries. This is a key information to keep in mind when it comes to sexual and reproductive health and rights, even if, of course, is not dedicated to women exclusively. Yet, despite these figures, you have already heard that the barriers to access health information and services are many. This is particularly true also for sexual and reproductive health, including maternal health. Information and services, despite the fact that, and this needs to be stated quite clearly, women and adolescent girls with disabilities have the same sexual and reproductive health needs and rights of women and girls without disabilities. Among the main barriers that are specific to sexual and reproductive health and rights and maternal health, we can mention some. Stigma and discrimination leading to misconceptions about their ability to be a sexual being, to become pregnant, to become mothers. A lack of sexual and reproductive health, including maternal health information accessible to women with different types of disabilities. Sexual and reproductive health, including maternal facilities, are often not accessible, and equipment is frequently not adapted for women with disabilities. And women with disabilities are more likely to come from low socioeconomic backgrounds, making it difficult to afford SRH services and maternity care. So when it comes to specifically to maternal health, while globally significant progress has been made in the field of maternal health, women with disabilities are still not intentionally included and are often overlooked due to low capacity of maternity health workers on disability inclusion, which leads to over-medicalization and unnecessary procedures during pregnancy and delivery. And this is to give you an idea of the barriers. When it comes to the consequences that come from these barriers, of course, there are some data available. Globally, data are not yet enough, and so the consequences are not, and the impact of exclusion is not yet well documented. What we know is that sexual and reproductive health and rights of women and girls with disabilities are consistently violated, and particularly when it comes to bodily integrity, privacy, and personal autonomy, which is often not respected. The ability to define the freedom to define their own sexuality, including sexual orientation and gender identity and expression. The freedom to decide whether and when to be sexually active, to choose their partners, and to decide when or not, or if to get married, and to decide if and when having children. Of course, the lack of access to sexuality education is significant for women and girls with disabilities. It is also documented that women and girls with disabilities have a higher risk of HIV and are less likely to know their status on or access to treatment. And last but not least, women and girls with disabilities are 2 to 4 times more likely to be affected by violence and face higher risk of experiencing violence in healthcare, including obstetrical violence and reproductive coercion, which are unique forms of violence owing to gender and disability. Now, there is a good news, because we cannot leave each other without talking about good news. Of course, transforming SRHR is possible. And it is possible by investing in disability inclusive and gender responsive or transformative health systems. But to be able to do that, we need to intentionally commit to it through joint actions and not to single projects or one-off projects. I will bring very briefly some examples and lessons learned from HR experience that is dedicated to really breaking down barriers faced by women with various types of disabilities in assessing quality SRH, including maternal health services. Some of the ideas are the following. First of all actions need to be taken at every level, individual, community, health facility, and institutional level. Second, and equally important, collaborative partnership are key, meaning that international NGOs like HI will work hand in hand with the Ministry of Health, with the SRHR providers, organization of persons with disabilities, including women with disabilities-led organization, for which it is important to guarantee meaningful participation at every step of the way. And other NGOs and partners, of course, to complement efforts, complementing the efforts of the different stakeholders altogether. Of course, partnership, HI has been working in partnership with the Organization of Persons with Disabilities for many years. We had the privilege to work with Down Syndrome International for the project that Pearl has referred to before, and it was a pleasure and an honor to work with you. Of course, there is an important aspect related to awareness raising at community level to ensure that community understand and are educated about the rights of persons with disabilities when it comes to SRHR, and activities that come to a social behavioral change to ensure SBC strategies to address disability stigma and conduct comprehensive accessibility audits, as well as, last but not least, ensuring strong capacity strengthening and training and coaching of health workers on disability inclusion, as Pearl has mentioned. Now, there are, of course, many more things that can be done, cannot be listed here. What we have realized throughout the years is that, of course, all of this can be done, but needs to be also done in connection with what is happening beyond health equity for persons with disability and in intersection with what happens, for example, with other crises that are taking place out there. One of them is, for example, the climate change crisis. I will spend 2 words on this, and maybe we can go back to it in the discussion. There is a growing evidence today that showing that climate change has drastic impact on SRHR outcomes of women and girls overall and globally. Extreme weather events damage health infrastructure, supply chain, and disrupt referral pathways, limiting access to essential SRHR services. And of course, climate-related crises increase exposure to gender-based violence. Among other aspects of the barriers and increasing difficulties that climate change brings, for example, climate-driven displacement disrupts SRHR access overall. There is a lot that can be said about how SRHR and climate change interact, but certainly very little has been said about how climate change, SRHR, and disability inclusion work, and how women and girls with disabilities and overall persons with disabilities are affected by climate change, and how this exacerbate the barriers that I have presented before when it comes to accessing SRH information and services. The slide that you see is the link to a study that has been done by HI in partnership with Women with Disabilities-led organization in Kenya and Uganda that brings the lived experience of women and girls with disabilities in these 2 countries that starts to shed some light on how we can work together on SRHR, disability inclusion, and climate change based on the experience of women and girls with disabilities who live this on their skin every day. I will stop here because time is tight. Happy to come back to it for the discussion.
Thank you, Alessandra. And we have one more perspective online from Patience Ofosu-Hema, who is Senior Health Promotion Manager and Activity Coordinator for Disability Inclusion and Health Service Delivery at the Ghana Health Service. Patience, we can't see you here. Maybe that's because I'm still... Yep. I need to stop sharing the screen. Great, yes. Go ahead. Patience, if you want to start.
Yes, please. Yes, can you hear me?
Yes, we can hear you.
Okay, great.
And just, of course, a warning that we're a little bit tight for time. Thank you.
Sure. Thank you very much. So, good morning, everyone. My name is Patience Ofosu-Hema. As it been mentioned, I work with the Ghana Health Service as a health promotion manager with the Health Promotion Division head office. So I coordinate activities for disability inclusion and communication at the service. Please, can my slides be projected? So over the years, in the year 2020, I have a limited time, so I will just brush it through. We had a ASBC, that is United States, with us. That is a ASBC consortium. They were here for a project, and then out of it, they had their implementing activities. So I took advantage with my able to communicate with the program manager. I made him understand how is it important to get inclusion as part of the work. So based on that, we were able to come out with a landscape review. And from the landscape review, actually give birth to what we have today from the Ghana Health Service, the Health Promotion Division. So with me were the first trainers that we had in Ghana. Please next. Please press again. So the background, based on what we have, the service is now committed to give out equitable, inclusive services to persons with disability. And then we want to align our national disability legislation as well. And then also go by the UNCRPD when it comes to persons with disability, and also try and integrate into the primary healthcare strengths and efforts for the service as well. Please next. Please next. So progress of work. No, please come back. Progress of work. As I mentioned earlier on, we conducted the landscape. And the landscape gave us, it was on a desktop review, desk review, focus group discussions with my team, and then led by Sightsavers International, Sightsavers Ghana, and then ASBC. We were able to identify the barriers, that is attitudinal communication, financial, and the knowledge gap on the part of health service delivery. And then based on that, I think with the recommendation, we're able to create a policy draft, implementation plan. This was to lobby into the other divisions of the services, and then also get the buy-in from the Ministry of Health, which is the mother umbrella for the service, to get the policy done. And then we also developed the in-person training, and then online also one that's also we were able to implement. After the first training, and then we developed all these, and then USAID actually left. And then please next. So when they left, we needed to also lobby for other partners to come on board to support us in what we were doing, because we can't let it be like that. It was small, but we wanted more to be done. Please next slide. We wanted more to be done. So we were able to go ahead to develop, we had a boot camp, and then got e-learning boot camp to be able to get the models, and then all the things that we needed. Please, the next slides. So based on the findings of this, I was able to go to Addis to present on the SBC Summit in Ethiopia, which was assessing entry points on disability inclusive in health promotion programming in Ghana. And then, please, next slide again. With that, we decided that if we want to make things standard, because of the knowledge gap we are talking about, we need to get a guidelines that will actually make health professionals understand their duty of work and what they need to do. I have always been saying that they want to actually give the best service to persons with disability, but the question has been how. So based on the network that we joined earlier, we joined the disability network, and then we're able to get we got the health equity report. We're able to get the main pillars within the WHO, what we needed in the guidelines, framework, data, communication, workforce, and then all that. So we have a draft copy now, pending validation, which we want to do that before the end of the year, and then we can go ahead. Please, next slide. We can go ahead, and then we adopt it. So during the guideline, these were the teams that actually came on board for us to develop the guidelines. My director is the one in the middle, smiling director, Mabel Kisiwa. May God bless you. And then director of health service support, then administrator from the public health. Then on the streamless setting is the Ghana Association for the Deaf, their president, Juventus. And then we have the deputy director, we have the Ministry of Health, and then all of them are there. These are the people that came together for us to be able to get the guidelines drafted. Please, next. Next slide, please. So when you go to the Ghana Health Service e-learning platform, the link has been provided. You will find mainstreaming disability inclusion in health service. The target audience were health workers. We target about 6,000. That was last year. We couldn't get the target because I think the dissemination was a bit low. So we have another plan this year to also reopening and get CPD for health workers who will take it. So we focus on respectful communication, reasonable accommodation, and then inclusive referrals, and so on and so forth. So we hope the learners go in and get the knowledge that they want. Please, next. So from the e-learning, and then we decided that we need to build on it for people to be able to get the whole disability inclusion activities. Please, next. So during the International Person Day with Disability last year, 3rd December 2025, we had this small DEBA, please next slide, DEBA at the Ghana Health Service office. And then the certificate that were given to us by the WHO Disability Network. On the right from my side is the WHO rep handing over the certificate to our Deputy Director General, Dr. Reindorf. And then Director Reindorf also giving it to my director, Director Mabel, and then Director Budget is also there. They took the certificate for the division, whilst the service also kept one, for us to remind us of our commitment on what we need to do and what needs to be done. Please, next. And then also we have also had engagement with a private organization, Nouvelle Hour Foundation. This initiative is like a health infrastructure in an app, which we believe that when it comes to data, Ghana is dangerous. When you want to talk about disability data, we don't have any. And therefore, they just mix them with the population. If you need a data for a particular interventions, you won't get. This particular app is not to replace the systems that we have, but this one is to complement what we have. And therefore, the data that we want to do is a study that we want to conduct in Ghana as a pilot. When it becomes visible, probably, we have already submitted the proposal to WHO Global Health, Kaloyan and the team, to get us the support that we needed so that we can able to have the pilot and then we can take it out from there. Please, next. And then we had the first national TOT. We have all these people, HPD, DHS means Ghana Health Service, Health Promotion Division, Family Health Division, Institutional Care Division, PPMED, HR, HEFRA, health, those who give the accreditation to health people, and health facility to be built, public health, immunization, Office of the Director General, National Council for Persons with Disability, and then the Federation. We had a training, master training on disability and communication. And then overview of that, we build on that. We were able to train 18 districts out from the 261 that we have in the country. So there was a very big gap. Please, next.
And just to ask you to come to a conclusion, please.
UNICEF with yes, please. All these to be able to get now the pillars. So we have the first training curriculum and then the second one here. So we had all these, and then now we are able to train 200 and out of the 261, we have only 38 districts being trained. Please, to the last two slides, to the challenges. Right now, the challenges we have now are the data. We institutionalize of data. We don't have no budget. Infrastructure accessibility, the old ones are there, which some of them can be adjusted. Workforce, funding constraints is also there. And then we don't have social behavior change materials, which we know it influences behavior. And then we normally engage the stakeholders enough, but the partners that support us. So the data is actually the problem now. We need data to get all that we are doing to be recorded so that we can speak to it. And on that, I think the slides will be given up. I just want to say thank you for acknowledgement of the partner. Please, you can show the partners. The Ministry of Health, the Ghana Health Service, our Director General, and then my director, Mrs. Mabel, and then the rest of the team. Thank you very much.
Thank you, and I'm sorry we didn't get to hear the whole story because there's obviously a lot of really good examples there for us to follow. But we recognize the problems, the issues, the challenges, but also the possibilities, and that's really why this Disability Health Equity Network has come together. And I'll hand the floor now to Angela Jenkins from Special Olympics to talk a little bit about how that is hopefully going to change things.
Thank you. And I do have some slides, John, if you want to go to slide 41. So Sarah spoke at the top about how we have worked together to keep raising the profile of the issue of health equity for persons with disabilities. So moving from the 2021 WHA resolution to the 2022 global report and the guide for action that we've heard so much about. And so the next step, bringing us ever closer to today, was the launch of the Disability Health Equity Initiative, which we did, or WHO did last year, to bring a variety of stakeholders together so that we can close the avoidable health gaps between persons with disabilities and the broader population. Next slide. The initiative has 4 interlinked components, which I will completely gloss over in the interest of time. I will just say that one of these components is the network, which you've heard that word a bunch of times today because all of the co-hosts of this event are members of the network or housing the network in the case of the WHO Health Equity Initiative. Next slide, please. So what are we even trying to do together? So along with many others who I'll talk about in a moment, our organizations and the other members of the network have several objectives. First, we want to raise awareness of the health inequities that people with disabilities face, like the reality that persons with intellectual disabilities are 6 times more likely to die of causes amenable to quality health care than the general population is. And we want to convert those aha and I had no idea moments of discovery and hopefully outrage into shared and synchronized demands for change. Another thing that we want to do, or one of our objectives, is to channel our collective resources efficiently. No matter where we sit in the health system or the ecosystem, we are all doing our work with less resources all of the time. And that means it's all the more important for us to coordinate our global efforts and our advocacy so that those of us who are doing the advocacy aren't duplicating each other's work, and those who are on the receiving end of the advocacy aren't being pulled in all kinds of different directions when we could all be pulling together in the same direction. And thirdly, in terms of our objectives, we are grounding our efforts in evidence and like I said, to aim to be as efficient as possible. And that's the reason that knowledge sharing and capacity building are an important part of our shared work. Next slide, please. At its launch in November 2025, the network had 152 members from all regions, and that included 31 member states, 13 intergovernmental organizations, 72 civil society organizations, 32 academic entities, and 4 organizations from the private sector. Next slide, please. And we've organized ourselves into 4 work streams. The first work stream is on building leadership on health equity among persons with disabilities. Pearl already brought us up to speed on nothing about us without us, but she put it even more aptly. Ask us, right? And so that is really the essence of work stream 1, is to make the ask us a reality in the health sector by equipping organizations of persons with disabilities with the knowledge and the financial resources to advocate for health equity for persons with disabilities, as well as the opportunities to participate in decision making. Workstream 2, which I co-chair, is about elevating health equity for persons with disabilities as a political priority in health. And so this is about ensuring that political leaders recognize the need for health equity for persons with disabilities, many of the arguments that you've heard here today, as well as trying to better position the issue within the global health agenda, which is one of the reasons for us to host this event. Workstream 3 focuses on creating a disability inclusive health sector and is much more focused on getting down into the country level work, which is why you've heard, I think, from Sarah and some of the others about that really grounded country level activation, which was at the center of the slide that I glossed over earlier. But it tackles the lack of ownership of the health equity for persons with disabilities agenda on the part of the ministries of health. And it seeks to improve inclusion across the 10 strategic entry points that Sarah mentioned and had on a slide earlier today and are well documented in the global report as well as the guide for action. Last but not least, work stream 4 aims to address the issue of data, which Patience brought up in her remarks, the need for robust indicators, for evidence, and for monitoring, because these are key for documenting the need for action and therefore driving action and informing what action even looks like on the policy front. And of course, they help with monitoring progress over time. I think I'll hand it back to John. Thank you, everyone.
Thank you. We're very close to time, but we've been told we can stay on a few more minutes in the room, so hopefully you've not got to rush away, and likewise online. We still want to hear from you and give you a chance to say something. I've put up the Mentimeter again, and this is just to go on the background, as it were. If you'd like to add there your suggestions or your insights into where you think you need the most support to strengthen disability inclusion in your work, then that's something which we'll just collect up the ideas there and we'll be able to take away with us. But in the meantime, if you have any questions for the panelists, please feel free. Or Mel, online, do we have any questions or comments? Well.
Thank you, John. Yes, the chat has been very, very busy. So we've had quite a few comments sharing some of the lived experiences from Lebanon, Zanzibar, and Pakistan. So thank you very much to the participants to share what you see on the ground. And they've really highlighted a lot of challenges that we hear very frequently, unfortunately. The same stories around the issues faced by persons with intellectual disabilities or the deaf community, or the specific issues of access to sexual and reproductive healthcare services. There's also a few questions that have popped up, so I'm going to pick a couple of them. One that I find really interesting is, how can we move from high-level global policies on disability equity in health to real implementation on the ground, and especially in crisis-affected and low-resource settings? Do you want me to share perhaps a couple more, or shall we start with this one?
It's a good question, and we'll gather a couple from the floor here. I think we have one over here.
Can you hear me? So I'm Martin from ICLC Physical Rehabilitation Program, and actually the last point that was raised there is very similar to what I was going to ask. One of the things we want to work on as well within the Red Cross movement is emergency preparedness and making sure that people with disabilities are included in emergency preparedness activities. So that's also my question for the panel, like what would you recommend in that regard? I mean, there is inclusive messaging, there is a preparation of kits and preparation of all sorts of, also for population movements and internally displaced and refugees and so on. But what would you recommend as the key actions and how to go about this process? So very similar to the question that was raised there. So thank you.
Thank you.
Thank you so much to all the speakers, and I'm really sorry to hear certain insensitive situations that they were in, and I extend my apologies for that. And I am also a person with multiple sclerosis from India, and I'm 26, and I often get when I get to the hospital when I apply and go to the hospital to get a disability card, I'm often told, "Oh, you look quite young." Of course I am. And and they comment on, "Oh, you look just fine." But then they don't really listen. And we don't have a healthcare system that actually listens and is not trained on being empathetic and kind. And while we have talked about a lot of things today on the panel, I would like to bring attention to invisible disabilities, and that is not often spoken about and is not trusted even when we are speaking about it. this creates a difficulty in our day-to-day lives and also at our work and in the community. So just wanted to bring attention to that, and thank you.
Thank you. So our panelists, who would like to go first? Maybe Patience or Smitha or Joseph online. How to turn these big global plans into concrete action in real life, what we need to do in emergency situations, and how we can improve the treatment of persons with invisible disabilities. Any volunteers?
Yes.
Patients online has their
Unmute
hand
yourselves
up.
and go for it, yeah.
Yeah, sure. So thank you very much for your question. Based on experience, I can say for Ghana or Ghana Health Service, we don't have funding like we have funding for programming. But to move from policy implementation to the ground, it determines on the people that are leading this advocacy. It's not easy at times, but there are a lot of times a lot of sacrifice needs to come in. You have to come on board and then work directly with persons with disability, especially where the health service providers are. So it should be a very tight collaboration between the health service and then the organizations for persons with disability or the individuals that need the service to be done. So that when you sit in and work with them, you're able to get to whatever they need. Working with the Federation and then the Council for Ghana on persons with disability has been one of the greatest decisions that I think we took. It's actually guide us on how we need to tailor our interventions from the office to the ground. And it was based on that we were able to do some of the few things that we know. Sometimes we know it's very few, but we can go forward in a big way. But so as I mentioned, there should be partnership. They should engage people who deliver the service. Or if you are on the service side, engage people who are also this who engage with persons with disability, come together and put up a plan, and so that it can move from the high level to the community, and then we can all work to the same path. I don't know if I've answered you correctly, but thank you very much.
Thank you. Would you like to add anything here, Pearl?
It sounds really clearly how you spoke up, and you gave everything.
Thank you. Okay, Alessandra? No, good. I can see some hands in the online. Is that we can maybe take one or two more comments online? You just want to unmute yourself if you get your hand up.
The first hand is Mohammed. Mohammed, if you can unmute yourself, we'll look at that for you.
Okay, we don't seem to be managing there to hear, but let me say, just put your comments into you've got the online chat and put them into the Mentimeter. Those will be read and we'll take those away with us. So I think what I'm going to do is pass over now for closing remarks to Kaloyan Kamonev from the WHO Secretariat. He's the technical lead on disability, and it's going to give us all of the answers that we're looking for. Thank you.
Thank you, John, and I'll be very quick. I know that we are over time, but I just wanted to thank all the speakers, both here in the room and also online, for this event, and also all the participants here and online. I think that it was a very thoughtful and action-oriented event. And if I can summarize it just with one sentence, perhaps I would say that what we were discussing is that disability inclusion is not really an add-on to universal health coverage. It's really a measure of how we can achieve universal health coverage. And we heard from two groups of speakers, one that shared their lived experience, showing that the barriers across the whole health system for persons with disabilities continue, But then we also heard from partners and organizations that progress is possible, and we heard a lot of country examples that show that how this can be done and how we can achieve disability inclusive health systems. And I think this is really central to WHO's vision on health equity and also health system transformation, because we will never achieve universal health coverage or the Sustainable Development Goals if disability inclusion is not a core part of it. And I think this is why partnerships and collaborative approaches are so important. And we heard already from Angela, so we will not repeat, but the Disability Health Equity Network that WHO launched last year really brings this opportunity for collaborative work, collaborative leadership. And this session is just the fruit of such work through the network. So we encourage all of the members of the network to continue being engaged, and for those who are not yet members to join us in this endeavor. And perhaps just the last message on just to leave the session with I guess with a shared understanding that inclusive health systems are stronger health systems, and that progress towards universal health coverage is not measured just through coverage, but through equity as well, and participation of persons with disabilities. So thank you again for the participation. Thank you also, John, for moderating the session, and we look forward to continue working together on advancing health equity for persons with disabilities. Thank you.
And thank you, everybody in the room and everybody online. Thank you for your patience with all of the technical challenges we faced. But thank you also for being here and for wanting to make our healthcare systems more inclusive for persons with disabilities. Thank you.
Thank you very much for this opportunity. Bye.
Thanks. Goodbye. Anything left from me?
Thank you, Faith. No, I think we're all good.
Okay, thank you so much. It was good meeting you. Nice working with you. I appreciate everything. Bye.
Similar. Thank you. Have a
Yes.
good day.
But I will in mind, yes, but I'm sure that it's not set up, but I don't know the other colleagues, I don't know.
I will, anyway, I've sent that to you, and then I'll just go through the photos to pick out some of the better ones. Because they're not yeah, okay. Brilliant, thank you so much. Oh, you're welcome. It was really, really lovely and touching. Yeah, I'm sorry. Yeah, we weren't, because we confirmed that we could go 10 minutes over. We actually did it in under the time. Sorry for having to be the person that's the one.
No. And I saw the notes on time. Was it there long?
Little bit.
Sorry, I was like looking at my.
Yeah. I'm not manager. Are you going to follow up before?
No, perfect. Yeah, that's what I need to know that we need to close. Otherwise, when you are in your notes, you don't.
Exactly.
That was perfect.
Yeah. Well, I've got some meetings coming up. I've got because there's all this guideline stuff that's going on.
On the gender?
We've got a meeting with Kenya with Rwanda at 2 o'clock.
Yes, I
No,
remember
it's not 2 o'clock.
the name of the organization, but
3 o'clock. It looks like 2 o'clock on my UK calendar. At 3 o'clock, so
And
it's
how
just
is
over an hour.
the Zoom?
And then there's a long seminar. I think it is going alright. We have a couple of people that are quite active, and so what I think what my manager and then we quite budget and everything because I also coordinate teams a bit and I manage someone who can present to this. There's a video film which you see a lot of saying, so I kind of need to show that's there. Yeah. You're working on the numbers? Yeah, exactly. Absolutely. But I'll see you on. Are you coming on? Are you able to come on Thursday? Yeah. And another thing I was going to send you in a second details of that because my colleague are like, no.
Even in our organization, it's so I mean, we have been there forever.
They usually have
We
some
haven't
good
always pushed
like and it's really good that candidates should situate themselves with this agenda. Because I think like some of the rest of the group other things going on with a lot of technical process where then it's tracking. It's still also happening. Right, so she's saying implementation.
And towards myself actually, but there is gender has to be
Really?
Oh yeah. It doesn't do anything unless I mean, as a friend of like
Yeah, she'll go back to basically making that session easier. Yeah. Brilliant. I was already planning to do a little bit of it, but now I definitely will. Yeah.
we don't have space to
Yeah, please do it. Are we doing any photos? I'm from the USA.
yeah, originally from Italy.
Excellent.
After a while, I think
Just joining. Yeah, at 3. And then I've got a long meeting to do with our interaction with the Senegal, after that in French. And then I'm going to yeah. So I'll see you tomorrow. It's good. Who's thinking of the ICRC again? Yeah. So really fascinating. It's a really nice space to spend time. I'll check my zip code, but I think that's the best place. And it's really just outside the play, so. Do we come up here to speak, or do we come? I have the transfer door slide. Good luck with everything. And then are we going to sit here? Yes, we can sit here. And then do I just post now or do you want me
Bonjour. Non, pas du tout. Vous faites partie de la session précédente.
Ce n'est pas moi,
C'est pas pour vous préparer la prochaine session?
Ah non, non.
Ah d'accord. Ok. Ok. Bonjour, nice to meet you.
Kim, you
Kim. Okay, Dimitri, nice to meet you. I'm Romain. Ouais. Okay, wonderful. We hope to help you out with the Zoom meeting, is it?
Okay.
You want Zoom? Zoom, WebEx, Teams.
I don't see tomorrow.
Hello. It's Stefan, do you have a Zoom?
No Zoom.
Okay, no, there's no Zoom meeting. I think I will give you a USB key to be easier, I think. I give you a USB key.
Okay, that's great.
Bonjour. Cap de fin. Mon verre retour. Sinon, c'est moi qui prends le relais. Ah ouais, bah putain. Alors là, vous voyez le crack. Yeah, we just changed it.
I was only there for a year, like it was a high school exchange program, and then yeah.
C'est qu'il est passé. You're right.
Oui, non, il n'y a pas de Zoom. Et en fait, je crois que...
Ouais, je viens de me donner la clé et tout, c'est tout bon. Je charge juste le clicker. Ah non, il est là-bas. Ouais,
Thank you so much for doing this today. Yeah, it's careful notice that it's very nothing. Just have to keep question. Oh, the question about this is shared with all of us. Yeah. Okay, so it's basically about discussion and there are two interventions in terms of first one is the example what your perspective on the example of your country and and then this answer is the last one. And then the second question.
Now this one doesn't work in our opportunities. We have a problem with this one, so we can use the relationship because we just changed it. Set a new one.
That's great.
Yeah.
Oh, that's okay. They're trying to we start to just thank you. Alors, je de faire. Okay, as we have coffee chat, it's just you and me. So.
Parce qu'à ce point que je fais le stream. Sometimes the Mac doesn't work properly.
Hi, hello. Welcome.
Sure it works. Just have to allow, please.
Ouais, ouais, ça a l'air ouais. Après, je suis justement en train de vanter auprès de mon collègue tout le sens.
Hi.
Request visit the same, right? First, we have to present our case study.
Yes, it's like some sort of example.
3 minutes.
Yes.
Launch. It can be more than 2, like 4.
Yes. It can be.
And then one question answer, and then closing remarks, right?
Yes.
Okay, perfect. Send me this.
I will send. Unfortunately, wait.
No, it can be very hectic. Don't worry about it.
Do you know how I can change the settings of?
Yeah. So what? Picture of the poster.
It's like a weird color. Why is it weird? Oh, zoom out a little bit.
We can like sit and then
Yeah. I will just start first.
How have you been?
Good. Oh, a picture. Then let's maybe we can take a group picture all together. Just a second. Okay, we have to also invite our. We are missing someone.
Missing some?
We are missing 2 speakers.
Individual one then. Oh, okay.
Please do it.
Okay, great. Let me check you. Yeah, it helps. Zoom out is better, right? Closer up. Why is not really? Yeah.
Yeah. Is it better?
One step. One step.
It does.
We should take one here together.
Yes.
Excuse me. Did you help me take a picture? Thank you. Merci.
Yeah, it's better.
Yes, let's put together, right? It's too high.
Oh yeah.
Yeah.
It's too high.
Yeah.
Yeah.
One, two, three. One more picture with my phone. One, two, three. Okay.
Thank you. Thank you. John might send me the picture later. Yeah.
Cynthia, can you give me my pouch?
Your what?
The leather bag.
Yep.
Oh, hi. My name is Wendy.
I'm Adil.
Adil?
Yeah, I'm the Junior Doctor Network, the World Medical Association. Yeah.
Cool.
And what about you?
Um, I'm a psychotherapist and I'm with the Global Mental Health Action Network. Yeah. You guys are all doctors. And
Yeah.
yeah, I noticed that when I see the concept.
Yeah, yeah. World Medical.
Oh. No?
Oh,
wait.
You starting now? Or you?
I think we can wait for 2 more minutes because some people are on the way.
I had one question.
Yes.
Because I think I was a little confused. So the opening statement is the use of the slides.
Yes.
And then the other part is the question. Okay.
Okay, I think we can start. Hello, everyone. Welcome to the panel Health for All by All, the multi-stakeholder dialogue. My name is Kana Halaj-Kordic, and I'm here on behalf of the International Federation of Medical Student Associations, and it's indeed an honor to welcome you all here. It is important to highlight that universal health coverage is not something that can be achieved by only one actor alone. It's something that requires government, professionals, civil society, young people, and all the other stakeholders working together in order to ensure that at the end of the day, health systems are equitable, accountable, and responsive to the people that they serve. However, despite the work that we do and the progress that was made, there are still many, many people that are left behind because of various barriers, including income, geography, gender, and other social barriers. As well, unfortunately, many families that often face financial hardships where they have to choose between their access to healthcare and other essential needs. So this is why this conversation today really matters. UHC is not only a policy goal, it is a commitment towards equity, dignity, and justice. So today we will have opportunity not only to exchange the ideas from our panelists that are here with us, but also learn from another challenge ourselves, and also identify some of the practical steps what each one of us can take to achieve the UHC. And with that being said, it's indeed a pleasure to introduce our high-level panel that we have here. We are very pleased that we have voices from WMA Junior Doctors Network, WONCA, CSEM, parliamentarians, as well representatives of the member states, because this is exactly what universal health coverage demands, and this is collaboration across various sectors, across various professions and institutions. And with that being said, I'm going to introduce our panelists one by one. And after that, each one of them is going to give their opening statement, giving their perspectives and sharing their experiences in their work on UHC. I think we can start from left to the right. Here with us we have Dr. Kim Yu, a family physician leader, here representative of WHA Executive Committee, who currently also serves as WHA liaison to the World Health Organization. Dr. Yu, thank you so much for joining us today. Then we have Ms. Wendy Bank, here representing CSEM and civil society. She was announced as UNC champion last year and also serves as co-chair of the UHC working group of the Global Mental Health Action Network. Thank you so much for joining us as well. Next, we have Dr. Mer Mohamed Adil Rias, physician and representative of Junior Doctors Network, as well as health advocate, currently also studying his master's degree. Thank you so much for joining us as well. And then representatives of decision-making spaces, Mrs. Natalia Alvarez, here representing the National Health Council of Brazil. Thank you so much for joining us today. And last but not least, Dr. Zayana Hamid, Vice Chair of Parliamentarian Standing Committee from Tanzania, who will be sharing with us the parliamentarian perspective. Well, thank you so much for joining us here. We are indeed expecting a very fruitful discussion. And with that being said, I would like to open the floor to Dr. Kim Yu, who is going to share perspectives of family physicians on behalf of WHA.
Thank you so much. And I'm not sure, do I have a clicker to be able to do slides?
I'm going to...
or you're going to advance for me? Thank you so much. I'd like to thank the International Federation of Medical Students Associations for inviting the World Organization of Family Doctors to speak today. And we are a global network of over 500,000 family doctors in 140 countries committed to improving primary health care and global health worldwide. And it is especially meaningful when you know that today is actually World Family Doctor Day. So I can wish all of you happy World Family Doctor Day. Who of you has a family doctor? Anyone have a family doctor? One person in the room. You are all missing out. I hope that this will inspire you all to get a family doctor to improve your own personal health. So it is, this is our organization. You can see here all the different countries represented, all the different member organizations. Again, 140 countries and over 500,000 family doctors. And our day is World Family Doctor Day. And this year's theme is actually compassionate care in a digital world. And I think this theme really reminds us that while technology continues to transform healthcare, trust, compassion, and human connection remain at the heart of primary healthcare. Primary healthcare is the foundation of universal health coverage and global health security, and we know that without strong primary healthcare systems, we cannot achieve equity, resilience, or sustainability. And family physicians are really central to delivering the core values of primary healthcare, with these values that you can see here of accessibility, compassionate, continuous, comprehensive, coordinated, and contextualized community connection. As the front line of care, family doctors provide person-centered care across the life course, integrating treatment, rehab, mental health support, and chronic disease management. But it really is these strong primary care systems that reduce geographic financial and social barriers. And, now more than ever, we need high quality primary care. Can you imagine having someone that really knows you like the back of their hand? That's how many of my patients are to me. Literally, they walk in the door and I don't even need to switch the computer on. I already know every single thing that's happened in their lives, happened to their children and their grandparents. So, it's really having that close connection with your family doctor that can make a difference. So as you see here, evidence shows that countries with stronger PhD systems have lower mortality, better chronic disease outcomes, and higher vaccination rates, fewer hospitalization, more efficient use of resources. And we have evidence that shows if you follow up with a family doctor for more than 15 years, your survival improves by 30%. Who wouldn't want to live 30% more? Should be everybody in the room, right? And you can actually show that if you close that relationship, you stop seeing that family doctor, you lose that advantage. So it's really important. No medication has shown such a strong result. But we're not in the stock market. We don't do Bitcoin and all of that. Our results are about the health of the population. And so family doctors strengthen trust and resilience with communities. And during crises, they play a critical role in health literacy, vaccine confidence, and combating misinformation. So I'm going to share more as we go on, but I wanted to share these things. And, in terms of that human touch, making sure that we have the empathy, all of the things here, first contact, comprehensiveness, etc., really do improve and strengthen primary health. In terms of medical students, I wanted to say that we have to strengthen the future workforce. And, for preparedness and resilience, these are some of the things that we call for: investment in primary care as early warning, interoperable digital health systems, training and support for the workforce, and integration of continuity of care so that we can do better management of chronic disease that usually invariably increases after disasters. And when I think of medical students and pre-med students, to achieve universal health coverage really requires all of these sustained investments, not only in family medicine specialization, but recruitment and retention of family doctors, increasing medical student interest and exposure to family medicine early on, and having those multidisciplinary teams with our psychotherapists, nurses, everyone, physical therapists, everyone that's in there, pharmacists, to really work well together, having the digital tools and having those community-based health systems. And this is what I will close with, but I'll mention it here, that global health security is only as strong as primary healthcare and only as durable as the trust family doctors hold within their communities. And that by strengthening family doctors and primary healthcare, we strengthen universal health coverage for all. Thank you.
Thank you so much, Dr. Yu, for sharing your perspective and experiences and providing examples how primary healthcare indeed is a key when it comes to achieving universal health coverage. With that being said, we are going to proceed with our next panelist, Ms. Wendy Weng, who is going to share the perspectives from civil society.
Mm-hmm. So I'm a psychotherapist myself, and I'm the co-chair for the UHC working group at Global Mental Health Action Network. And I noticed for our event today, there's a lot of doctors and medical students. So I feel I'm trying to share some of my perspective from a mental health practitioner. And I think during the WHA, I have been really thinking about like how mental health is often treated as an afterthought. And yesterday I was actually having a really interesting conversation, and they asked me a question that shouldn't mental health be considered after people's other needs are fulfilled? And I find it very interesting because I understand why people think this way, right? Like why? Because mental health it is kind of invisible to most of the time. It's not like, our housing crisis or like, the food we put on our table or the healthcare access. But from my experience as a practitioner, I think mental health is actually very deeply connected with a lot of things. It affects how we study, how we work, and how we build relationship around us, and also how we ask for help. And even sometimes it involves how if we can trust institutions or even imagine the future for ourselves. So that's the reason why in our work we are trying to think more about early interventions and community-based support, and not waiting for people to reach out when they are already in a crisis. And so I want to share an example of what we are doing right now. I'm based in Shanghai, China, and there we are actually piloting a program in China and Cambodia's garment industry. And in the garment industry, there are a lot of female workers, and often they are not the ones that we're thinking about providing mental health support, right? So it is really difficult to get the gain the trust from the workers to let them, seek mental health resources. And it's because they were never introduced the language of mental health, and it is not something they trust because it is still a very stigmatized topic. So what we find from doing this project is that the management team at their factory, like from the like middle level or like top level management, their behavior or like their attitude toward a mental health project is actually act like a role model to the workers on the ground. Because only if they have an uh, open-minded discussion around mental health, then the workers started to kind of explore the option of, what kind of mental health support is available, and like, if I like to see if I need mental health support. So this is something we are working on right now. And this is not just in the factory, right? So when we are talking about mental health, it really in everywhere of every aspect of our life. And so I also want to talk about an interesting project we did. It's a pilot we did in a Chinese university campus. It was a peer counseling program, and it is actually not really successful because the students didn't really go to seek peer counseling support. So we were wondering why, and we started to talk more with the students and realized like they feel like, their peers might judge them, and the mental health, because it's a sensitive topic, they don't want to share so much of their personal information with their peer. So this is kind of a lesson that we learned. And but I don't see this as a failure, right? Like we have to really connect with the youth to understand what they can relate to, what they can engage with. And that's what I want to share today, because a lot of times the policies and the programs are looks very good on paper, and only when we are actually practicing it or like pilot program, we realize, how the young people are connecting and how they understand the program. And we can't just imagining, if this gonna work for them. We have to really have this open conversation and do the program within the community, within the school setting. Yeah. Thank you.
Thank you so much, Wendy, especially for highlighting the aspect of mental health, which often tends to be overlooked when we are talking about universal health coverage. Now we are going to proceed with Dr. Adil, the representative of Junior Doctors Network.
Thank you so much. Am I audible?
You are.
Okay, thank you. So I'm the representative of Junior Doctor Network, the World Medical Association. So I will go into a very clinical case that I discussed with my colleague. It's a not a real person, but a representative of case that comes from Pakistan. And I would present case that stress tests are UHC commitments at the point of delivery care, especially as a physician working in psychiatric department. So a patient named Leena, who is 26 and transgender woman, presented in ED in Pakistan within the span of 4 months for 2 times with injuries from targeted violence, insecure housing, survival sex work, 18-month gender identity clinic waiting list, disengaged from primary healthcare services, clinically complex PTSD, chronic minority stress syndrome, acute safeguarding need. But whatever she received in a healthcare system in a low middle income country and a conservative society like Pakistan was only wound management and discharge and was only sent back to the system that was generating that harm towards that. So why we are discussing that case in such a multilateral platform like WHA79? Because most of the time, WHO has constitutions that have been adopted by member states, and they are voluntarily they agreed to follow those set of rules. For example, WHO constitution and foundational principles that mandates health as a right without distinction, and WHA79, of course, is also deliberating half a mile away from WHO's 14th General Program of Work, which centers equity, universal access, and leaving no one behind as operational, not aspirational targets, especially when it comes to the delivery of healthcare for the minority people. And tomorrow, WHA is also convening on the health and care workforce and WHO Health and Care Workforce Support Program. And they will acknowledge, although they have acknowledged critical gaps in community-facing and multidisciplinary roles when it comes to delivering the healthcare services towards the minority people. But these things are only, in a way, these things are only words when they are not implemented by member states, and especially member states are not willing to take this as seriously for their minority people. So as one of the core objective for this panel discussion was to look forward to 2027 UN high-level meeting on UHC. So one of the things that I do want to highlight is this sort of issues that comes from exposes the data disaggregation, on a macro level picture. For example, 2023 UN SDG Summit Progress Report on SDG 3.8 flagged that most national UHC service engaged indices remain too aggregated to detect these sort of, exclusion at population subgroup level. This patient would have not even appeared on any national UHC data set that is provided by WHO or UN departments on economic survey. So I think this is not just as a coverage failure, but it also is a data architecture failure that we cannot see, that we cannot measure. So I do want to call upon the member states as a physician, so they can commit to disaggregated UHC monitoring framework, and with national legislation that creates enforceable entitlements, not just pragmatic targeters. And it's just not empty words that you can sit in Palais and then they can talk about these things and adopt another document when these things are not being translated for the service delivery for the patients. Thank you so much.
Thank you so much, Adil, for your intervention. We have heard from the civil society, we have heard from the practitioners that are working at the forefront of the healthcare system. And now we're going to proceed with representatives of policymakers and decision makers. So I'm going to give the floor to Mrs. Natalia from National Health Council of Brazil.
Thank you. Good afternoon, everyone. I would like to start first thanking the organizers for this kind invitation and also our other panelists and the people here present. To talk a little about universal health coverage, I would first like to make the link between universal health coverage and universal public health systems. The Brazilian unified health system is guaranteed by law, and the right to health is guaranteed by the Constitution. But there are countries that have health in their laws and have the right to health in their constitutions. But even so, they do not guarantee universality. And one of the main reasons is because they do not have universal, participative, and public health systems. Brazil's health system was built underneath the pillars of universality, integrality, and equity. One of its main principles is social participation. And this is a key to ensure universal health coverage everywhere. Because to build anything for people, for all people, first we must listen to them. Social participation is also a core need to address important topics for universal health coverage, such as social determinants, because vulnerable people, marginalized people, are the ones who know what are the social aspects that make them more susceptible to diseases and disorders. So, to make sure we address what is important and needed for health, we must defend and guarantee social participation and universality, and also public health systems. Thank you very much.
Thank you so much. And now I'm going to give the floor to Dr. Hamid to share the parliamentarian perspective.
Thank you. Thank you for organizing this important panel and having us participate as health for all, by all, and we are part and parcel of it. My name is Dr. Ziana Hamid. I am a parliamentarian, also a vice chairperson of the Health Committee. I happen to also be a member of IPU, and this year I have learned so much about how global health really depends on the unity, or especially funding it and supporting countries at different spectrums to enable to serve its populations. And having these conversations really help us learn from different countries' perspectives, and also giving us an opportunity to share our own perspectives in the country. Tanzania has started implementing its act on universal healthcare coverage in January 2026. We are still in phase one, and until April, we have registered about 250,000 households in order to learn from the process. Until to the point we start, we don't have all the answers on how the entire country can afford it, and therefore phase like implementation is helping us looking at our funding sources and how we can allocate with equity in mind. We appreciate the approach because we started with the low income families. We also went to look at the elderly who are being looked after the government anyway, and the children. But the intention is to have everybody in Tanzania covered by the government health insurance, of course through employment, but we have a tremendous number of population who are not formally employed. However, we do have a moderate percentage that are earning their living. We just don't have any formal means of being able to cover them through their employment. So in February, we started utilizing the health benefits package. And our job as a health committee is to be able to look at the different benefits that are coming with it, especially the essential services, and being able to look at our own information. And I'll talk about data and systems towards the end, on how, as we start, we can plan to have equitable coverage. Now, equity here is the main focus of the entire fund anyway. However, we're having different sources of being able to finance it. And through this phase, we are already learning. We are getting from taxes, from special services, for example, mining, and our investments in transportation. However, we still need to innovate on what are the additional ways that we can secure to ensure we are providing healthcare coverage for all is a right, and for us as a country, it's a responsibility. Tanzania has emerged when it comes to different initiatives, especially in healthcare. And as you know, we are the champion now with our President Samia Suluhu Hassan for reducing maternal mortality health. This is giving us a motivation that with some well thought specific investment, we can overcome many of the other health outcomes that historically have been known for Africa. So we are utilizing this opportunity to ensure that when the population is covered and when we have the right information, we can support different programs, we can support different initiatives, and we can cover multiple populations based on their age or income levels, and based on national priorities, for example, reduction of disease burdens, and how we also look at the information we're getting from vertical programs and trying to change the mindset now to the universal healthcare at primary health level. And therefore, national priorities are right now to ensure access, to ensure financing, to ensure we have the systems. So as a country, we are looking now at a necessity to invest in digital health systems as part of universal healthcare coverage, which is not a traditional way of looking at it. But we at the Parliament have endorsed that without investing in digital health system, even the sustainability of universal healthcare coverage can be questioned, because in our developing systems, we oversee a lot of wastage. We oversee a lot of misallocation of funds, and we are capitalizing on a unified health information system in a country so that we can provide equitable resources, we can monitor coverage, we can monitor disease burdens. We believe we will be saving a lot from this investment. Research shows that for every dollar spent, $3 is saved. The kind of funds that will ensure coverage of additional population as we roll it out on phases. So as a health committee, we do have multiple priorities in the sector, but universal healthcare coverage has happened to be the first, and everything else will fall on it, because primary healthcare will thrive, and with that, prevention will excel. With that, the disease burden will be lowered, and even chronic diseases and other special care interventions will be well managed. We are sort of doing all that at the same time. In fact, the budget that we just passed 2 weeks ago mandated that universal healthcare coverage plan has to detail how national health information system will thrive parallelly. And with that, we believe even the issue of equitable healthcare, when it comes to coverage, workforce, even materials, dispersions of services, will be able to be tackled in a straightforward manner. So I believe in a year from now, we'll be finalizing phase 2. And the third phase will be now with the employed population. We are still working with informally and underemployed population, and learning the funds, the different fund sources that we are aiming at is a country that is also finding additional income opportunities. Mining remains to be the most prominent one, but recently there has been a discussion that spurred the population anger, but I'm sure it can be revisited on how we can utilize electronic remittances nationally to have a small contribution into universal healthcare coverage. With that, I believe we are on the right track in the beginning, and we will be taking ideas from how other countries succeed and how we can remain at capitalizing primary healthcare as a backbone of the entire health sector. Thank you.
Thank you so much, Dr. Hamid, for sharing the progress of Tanzania, and wishing you all the best as you will be implementing the plan.
Thank you.
For our next question, we're going to proceed with the rest of the panel. And my next question is directed both to you, Dr. Hamid, and to Natalia as representatives of countries here. So to ensure that UHC is indeed by all, from your perspective and your experience, what are specific legislative frameworks that we can implement to move beyond political promises and create legally binding oversight for health equity and social determinants like housing and income?
Okay, do you want me to take that first? So when a country is implementing an act, it becomes easy to look at in the beginning that that's insured, right? But when we don't have proper guidelines or instrumentation for implementation, it is still a challenge. And I'm looking at the financial capacity of the country to implement the act. I'm looking at the workforce capacity. We have a dedicated workforce that we're working hand in hand through Ministry of Health and other educational sector, that you can see the intention to improve is there, but capacity to deliver is really questionable in most of our settings. Even understanding the outcomes or the main key indicators that can put us from one point to another can require a lot of capacity building at an implementation level. At the same time, where this workforce is needed elsewhere to look at the large population that it's serving. So I usually urge a lot of support when it comes to capacity building, training, and retraining those whom we already have in the workforce, because we are transforming from traditional setup of healthcare delivery to now should be modern ways of minimizing pressure in the healthcare sector, so that if we're talking of primary healthcare, it's adequately done. And that requires several layers of trying to map it from the national level to mid and to the grassroots level on having the common objectives and common agenda when it comes to improving health outcomes and what are the specific health outcomes, monitoring the workforce on how we distribute them equitably. We are having some other places that have minimal access compared to other and more disease burdens compared to other. But how do we test our health systems when it comes to emergency preparedness, so to speak? And we have seen how much our systems have been tested during different emergencies like pandemics. Capacity to me is everything. We can have the funds and we can have the policy instruments, but we are failing to navigate it from national level to grassroots level where impact actually does happen.
Thank you so much, Dr. Hamid. And I think we can definitely agree as the point that you realized that there are a lot of challenges when it comes to and gaps between what is being specified in the legal frameworks and how at the end of the day they are being implemented, or how the workforce is capacitated and empowered to implement them. Now I'm going to give the floor to Natalia. Brazil has indeed championed the UHC, especially in context of the resolution that was led in 2024. So the same question as for Dr. Hamid from your perspective.
In Brazil, we have a good and strong experience having health defended by laws and the constitution. We have a law 8080 that guarantees as principles of the health system universality, integrality, and equity. And we also have law 8142 that guarantees social participation in the form of health conferences and the National Health Council that is it's formed by 50% national health system users, 25% health professionals, and 25% managers from the ministry. And that provides legal guarantees to defend both universality and social participation, even when we have exchange of governments and when we have unstable geopolitical times like we have right now. And that also gives us legal protection to defend it and to ask for it and to demand it. And that is translated, for example, in lawsuits for healthcare, especially for medicines that are very common in Brazil. And that is also a right. People have the right to go to court and ask for the help if they're not getting it, because it's defended by law that we have the right to universality. We have the right to integrality. But I think what makes us different from many countries that also have laws on health and also have health, right to health in their constitution is that we have social participation established as well, because that makes us stronger, that makes us care better for vulnerable populations, that makes us listen to them and put them in decision making spaces and priority definition spaces. And also our system laws and the creation of the unified health system as well was fought by people. There was a strong participation of civil society, and the national health system was created in a national health conference. So it was created by the people for the people, and I think that's what makes us stand out in the international scene. Thank you very much.
Thank you so much. Your quote, by the people, for the people, I think is definitely something that we can take away from this discussion. We have heard how things work when it comes to legal frameworks, when it comes to governance, but now we are gonna focus on a perspective of the ones who are working in the system itself. So going back to Dr. Yu. You are a primary care physician. So from your perspective, as WHO and member states work to strengthen universal health coverage and global health security, how can health system better invest in family doctors as the trusted frontline of primary healthcare, not only in context of prevention and continuity of care, but also for emergency preparedness, chronic disease management, and community resilience?
I think that what's important is to realize that a system is only as good as this infrastructure and the number of people that are in it. If you have built a structure and a system with primary care and you think that you have access, but you actually don't have access, that doesn't help you. So we need to ensure that the foundation and infrastructure of primary healthcare ensures that you have access, that you also have coordinated care between all the different parts of the healthcare system to ensure that no one gets left behind. We know that primary healthcare is the foundation of universal health coverage, and you've heard that through many of us who have spoken about that, and that primary healthcare improves equity and access, and that we can deliver better health at lower cost. But many infrastructures are set up to incentivize hospital-led systems to do the work. And so you may have a family doctor who is able to see a diabetic patient who also has hypertension, depression, obesity, and a sprained ankle, and take care of that one patient in one visit, versus having that same patient being funneled through 5 different specialty in the hospital system. So we need to ensure that primary care is really elevated in a way to ensure that they are not seen as just the stepchild, but that we are really part and parcel of how to provide universal health coverage for the majority of patients who need the care. And I think that's when you really see the trust that patients have with their family doctors, then you realize that you can move the needle when it comes to preventive care and then long-term chronic care management. So we want to really ensure that when you're trying to build an infrastructure of universal health coverage, that you really invest in the primary care workforce. That's why I mentioned earlier the importance of ensuring that you have a majority of your physicians going into primary care. Now, when I will tell you, when I graduated from King's College London. I'm originally from England. I went to medical school in England. And when I was graduating from med school, the physicians in England actually the family doctors were paid more than the surgeons. You would never have that happen in most other countries. But because of that, more people went into primary care than into surgery. And we had the best and brightest going into family medicine. And it shows, right? It shows when the infrastructure is built in that way and incentivizes. Even in certain countries now where they're moving to value-based care. Have you heard of value-based care? Where, you know, they're trying to contain the cost of better care, lower cost, but better experience for the patient and also the clinicians that are providing the care, the quadruple, quintuple aim, right, of increasing health equity and all the things that we want. Well, if you're actually able to incentivize and say to a group of carers, a practice, if you take care of your patients really well, you decrease their blood pressure, you know, and you decrease their A1Cs and you help them with their depression, right? We're able to actually fund that and give you more money to be able to pay for a social worker or community health worker or someone that can help you, a nurse, an extra nurse in your clinic that will be able to call patients to make sure that they come in for their care. This has transformed practices and primary care around the world that are moving in that direction. So we need to build systems and infrastructure that support primary care and family medicine in a way that makes sense.
Thank you so much, Dr. Yu. Multiple times during this panel, there was a point raised about the capacitation of healthcare workforce. I'm also reflecting on that a lot because I'm a final year medical student and I'll be stepping into a role probably of primary care physician in less than 6 months. And there is evident that there are certain gaps when it comes to our training and how we can, as future healthcare professionals, address UHC. And with that being said, we're going to go to Adil. Adil, you're a junior doctor. So from a frontline practice standpoint, what are, from your perspective, the primary regulatory or educational barriers currently preventing young junior doctors from effectively addressing social determinants in their daily work, and how we can reform professional training to better support education related to UHC?
Of course. Thank you so much for this very important question. I think most of the time our curriculum does focus on treating diseases rather than understanding why those things happen in the very first place. And I think the world is moving fast now. From social, we have moved to commercial, now to digital determinants of health. So it's just a very complicated space we are in. So not to make it overly complex as it is, I have come up with the three basics structural failure that we need to address in order to move forward with the better outcomes. First is I think we need to address curriculum gaps. Medical education curriculum was still designed somewhere for the needs of 20th century. It does not talk about the needs of 21st century human. So I think undergraduate and postgraduate training frameworks needs to understand and work in a way that are designed for social screening, welfare need assessment, or referral to housing, employment, or community support services that is related to social and commercial determinants of health that are affecting the healthcare outcomes. If it is assessed, it isn't prioritized. And right now, junior doctors are graduating clinically competent, but unfortunately, structurally unprepared. They're just being given the space to talk to a patient, but they don't have the resources to actually address those issues that are causing those things in the very first place. Second, I think is broken workflows. Validated social screening tool exist, but they are not embedded into clinical ward documentation, hospital electronic records, or discharge planning processes. Social data is neither collected nor coded systemically. So when there is no data for these subpopulations, or specifically for this section of where I talked about queer population coming from as a specific example, it does not get talked about in a larger setting with maybe health system planning or maybe even in the health policy planning for the country. And those resources are never allocated towards them. Third, I think regulatory silence, postgraduate training, assessment, and specialty college curricula do not hold doctors or training program accountable for competency in addressing social determinants. Usually your post-graduation exam is designed in a way you just go diagnose the disease, talk about that disease, what is etiology and everything, but it does not talk about epidemiology and the complex relationship with social determinants of health. So I think the reform levels are, I think it's clear as we build towards the 2027 UN high-level meeting for UHC, workforce training must be treated as a legislative accountability issue rather than a clinical training issue, because a doctor who can identify poverty but has no system to act on it, on its delivering universal health coverage, they are just documenting the system failure. They are not able to communicate, or they are not able to deliver better healthcare outcome for the patient. Thank you.
Thank you so much, Adil. You also made a really good introduction to my next question. So next year we have high-level meeting on UHC. Multiple processes from various stakeholders have already started, and even some of our panelists are actively engaged in them. So I'm gonna go back to Wendy, here representing perspective of civil society. So as we look towards the 2027 high-level meeting on UHC, what successful mechanism have you seen that move this engagement of civil society and young people from being, let's say, tokenistic to meaningful partnership in decision-making processes?
Thank you for the question. And I actually think it's really important to talk about tokenism in this kind of the current situation, because it can happen very easily. And sometimes with good intention, it could still happen. And I have to be honest, I don't have a perfect answer for this. And I think a lot of the organizations are still learning about how to avoid this happen. And I think our challenge right now is that the policy space often uses languages and structures, and also sometimes timelines that are difficult for younger people to meaningfully engage with. So sometimes I think younger people are invited to this discussion, but they're not given the correct tools or context or the kind of like ongoing support in this process to participate in the process like very confidently. And I think for myself, as example, this is my second time at the WHA, and I think the first year I was here, I was really just trying to figure out what everyone's talking about. And so this year, I think I could really trying to understand and listening more about, the policy aspect and the advocacy side, like how we achieve this, like health for all. Um, so I think a lot of time it does have this kind of barrier for younger people to engage with the policy. And I think meaningful engagement start with, much earlier than like putting someone, maybe on the panel and or inviting them for like a consultation. And I actually heard, I think, a really good example of kind of avoiding the tokenism and to also engage with young people. And I was speaking with the members from the WHO Youth Council, and they were talking about how they are able to have the opportunity to share a concept note every few months to directly connect with the Director General at the WHO, Dr. Tedros, and it actually have a real impact on the policy later put out. So I think this is really powerful, not only systematically, but because there was a visible connection between the youth voice and the actual decision-making process. So I think this is part of the strategy we could try to implement when we are thinking about to engage youth more intentionally, and also to, I think, more relatable to the people who are not familiar with the field. Yeah, thank you.
Thank you so much, Wendy. We are almost coming to the end of this panel, and before we proceed with the final round of like questions and take-home messages from our panelists, I would also like to open the floor to the audience if you maybe have any questions or interventions. Oh, you can come up. Yes.
Thank you very much for the amazing session and panels. I was really enjoying it, like listening to different perspectives by each. So my name is Yu Oda. I'm a medical student from Japan and representing the IMSA, International Federation of Medical Student Association with Ghana. And I'd like to ask to Dr. Honnet about that you mentioned that many people are working without being legally registered in Tanzania. And
Many people are working. Can you please repeat?
yeah, sure. You mentioned that many people are working without being legally registered in Tanzania. You mentioned like informally. You mentioned.
No, maybe. Can you explain what I was?
Yeah, sure. Like I was wondering, like in Tanzania, what strategies are going to be used to achieve universal health coverage, while also including such people who is working.
Oh, okay. In informal employment. Okay. Yeah, but not illegal. So let us. Yeah. Mm-hmm.
What kind of strategy do you think we can approach more to those populations?
Okay. It's still a homework to the health sector on how best we can include everyone. However, we acknowledge the large sector, especially of the youth that are self-employed or informally employed, daily trade, and there's so much inconsistency of the type of trade anyone can be engaged in such a way it's limiting the government to involve them in the normal taxation schemes or to put them under employment-based health insurance, for example. So not that there has been a strategy on how best to involve and incorporate them, but we are trying to understand them by this first phase of underemployed or low income families, because in that we are working with them to gather more information on how they sustain themselves, how they sustain their health expenditures, and how best can we put them in the formal streams of ensuring they are participating in the universal healthcare coverage plan. I can easily say those that are employed by the government or private sector, that's not a big homework, but it is these that are documented to be unemployed, but we understand they purchase, they in some of their services there are some tax rooms that are involved, and that is when the discussion of electronic remittances come up, because in this part of the population, you can study how their phone numbers are involved in large transactions on daily basis, such that probably they could be, some of them, earning more than the formally employed population. So because we are in the exploratory phase, that's an opportunity to be able to include them, but there hasn't been a clear-cut answer on how best we will be able to include them in the participation of the coverage. If they are documented by the health authorities that they are unemployed and therefore at this point they are eligible, but we are trying to sector them. Are they self-employed? Are they merchants? Are they business? At what levels? It's not an easy question to give you a straight answer. But you also talked about the foreign population that we have. As far as I understand, they come through employment-based mechanisms. We do not have apart from the refugees, we do not have simply a sector of foreigners who come and live without any formal engagement. I would not say we are a country that is providing education, so we don't have a significant number of foreign students, but we have foreign workers. So they came through employment mechanism. And when there is an employment, that means it can be employment based. But as far as they are foreign, they're not employed, they're not studying, they're not refugees, I don't see a formal category to put them so that we can institutionalize them into the healthcare coverage at this point. But maybe that is something that we should also be able to consider in the future. No worries. Thank you. Thank you.
Thank you so much, Dr. Hamid. Anyone else from the panelists that would like to add something to that question?
Yeah, I think it's a very, very good question because when you think of universal health coverage, we always want to believe that everyone should have access and everyone should be able to be covered, right? Health for all, not just health for some or health for the privileged or those that have insurance. And so when you're building a system and a structure, it's important to be able to consider every single human, every single person. And I've seen this happen, where I live in California, and aside from all the other things that are happening in that country that I live in, there are rules that were put in place to try and protect those who are refugees. Unfortunately, with things the way they are, those rules and protections have gone away. And so now we have individuals who fear coming into the clinic. So what do? We've seen certain health centers that do take care of refugees and those who are uninsured or underinsured. And they've seen drops of, 50, 60%, right? The number of people coming to their doors because they're fearful of being deported or put in jail. And so we've had to really pivot and say, well, we're going to care for these patients no matter what. How can we bring care to them? So we were doing more telehealth, we're doing more visits after hours. We're trying to provide safe spaces for our patients to be able to come and to provide healthcare for free because that's all we can do right now. But I think that this is something that I wish there were more rules and regulations in place to protect those who are the most vulnerable in our communities.
Thank you so much, Dr. Yu. Any other questions from the floor? Yes.
My question is related to health sovereignty, because we have seen a lot of countries in Africa and South America doing like agreements with another countries, like United States especially. And I'm thinking, how can we achieve universal health coverage if we have so many different interests to set priorities? How can we give health for all if you have like financial priorities that are not set by the people? This question is, how can we handle this? How can we try to improve another options to these countries in South America and Africa to achieve health coverage in universal health systems too? Because the situation now is completely opposite nowadays in a sense. So the question is for all the panelists, but especially for Dr. Hamid.
Yeah, thank you very much. I would answer from the context of my country what makes health agenda become a priority. It really is coming from our country as an ideology. Health and education has always been our political system from country of peasants in what's that in English? Communalism. It's part of our values as a country. When you can take care of your people, and health education becomes the first protection, social protection. So I know it's different from other countries that are capitalist in their nature. I lived in the United States for several years, where I look at the population that is not insured in any way, and it bothers my head at sometimes, but I came to understand it's the country's ideologies, and it does work in different ways. It doesn't have to be one way. So in Tanzania, as a socialist country, healthcare is naturally a right. Can we afford it? That's a different question. How well are we doing in the process? That is up to us to improve and learn from other countries. Um, but I also wanted to add, when we discussed about how we reach into the different diversified populations that are not covered, recently we have also included in the formal systems utilizing the community healthcare workers. And these have become an important bridge between the government and the civil society, because it happens civil society works with community health workers, and us through primary healthcare, we work with community health workers. So they are the most rich workforce when it comes to how we can connect it all together to a person in the community. They know the suffering households, they know the homeless, they know the different population that are not getting this type of services. In the government of Zanzibar, which is also government in Tanzania, they are now going to be paid by the government to support the national health system in navigation, in bringing access and informing on different investment. They sit on the board to listen to the budget and also advise on the priorities. I think community health workforce can help a lot in obtaining universality, because it is this group that even doesn't have any priority other than ensuring the community is healthy. And how can we make it formal? That can be a different approach from country to country. How can we fund them? Because in many countries they are considered volunteers of healthcare sector, but not actually the part and parcel of supporting universal healthcare coverage and primary healthcare, especially. So I am also a student of policies. It's not my area, but I am learning that throughout history, different things have shaped countries and population interest. And through political engagement, you are coming to see how different initiatives can create an impact and people can feel the impact. They can give you examples of how we used to stand long lines to see a doctor in a day, and how now in the community healthcare, even in rural areas, they will be done with service in the first 2 or 3 hours of getting there. So these are specific examples. Once you engage with the community and you involve the community healthcare workers, you are coming to see the impact that is creating and that is being appreciated. And that is also in motivating us as politicians to put more budgets in getting additional improvements and how we can close these gaps. And as I said earlier, let us not forget the role of technology. So much that is being invested here can become impossible if we cannot monitor it at the time that is happening. We can allocate huge budgets, believing it's escalating down to the community level, but we are failing to have a bird's eye view on how it is being implemented, how the workforce is on the front, how the population is being served, what is the disease burden, and what are the impact or output indicators that we can tell the community that there is this improvement. So there's still work to be done, but I believe for Tanzania, we are heading in the right direction.
Thank you so much. And I saw one more hand raised.
talking about universal health coverage, the process of designing it must also be just as universal as the World South. So I think that means that we have a geographical balance and gender balance and also a generational balance in the rooms that the decisions are made. Because I believe our policies will reflect the political privilege rather than the needs of the many, if the people that most impact are missing from the table. So my question is, what concrete steps are the member states and civil society organizations willing to take to make spaces like these more inclusive and accessible so that UHC is not universal only in its name, but also universal in practice?
Do you have a specific panelist that you would like to address the question, or maybe if we have a volunteer from the panel? Okay.
Thank you very much for your question. I would like to make a few statements about how we handle the representativeness in Brazil. In our National Health Council, we have a very diverse group of counselors. They're as you may know, Brazil is the size of a continent. So our cities are very diverse within themselves. So we have representativeness from geographical, from the cities, from the municipalities. We have gender balance, we have race. We have counselors that are people with disabilities, families of people with disabilities as well. We have people with rare diseases that are also sometimes neglected even when people make policies for them. As an example, how we can move forward here at the WHA with that matter, I would like to bring the example of our delegation for this assembly, for the 79th assembly. We brought a big delegation of civil society this time with us from the council. We brought together around 15 counselors of civil society that are representative, that are different in where they come from in Brazil, their gender, their race. And another example is that we have a visit of the international delegation that is moving forward with the resolution of social participation, resolution 77.2 from WHA 77. They all came to Brazil and they could see our process, how it is, how diverse is our crowd, how in our conference we can gather thousands of people and have their LGBTQ IA people. We have people with disabilities. We want everyone to be there as we give our inputs to policies and how people and to help these people influence the future of health and the policies. And that is very important for us. This experience of the visit of the delegation to Brazil is also cited in the Director General's report on the progress of the resolution. So we're really proud of the strategies we're using to defend the representativeness in spaces like this, in power spaces, because not everyone can be here and we cannot forget those people. And if they cannot come, we bring the others to see us and to see them and make them heard. Thank you.
Thank you so much, Natalia, and thank you so much to everyone in the audience who was engaging with the questions. Oh, would you like to add something?
Same question. Yeah, I think that's a very important question because it takes us from objectives that we have at global level, and for this specific one, universal healthcare coverage, but how do we practicalize it? I think that was the base of it. How can we not, instead of discussing about it or put it in a policy, put it in frameworks, how can we make sure it actually is implemented? And that's a challenge we all go back home with, because we are going at the ground level to see everything that the global wants our healthy populations to have? What are the challenges in navigating through the process? So I have been looking at health system as integrated, and how those policies go down into implementation differ from country to country. Some of our governments are still very centralized, and gradually we are putting more resources to decentralization. So equipping local governments is very important here, to be able to navigate through the challenges, capacity, and resources. But there are also locally grown resources that we need to look at, and helping the local governments maintain these priorities, because we are working with different regions that have different priorities. How can we have common health priorities for every region is a challenge, especially if the resources are being locally collected. So we need to understand the different funding mechanisms that we have internally and externally, and support implementation of those frameworks at a local level. And you can see authorities have been experienced over years doing the same things, but integration of knowledge from the global level to the grassroots implementers is very important to enable achieving these objectives. Having champions that are speaking the same language and monitoring the same indicators is also very valuable. And I believe us as parliamentarians, we do get opportunities to question on a spectrum on how these diversities show up on a very single item, healthcare access or coverage, and be able to re-communicate that information and monitor it on a different time, but still monitor the same information. Do we have funds to or resources to put in these objectives and initiatives? And do we have capacity to monitor and navigate? Do we have capacity to improve the workforce in order to emerge with the objectives that we want to foresee in a near and long term?
Thank you so much, Dr. Hamid. In FMSA, we often say the same, and that is to think global, but when it comes to implementing it local, it's also something that we need to adapt. And we entered the final 5 minutes of this panel. So I'm just going to kindly ask our panelists to deliver their closing remarks. As mentioned, we are on the road to the high-level meeting of 2027. So our closing remarks will be reflecting on actionable recommendations that should bridge the gaps that we have discussed today, from today to 2027, so we can achieve the goals that we have set for that. Dr. Yu, would you like to start?
I think I've mentioned most of these already, but really truly strengthening primary care. I cannot stress enough that without primary care, you do not have universal health coverage. It is not, just simply not possible. So we really need to strengthen the primary care workforce. You need to ensure that you have family doctors as part of your teams if possible. I know that many regions may not have enough access to family doctors, but we hope that we'll be able to share and increase the numbers of those who are trained in medical school to choose family medicine and primary care to be able to deliver on universal health coverage.
Thank you so much. Wendy?
And I think from my perspective, I believe UHC really needs us to achieve UHC. It really needs us to help more people understand the health policy, and so people can reach them and trust the system, and also participating in shaping the policies. And again, I want to emphasize that we have to treat mental health as something um, preventative, and to have in early intervention instead of always treating as an afterthought, or taking the reactive approach. So I think then we could achieve the health for all. Thank you.
Thank you so much.
Thank you so much. So I would just like to end this my discussion as I talked about data disaggregation and the disaggregate the training modules for our clinical training. So I believe it needs to be designed in a way that it can protect both physicians and the healthcare outcomes for the patient. So it can be more deliverable and accessible towards the more at primary healthcare level, as they mentioned. Without primary healthcare level, there is no universal health coverage. So I think if we these sort of universal health coverage metrics cannot find the patient needs and cannot also are not meeting the healthcare professional demands in this setting, then what we have is not build a universal health coverage system. It's just a selective coverage with universal branding. So I think we need to talk more about that. Thank you.
Thank you so much.
I believe that to move on with this agenda, first, we need to ensure social participation. We need to ensure that we are listening to our people in our territories, in our countries, to see what they need and to see how to get their perspectives on how we can overcome local and national barriers and challenges for universal health coverage. Second thing, we need cooperation, collaboration, solidarity, so that we can overcome the global barriers. In order to move forward with this, I believe we need to share our experiences and perspectives from our communities, from civil societies, governments, just like we're doing here today in this panel. We need to unite ourselves with those who have a commitment to agenda. We must learn from each other's mistakes and from each other's successes. And to quote a famous Brazilian song, alone we can be strong, but together we can be invincible. You can count on Brazil for that cooperation, and thank you very much.
Thank you.
Thank you. Our way forward first will be to innovate on different mechanism of getting resources for covering healthcare coverage. Um, Financial resources is one, capitalizing on the information that we get, moving from knowledge and evidence to implementation and practicality. I believe we know already enough to be able to cover the population, but how can we make it practical? I was sharing with my colleagues that once it becomes official, we'll have a larger influx of disease population that we never saw before because there is access to care, and it is not to be ignored. It is to be for us to have preparedness in how we will tackle it. um, Another way forward that I had is to build local capacity to be able to utilize the resources adequately. And once that happens, we will be able to save on other aspects, the kind of funds that we really need to continue to cover more population. How can we improve implementation science? It is very important because these are new frameworks that are becoming the new norm, and navigating the healthcare workforce to become a culture of serving the population that otherwise would not be possible with our limited resources, and how we can, as a central government, work very closely with the local government to delegate some of these expenditures, have them run on their local capacities and needs, and be able to utilize the local funds that are being collected at a local government but otherwise will be allocated to other issues, put priority on universal healthcare coverage. I also wanted to call upon the philanthropy societies of the world to invest in capacity building for the low income countries, because as I said earlier, you can see the intent in there. When we do visitations at different facilities, you can see how they own the profession, but they are under limited capacity, under limited resources. And as we have seen, the funding wave has changed globally, which really impacts primary healthcare in most of our countries. But joining hands together in these occasions can help us um, come back and look at the low-hanging fruits that can help countries improve their workforce capacity that is really needed to serve this huge population. Thank you.
Thank you so much. I believe that one of the take-home messages that we can take from this panel is that if we want to indeed achieve universal health coverage is something that we have to work on all together, ensuring that we are all being accountable and that all stakeholders are meaningfully engaged. Because if we are really serious about it, then we also have to be serious about making it inclusive, equitable, and that it's responsive to the system that it serves. I would like to extend a huge thank you to our panelists for joining us today, for sharing their experiences and perspectives, as well to CSEM for securing this space, that there is a whole space dedicated to UHC. And last but not least, to all of you who recognize the importance of this topic and joined us today. So I hope that this session brought you some ideas, inspired you, and maybe also gave you some guidance for the future work. So let's continue to work towards universal health coverage that at the end of the day, there is health for all and that indeed it is created by all. Thank you so much for joining us today.
A group picture with everyone.
Yes.
So
Can we take a fast group picture with everyone?
Yes. Can we take a group picture?
They can come in the back.
Yeah, you can come in the back. Everyone come up and just, we can sit. Or you want us to sit and then it can be behind us? Stand?
Yeah.
Yeah, that might be helpful.
Yeah.
That'd be easier. You go. Oh, okay, yeah. Where's Anna? Should have Anna here.
Anna, please come.
Someone take the lead. Closer.
So can someone? You just have to.
Stop.
It's not working.
Go there. So say here.
Okay. I'm consequent.
So I'm watching. Okay, say here. You have to say here, otherwise we don't know where to. Okay.
UHC. Thank you.
Thank you. Thank you.
Thank you.
So much. I'll send it to the email.
Thank you so much for your comment.
Wendy, thank you so much for joining. Yeah, thank you for arranging everything. You're also
No, but now that I came here, this is like
so
it was also it's the same place. But I was in the garden because you start working like in Rama Forest.
But you know, actually, I'm glad that when I was there, that you called me before because I was sorry, I'm not lost.
Because we're so many second speakers. Yeah. Yeah. That's okay.
I am.
Yes, I'm speaking. Do you hear me? Yeah. Hi. You. See you. And I think we'll just like here and then having invite one. Yeah. Otherwise, you're gonna spend too long and have a little break. That's fine. Absolutely. Yeah, the middle of the session is fine.
All right. Welcome, everyone. We're going to start slowly this session together, inviting people to come in the room. I know there's food outside. There's nothing I can do against it. Um, you feel free to like bring, food in the room, if I can say. So lovely to have you all here for this session during this busy WHA. I'm so looking forward for this session. It's the first time we're doing this with so many different youth groups united around UHC. This idea came from our great partners, so I want to warmly thank them, Transform Health, who came with us with the idea of having, youth informal networking session to connect the dot between great youth-led initiative. So we are doing this event today with a lot of different youth group, and many of you are also in the room, so we want to hear from you. Today, this event is co-sponsoring by Transform Health, by CSEM for UHC 2030, which I represent, Rare Disease International, Incision, IPSF, International Pharmaceutical Student Federation, Blue Circle Diabetes Foundation, IFMSA, World Medical Association Junior Doctor Network, and the World World Health Organization, the World Youth Group. My name is Laura Philidor, and I'm the Advocacy and Communication Advisor for CSEM for UHC 2030, which stands for Civil Society Engagement Mechanism for UHC. I'll explain a bit later because you'll see a presentation for that. I also work for WHA Health, which is an NGO working also on UHC, but on a lot of different things. You must have seen them on global health architecture at the moment. They're a lot involved on the Lusaka agenda and also a lot on HIV, tuberculosis, and malaria. Yes, so I think we can start a bit this session together. So why are we here today? Next slide, please. Thank you. Also want to warmly thank specifically my colleague Cesar from Transform Health, who's been also co-leading this event and has been doing an amazing job trying to also gather everyone here today. So we will have this session. The aim of it is really to bring youth advocates together to network, connect, and make sure we're doing, collaboration around the great work that is doing. You might have seen that we talk a lot about social participation. We'll come to it also. And it was very important for us to have this youth conversation to make sure and illustrate our point on including everyone in the conversation. This session will also have for objective to raise awareness of youth-led initiative and innovation, and also then to share opportunities for further collaboration. So in our agenda today, next slide, please. Thank you. We'll have some welcome remarks from our dear colleague from Transform Health. I will set the scene on behalf of CSEM for UHC 2030, so explain a bit more about, you're all familiar with UHC, so we're not going through that, but the main priorities of, UHC in the next 2 years that are coming, and see how we can collaborate on that together. And then we'll have a panel session with an amazing group of panelists divided in 4 different sessions. So we have around 6 or 7 speakers to introduce what they are doing and they're working on as youth advocates. And then we'll have one of the most exciting part that will be the networking session. So really counting on you to be active during the session. Don't stay to ask any question. We're here to connect. So yeah, happy you all here in the room. We also have some participants joining online. So please, for those joining online, feel free to use the chat. We'll try to look at it as much as we can. And if you have any issue seeing, hearing what we're saying, feel free to flag this also. Yeah, so we're gonna start, and I want to warmly welcome my colleague here from Transform Health, and I'll try to pronounce the name right, Seka Putri Adriani, Indonesia representative of the Transform Health Youth Council. Please give her a warm applause.
Okay, so good afternoon, everyone, distinguished guests, speakers, partners, and also youth advocates and participants. So thank you, Laura, for the introduction. So I would like to introduce myself. My name is Sekar Putri Andriani, a member of the Transform Health Youth Council representing Indonesia. So it's been my pleasure to welcome you today's session, Youth Voices for Universal Health Coverage, a networking and learning sessions. And thank you all for being here today and for bringing your energy, perspectives, and also the commitment to advancing health equity and also the universal health coverage. And today's discussions actually comes at a critical moment for global health. Around the world, young people continue to face major challenges to their health and well-being, and millions of people still lack access to essential health services, and far too many continue to experience financial hardships when seeking care. And universal health coverage cannot become a reality if healthcare remains inaccessible or unaffordable for the people who need it the most. And at the same time, we are experiencing rapid digital transformation in health system. Like right now, we could see that digital health technologies are changing rapidly, and how people access to information, healthcare services, and also support. And these innovations have enormous potential to improve health access, strengthen healthcare systems, and also expand the access. But we must also ask who benefits from these digital transformations and who is still being left behind, and despite being highly engaged and in digital spaces and deeply affected by the health policies, young people and also marginalized populations remain underrepresented in health and also digital health decision making processes. And this is why meaningful youth engagement matters. Young people should not only be seen as beneficiaries of health system, but also as leaders, innovators, and also equal partners in co-creating more inclusive, people-centered, and also sustainable health systems. This is why all digital health systems must be developed with young people and also marginalized communities, and must work for them. We must ensure that no one is left behind, including the communities living in areas with poor connectivity or limited access to digital access. And today's session provides a platform for all, especially the youth and also youth-led organizations that are coming here today to connect, learn from one another, and share initiatives across different health areas and also from different global practices. And through this networking and learning session, we hope we could strengthen the collaboration, encourage shared learning, and also build partnerships, and also amplify the youth-led solution that can accelerate the progress toward the universal health coverage 2030. And so moving on, we're going to move to the mentee mentor session. So we would like to invite everyone here to participate in a short interactive sessions. Please write your name, organization, and also email and country. So yeah, the mentee mentor link are displayed here. So you can just scan the QR code here, and I really appreciate it because this will really help us, to gather all the perspective of the voices and also the experiences in the room today. Okay. Sorry? Oh, oh, okay, no network, unfortunately. Oh, there's Wi-Fi, sorry. Could we just share the Wi-Fi? Okay, okay. Maybe anyone else want to stand up and share your own perspectives? Okay, okay. We could see that. Is it okay if I could just ask someone? So maybe I would like to hear from Wendy. Is it right? I pronounce it. Your name, Wendy from China. Okay, okay. Okay. I'll ask to you. Okay. So what are your doing right now, or maybe your organizations towards achieving the universal health coverage 2030?
Actually, I'm from the Global Mental Health Action Network's UHC working group. So our working group is actually focused on the UHC 2030 and working toward the high-level meeting next year and advocating for the cause. Thank you.
Thank you so much, Wendy. Maybe next I would like to hear from other participants. Maybe from the Global Mental Health Action Network, Pradeep. Oh, okay. Oh, same. Sorry, sorry. Uh, Other than that, maybe from Sarah, the International Federation of Green Crescent. Sarah, okay. Hmm.
Yes, hello. I'm from the International Federation of Green Crescent. The federation is actually responsible for 70 countries around the world who are doing prevention recovery on addiction prevention and recovery. And yes, and we are right now more working on how addiction efforts on prevention and recovery should be also included through the universal health coverage in all countries.
Thank you so much. It's really interesting. Maybe we could just move to other participant. I think from Netherlands, Daphne Visser. Oh, okay. Sorry.
Hi everyone. My name is Daphne Visser. I don't think I'm a young person anymore. I'm 32 years old, but still very happy to be here. I'm from the Netherlands and I'm working for Liliane Fonds, and we are an organization that works mainly in Africa and Asian countries, specifically for children and young people with a disability. And I then work on sexual and reproductive health and rights. And so we're trying to make the health services that provide sexual and reproductive health more inclusive.
Thank you so much for your introduction. So we've heard from the mental health and sexual reproductive health, and also from the addiction prevention, and maybe other for next. Okay, one more. I think I'd like to ask So Hyun Yun from IPSF. Okay.
Hello, I'm Soyeon Yoon from South Korea. I'm as an IPSF student, International Pharmaceutical Students Federation, and we represent more than 600,000 students and recent graduates. So we advocate some various agendas, including UHC. So thank you.
Okay, thank you so much. Next, it's all very interesting. Maybe we could just proceed to the next session. It's gonna be the networking session. So, next, I'd like to maybe just before we're going to the next session, I would just like to, tell about the Transform Health a little bit. So, Transform Health is actually a global coalition of 215 organizations dedicated to achieving universal health coverage by 2030 by harnessing digital technology and the use of data. So we bring all partners here and networks together by leveraging our shared experience and also expertise to shape the policy agendas. So we also provide a space for youth, women, and other excluded and marginalized communities to engage on this issue of the digital transformation of health systems. So yeah, we believe that by strengthening the good governance and also involve all the communities, we could create and also shape the digital transformation more robust and more more better for everyone. And then for the next session, I'll introduce you again with the moderator. I'll give it to so we will start with a keynote presentation on youth leadership for universal health coverage, advancing equitable, sustainable, and people-centered health systems. And this will be led by Laura Philidor as the advocacy and communication advisors from WACI Health and CSEM for UHC 2030. So the time is yours, Laura, and give applause for her.
Thank you so much, Sika. I swear after you'll be done with me. But yeah, easier like this. Thank you so much. That is so exciting to see like we have so diverse and complementary youth group engaged in the conversation. So thank you very much for taking the time to be here today and looking forward to discuss even more about our next collaboration together. So this presentation is to set up the tone for this session and setting the scene on what's happening at the moment on UHC and give a few priorities we're working on to identify eventually the priorities you're interested in working in. Next slide, please. Thank you. So UHC 2030 and CSEM for UHC 2030 work together. UHC 2030 is the global multi-stakeholder platform to accelerate universal health coverage. So they work with multi-stakeholders, so they work with governments, with private sector, and with civil society. That's us. And civil society is a bit independent, and it's called CSEM for UHC 2030, Civil Society Engagement for UHC 2030. And our role is to ensure that UHC policy are equitable and inclusive. So concretely, we make sure that voices are including in decision-making in UHC. So we meet different and we connect with advocates around the world in different sectors, and we make sure their voice are heard the best we can. Membership is completely open to everyone. You have a QR code if you manage to connect to the Wi-Fi. There will be many QR codes along the way. But this one is to join our membership and keep updated about opportunities to engage into UHC. We have 1.7K individual over 130 countries. And yeah, you're welcome to join us as well. That would be great. Next slide, please. Thank you. So we'll go into the different priorities, but you here for WHA also, which is one of the priorities to act on UHC. So you'll see on this other QR code, we have a various page with a lot of different resources that you can access to. So statements, advocacy messages, and other resources. Feel free to explore that as meeting at the Palais or at side events to use this also in your advocacy if helpful. Next slide, please. So among the different priorities, I'll be quick on all of this thing, but you probably heard about social participation. Just for like hand raising, who is not familiar with social participation? Good. That's the first time I have no hands. Don't be shy. Great. Okay, so that's amazing. So social participation, yes, is really about empowering voices and communities in health decision-making processes. And if this is implemented, I mean, our work as CSEM would be almost done, right? So as you know, 2 years ago, a resolution, very important resolution, was adopted on social participation for health, UHC, and well-being. And in this resolution, member states agreed to commit and implement social participation, meaning voices to be included in health decision-making processes, but along the policy circle and consistently and meaningfully. You might have seen some processes as youth advocates. Sometimes you are brought at the end of the negotiation or when the resolution is almost adopted to talk about a certain type of decision making, just to, testify or deliver on your experience. That sometimes is the best case, but don't really maybe have a say in what's in the resolution or the decision. So that's very important process. This year is also very important because it's been 2 years. That means that WHO will report on progress on this resolution. It's a very short report and it's online. It's 600 words to state a bit on this progress of this resolution. So as civil society with diverse partners, including Save the Children, Global Health Council, Sphere, and CD Alliance, we work together to have a report to complement a bit this result. For WHA, we have preliminary results accessible on how this is going. Globally, the summary is that it's encouraging to have a resolution, but the implementation is still weak and consultation still ad hoc and not really sustainable on the long term and in a lot of countries. So yeah, we invite you to explore more about that also. We'll pass over to the next slide, please. Thank you. You might have seen also we have a UHC Day campaign, which is a campaign to really like every UHC advocates and to raise our voices. This year would be the 3rd year campaign on financial protection. We had a successful campaign last year with over 50 governments committed again to make progress toward UHC. So I had a quick session just to see about your views, but we already had this interactive part. So I think we good on that front. But if we move to the next slide. Thank you. So you can see some of the result here with 50 governments making major UHC commitments mentioned in a lot of countries and event also in a lot of countries. So that tells us that people also are interested in moving UHC agenda, which is good. And if we move to the next slide. Yes, so we also like welcoming your views later in the networking part on potentially like theme you would like to see. The first year was really about making sure that government was involved in UHC. With health, it's on the governments. And last year was a more alarming tone with unaffordable health cost. We speak of it. So from first consultation, we are probably going for an alarming tone also because we're not making as much progress as we would like on UHC. A billion of people face financial hardship trying to accessing health costs, and billions of them still fall into poverty because of that. So yeah, just to give a bit more energy in the room, just want to see quickly, stand up if you've been in this situation. Yeah, stand up if you ever been in the situation of choosing between healthcare and another basic need like education or food or other priorities. That's good. I'm happy to see that. Great. Please stand up if you haven't been worried by financial costs for health that might impact your daily life. No, you've been worried. Sorry. Thank you for the clarification. Good. And last question. Have you ever had to pay to get qualitative healthcare? Meaning you could have like access to healthcare maybe for free in your country, but if you want better and more accessible health, you have to pay for it. Yeah, yeah, that's yeah. So as you can see, yes, this theme is still very up to date, and it's concern us all, from close or from afar. So yes, there is still a lot of work to do, and let's work on this together. And next slide, please. Oh, yeah, that's done. Thank you. So to make sure that governments know about that and keep also translating commitment into action, one of the main thing of this campaign that will continue this year is to leverage lived experience. So basically, even from all the questions, I think most of you already have the contents for the health concert video. It's a 1-minute video you can do like everywhere and post on social media to stand, one of your experience or someone facing financial health costs or difficulty accessing health, or why it's important to ensure to that to everyone. We have some booth outside, the photo booth, but also a video booth, and we're happy to help with that too. I will, I think, conclude now with a last one, which is very important. But in 2 years, a bit less than 2 years, there will be the UN high-level meeting on 2027. So that's a really important point to rally on. And I would say from all the main, opportunities to engage here, the main dates to keep in our agenda is the UN multi-stakeholder hearing that will be happening in May, which is basically the time where civil society have a space to provide first contents for this resolution, and then it gets negotiated. So we have a huge role to play in there. Before the UN high-level meeting in September 2027, where hopefully the political declaration will be adopted. We have a tool to explore a bit more the progress in your country, which is called the Act for UHC reports. And you can basically explore that and see where your country is in terms of UHC progress to make sure we have solid political declaration coming out of the third political declaration negotiation. Thank you everyone for your attention here. We're here if you have any question, and I'm happy to give the floor to the next moderator of the session, Anna from IFMSA, who will be the successor from Kenna, who you might know.
Perfect. Thank you so much, Laura. So as we already heard so far, we know what are the problems in UHC and where youth comes from, but we want to hear from the youth, of course, and we have various youth organizations here with us. So we're going to have some short presentations on 4 topics. Next slide, please. Perfect, thank you so much. So the first one is on strengthening health systems for access and equity. The second one on integration and inclusion in UHC. The third one will be about youth leadership on AMR and global health challenges. And the fourth on the youth call to action, digital transformation and the future of UHC. Next slide. Perfect. So as you can see here, we have a lot of different youth organizations, a lot of different backgrounds, and they're going to present what other organizations are doing, how they work exactly on UHC, and how other youth can get engaged in their activities. So we have IPSF, Incision, Blue Circle Diabetes Foundation, VA Diabetes Strategic Committee, Rare Diseases International, the World Medical Association, JDN, and Transform Health, and I must say that is me. So we're going to start with the first presentation from IPSF, and Elizabeth Jones, who is the humanitarian coordinator, will do her presentation. Thank you.
Yeah, thank you so much, Anna. I'm just going to do a little short overview over what IPSF is doing in the realms of UHC, and then some maybe short reflections also in looking at the intersection of UHC and humanitarian work or humanitarian crises. So IPSF is actually focusing on universal health coverage this year and the next year because we're doing a global declaration on UHC this summer. We're already working on it, and have like input from our member organizations to then actually reflect what the national member states are doing or what the situation is. And yeah, we'll vote on it at our General Assembly. And then from autumn onwards, we'll be working on implementing this declaration. So then also leading up to the HLM, we'll be doing work on UHC to really prepare for it. And then we're also hosting a side event on UHC tomorrow. So if someone wants to see some more UHC, please feel free to register. And that will actually be leading up to a UHC Youth Summit we'll be doing in Thailand this summer, with our World Congress kind of. And we'll have the participants from the World Congress there. So like over 500 people kind of working in looking at policies for UHC, and we're hoping to just train them, engage them, motivate them to also become advocates for UHC and then bring that into their national countries to then hopefully, advocate there for UHC as well. Then, we can have the next slide. As I'm humanitarian coordinator, I just wanted to bring that topic in a bit as well, because I think we all kind of have a general agreement that we need accessibility and equity in UHC, but maybe some thoughts on that in humanitarian settings is that obviously if we already have weaknesses, those are just heightened in humanitarian crises. So we really can't think that in humanitarian crises anything is going to be better, but we have to kind of already work to get accessible and equitable healthcare in times of peace to then be prepared for times of crises. And even if we have organizations coming in like during times of crises, they can of course provide so much aid and help and humanitarian response to help the people on ground, but that's also not a sustainable long-term structure. So UHC is also still very, very relevant in the countries and would also be probably the way, like if we have chronic diseases, to actually have that integrated and be taken care of. Yes, so actually just wrapping that up, we really have to strengthen our health systems, even also in time of peace, to then be prepared for times of crises, to then continuously have equitable and accessible healthcare systems for everyone. Thank you.
Thank you, Elizabeth. You can sit over here on the table. Yeah. And please, the rest of the speakers, if you can come sit in the front so we don't miss time when you get up on the stage, you can sit here on the table. So you can come directly to the podium when it's time. But Rina, if you can come here since you're the next one. So Dr. Rina Santos Malilin from In-Season Philippines will be continuing the discussion on strengthening health systems for UHC.
The podium is as tall as me. I'm so sorry. Hello. Hello, everyone. Hi, and I'm speaking on behalf of Incision Global, actually, and Incision Philippines. So, can you go to the next slide? There. Okay. So I'm here to talk about shortly about global surgery and what Incision Global does. So when talking about global surgery, we are not talking about just surgery done by international teams from all across the globe. It's global surgery is a field within global health that focuses on improving health equity through access to safe, affordable surgical obstetric trauma and anesthesia care, or what we call SOTA care. Oh, sorry, not yet. Can you go to the slide before that, please? There. Before that. There. Okay. So 5 billion people, that's the number in 2015. So you could only imagine what it is now. 5 billion people around the world lack access to safe, timely, and affordable surgical care. That means millions of people with treated conditions are unable to receive care simply because healthcare systems cannot reach there in time. Next slide. Oh. Slide before that. Thank you. Incision is a youth-led global surgery network working across advocacy, research, and education to improve access to SOTA care worldwide. Next slide. So every possible global surgery advocate has probably heard of this phrase by Dr. Paul Farmer and Jim Yong Kim. Surgery is the neglected stepchild of universal health care. Next slide, please. And it's neglected because of some myths. So the ones that are in the blue, those are myths. Uh, s- Surgery is not, it's neglected because many policy makers believe that investing on surgery is not cost effective. But in fact, failing to invest in surgical systems costs more through disability, preventable deaths, and economic loss. Next slide. There's also this notion that burden of surgical disease is low, but in reality, nearly 28 to 32% of the uh, global burden of disease requires surgical care. And lastly, many think training more surgeons alone will solve the problem, but surgical systems require much more than that. Um, we need anesthesia providers, nurses, infrastructures, transportations, financing, and other referral pathways. This is also why global surgery is very difficult to advocate for. Unlike vertical programs like HIV and TB, surgical care is cross cutting and deeply interconnected in broader health systems. The barriers are very multi layered, involving workforce, infrastructure, equipment, and the likes. Next slide. Oh, so other side? Thank you. Okay, one of the things that Incision Global does is that we ensure that the youth voices are represented in discussions on universal health coverage and surgical system strengthening. For the past few days, we've been involved in the G4 Alliance Permanent Council meeting, but before that, we also engage um, in advocacy efforts through partnerships like with Acute Care Action Network, where we're directly participating in planning and improving emergency, critical, and operative care or eco care. So tomorrow, I just want to say that tomorrow in this WHA will discuss the draft of global strategy for integrated eco care for 2026 and 2035. It's an important milestone for the surgical systems globally. So we also organize this Global Surgery Day 20 every year, every May 25, where national working groups worldwide hold campaigns, workshops, and discussions to raise awareness and inequities in surgical access. So this year, we're releasing a position paper and call to action. One of the organization strengths is the national working groups. So they respond to the realities within our own communities. So, for example, in Incision Moldova, the advocates are exploring barriers to surgical care among refugees and impact of surgery on climate change. For us in the Philippines, we do analysis on cancer care. And at the same time, we partner with Philippine colleges of surgeons to develop their national surgical plan and their rural surgery curriculum. And in Singapore, they have this thing called Incision Challenge where they teach students surgical skills and quizzes, but more than the technical one, they actually encourage critical thinking to encourage these students to think about equity in healthcare delivery in resource limited settings. Okay. So, how else can young people help? So, I'm sure you'll hear this a lot today since a lot of us are in the youth. First, learn more and participate. Follow organizations, attend discussions, stay curious, about the health systems and equity. Doesn't matter if it's global surgery or universal healthcare. Join advocacy groups, research initiatives, and campaigns such as Global Surgery Day that we have on May 25. You're probably already in it since we're already all here. Secondly, we engage in policy spaces. So again, tomorrow at 2:30 p.m. there's a WHA agenda tomorrow and committee A. Yeah. In Committee A, they will discuss the draft global strategy for integrated eco care 2026. So it's a really big milestone. Um, and even listening to these conversations that we have right now is already a meaningful step towards engagement. And lastly, surround yourself with people who inspire and challenge you. I certainly wouldn't be here literally on this stage right now if I'm not surrounded with those kind of people. So we, the youth, are uniquely positioned to bridge disciplines, collaborate, and push more inclusive and equitable health systems. So because universal health coverage cannot truly exist if 5 billion people are still left behind. So, thank you.
Thank you. Thank you so much, Rina. So now we're going to move on to the second topic, which is integration and inclusion in UHC. And their first presentation is going to be on youth and NCDs, and it's going to be from Nupur Lalvani, from the founder director from, sorry, one before, from Blue Circle Diabetes Foundation, and Anita Sabidi, a patient advocate from VAA Diabetes Strategic Committee. You can.
Hi, everyone. Good evening. My name is Nupur, and over the next 2 minutes, I'll be talking a little bit about youth, NCDs, and UHC, and then hand over to my colleague Lindsay, who's filling in for Anita. Um, Firstly, I'd like to thank the organizers, CSEM and Transform Health, for creating the space. I was just chatting with Amy outside, and how this is such a safe space. The WHA can be overwhelming, intimidating, lots of things, but for us here is a safe space for civil society and youth to congregate and network and exchange ideas. So today I'm speaking on behalf of a coalition of organizations that work in diabetes and NCDs, the Voices in Action, Diabetes Action Canada, Sante Diabete, the intersection of intersectoral forum of NCDs in Brazil, and the Blue Circle Diabetes Foundation. And we're going to cover three things very quickly. What we do, how we plan to progress towards UHC, and how can we have more youth involved and engaged in these sort of events. So all of these organizations that I just spoke about work in the space of our patient organizations that work in the space of patient engagement and diabetes and NCDs. And one of the goals that all of us have is to elevate the voices of lived experience and have them not just there in a tokenistic way just because it's nice to have, but actually have them in positions and build capacity to have those voices on tables that really matter. And so that's something that we've been wanting to talk about and to do. I'd also like to invite Lindsay now, and she can also share something from her perspective.
Thanks, Nupur. Hi, everybody. I am not Anita. My name is Lindsay McCauley. It's a pleasure to be with you today. I come to you with lived, loved, learned, and labored experience of NCDs. So my lived experience is as someone living with diabetes and multiple other disabilities. I have loved experience by caring for family members with mental health conditions and other chronic diseases. I have learned experience because I went to school for biopharmaceutical sciences and healthcare management. And last but not least, I have labored experience in the healthcare system as the Director of Patient Engagement for Diabetes Action Canada, a pan-Canadian research network that connects the dots between patients, researchers, and policymakers to co-design everything from a research question together to how do we deliver care in a hospital or at home, to how do we testify in front of Senate, for what universal healthcare means for people living with chronic conditions. I also hold the hat today as Canada's youth delegate to the WHA. And what that means is that I have the role of trying to represent youth needs across the country at a multilateral forum like this. And I wanted to just bring 3 takeaways from those hats for all of you today. One piece around the youth engagement in multilateral global health spaces, but also as a person with lived experience, we're tired. Like, we do a lot. I don't know any young person who hasn't worked multiple jobs at any given time. You're studying, you're volunteering, you're most likely caring for aging parents, but maybe sometimes children as well. I think people forget that young people are uniquely positioned to be very exhausted. And one of the things that we've advocated for with the Government of Canada, as well as federally with the Ministry of Health, is that all youth programming, not only should it be compensated, but we provide a package of how do you describe this program in your resume, your LinkedIn, your resumes, your interviews. It's very vulnerable to say, I care about universal health care because I'm disabled. And that could lose you a job. So what we've done is we've created packages of how can you safely disclose this wonderful volunteer or advocacy experience without putting yourself in a position of vulnerability. The other thing that we've chosen to do at Diabetes Action Canada is to not have a youth advisory committee, but every single committee has a youth co-chair. And this has been really successful over the years because it allows for horizontal mentorship. We're learning from folks that are older than us, but they're also learning what it's like to manage multiple conditions right now and be 21 and go to school and maybe have a job and have multiple hats. The last takeaway that connects both of these is that the reason that we've gotten to those 2 success stories is because of nothing about us without us. Everything has been co-designed along the way. What universal healthcare might mean to Napur today is not the same thing that it means to me, and it might mean a different thing for her tomorrow as well. So that's why co-design is imperative in this work. My favorite saying is that most rules are suggestions. So if a space is not a co-design space, that isn't a rule, that's a suggestion, which means that you can suggest otherwise as well. So I encourage you to just suggest otherwise and make space for yourself in spaces that you don't feel seen or heard or visible. Thank you so much.
Thank you so much for these very inspiring words and personal sharing. It's great to hear about what you're doing in Canada, and of course, it's great to have your youth delegate. So we're going to continue the discussion on integration with Ida Mirkovic-Knaus, a rare disease advocate from Rare Disease Croatia and the Rare Disease International Youth Leader. Ida, the floor is yours.
Thank you. I do not have a presentation, but I hope I can get your attention anyways. So, universal health coverage. When we talk about UHC, we talk about equal access to care. We talk about affordable care. We talk about meeting certain quality of care, and we talk about how it should cover every group and every individual. But the thing is that when we talk about UHC, we are approaching from the presumption of that people want to be a part of healthcare systems, which is not always the case. So I am a social worker. I work with Rare Diseases Croatia, and what I hear from our patients is not only that they cannot afford healthcare. It's not only that there is not a certain treatment in our country. They are also talking about the fundamental things as a lack of psychological safety and trust in the healthcare systems, which leads to them becoming self-excluded from the healthcare system. And that can be explained through stigma. So stigma means that a person is being labeled as less desirable based on their characteristic. And in this case, it's a rare disease. So a person with a rare disease is less important, let's say, labeled as less important than someone who is healthy. And when people hear those messages from around the healthcare system, and it can be just small messages such as, oh, you're lucky to be alive. Don't worry about your appearance. There are people who got it worse with your disease, so be thankful for that. Or do not worry. It's we don't know what will happen. To minimizing how people feel, and they start to believe those stories. They start to self-stigmatize themselves, and they exclude themselves from the system. They start skipping their like regular checkups. They start not talking about what their condition is currently. They are not. They do not have trust in their uh, medical professionals who they work with, and it is dangerous when that stigma becomes internalized because people back up and they are not no longer a part of the healthcare system. And the youth, I think, is already kind of leading a global conversation on mental health. And I think the stigma has to be a part of that conversation because it is an invisible barrier that we often overlook. But the thing is that we talk about people who in the healthcare system who cannot access care because it's expensive, but we forget that we have people outdoors who are not even in the room because they are too ashamed to come into the room. They're too ashamed to share how they feel, um, what are they struggling with, and we need to recognize that because we cannot talk about universal health coverage and having invisible patients at the same time. So one excludes the other one. So this is a community that is hard to reach because they believe that they really do not belong here because somebody else is more important than them. And we have to kind of dig back to them, find those people. We have no idea how many people left the healthcare systems because of those experiences, but it is our job if we want universal health coverage to find those people and to get them back into the system. Yeah, thank you.
Thank you so much, Ida. It's very important to also hear this part of the story because there's a lot of times that we also see healthcare in numbers and we leave these people behind because maybe they're not the majority, but they're still people. They're still humans and they need this care and this access. So thank you for bringing this on the table. And the next topic we're going to discuss is about AMR. So I'm going to invite Dr. Pablo Estrella Porter, the chair of the World Medical Association Junior Doctors Network, to tell us a little bit more about how youth is engaged in AMR.
Thank you so much, Anna. And it's also an honor to be here present, actually, with a couple of hats. As Anna mentioned, the chair of the WMA Junior Doctors Network, as well as a WHO Youth Council member, and more relevant for today, also the chair of the Quadripartite Working Group on Youth Engagement for AMR. When we talk about UHC, you see that it's really a common point for youth to care about. When we talk about UHC, is also not just about the access to health, but also the effectiveness of it, the quality, and also the cost effective as well. But it's true that antimicrobial resistance, AMR, can put also a breakout point where all of this can be threatened. Next slide, please. So the Quadripartite Working Group, it's a working group created by the four big organizations on One Health, WHO, FAO, the United Nations on Environmental Program, and the World Organization of Animal Health. And it's a structure representing 14 youth-led or youth-serving organizations, some of them included here as well. And our work is mainly how to drive forward youth voices and youth representation on the antimicrobial resistance work. Next slide, please. Just to bring you some success stories, a few months ago, we had the high-level meeting from the United Nations on antimicrobial resistance. And we organized a youth consultation where we tried to hear the voices of youth on the priorities that they have around antimicrobial resistance. And we actually created this youth manifesto, which was a document that was highly distributed and used in around the high-level spaces. We agreed, or we found that there were 4 main points. There was advocacy and engagement of youth, the education and capacity building, the patient care center, and addressing AMR in a One Health approach. Next slide, please. Another really success story is that we work also on educational materials for schools. This is a story called Leslie Got Malaria, which is a book talking about also the resistance around malaria in a really friendly and school focus. Next, please. Most recently, we also published this policy brief that is mobilizing youth leaders in actions on AMR. We work together with these different youth representatives where we identify a couple barriers and action points. Next. So when we talk about barriers in youth participation, this might be also relevant in other areas, not just antimicrobial resistance, but first was this limited awareness about the topic of antimicrobial resistance. Then that we find that there's still a lot of tokenism when we talk about engagement, as well as insufficient funding for youth to be present at the table. Unequal access to training at networks, the lack of diversity and inclusion in these spaces, and especially on AMR, we have to think that it's not just about human health, but we have to give it a One Health approach as well. The fragmented multi-sectoral collaboration that is included also in this lack of One Health, and the weak monitoring and evaluation of indicators. Next slide. So what was our suggestions or strategies in this policy brief was we need to integrate youth in the national antimicrobial resistance committees and national action plans, as well as we need to provide the capacity building, mentorship, and as well accessible training. We have to try to find these fundings for and small grants for youth-led projects, especially on a local and a national level, and ensure also the gender balance and the diverse participation. Next slide, please. So for this, I want to also share that we've been trying to collect also AMR initiatives. In the past AMR 2026 summit that happened in Sydney, we also made an open call for youth to share their initiatives. Next slide. Where we identify 44 youth-led initiatives on AMR from 19 different countries and 5 regions. Next slide. Here's just a map of the ones that we showcase in this AMR summit, but just for you to have a general idea of the ones that we were able to locate in a really short time. So it's for sure that there's many more out there. And one of the new initiatives that we're trying also to identify to come together with youth, next slide, is we're trying also to create this AMR burst. This a first proposal. We're still looking for funding, but basically is a centralized place where youth will be able to find the different youth activities happening across the globe, resources, the toolkit that we have been working on, as well as stories and a place to come together around AMR. Next slide. Just this how this will look. One more click, please. So we will try also to integrate in one single place all the different AMR activities for also providing inspiration of what's happening around the world and also to connect these initiatives. Next slide. And our other big proposal is we are trying also to find the funding to creating this training of trainers capacity building initiative where we can put into practice the youth toolkit that we also have that is AMR toolkit for youth engagement. We already have a proposal and we're trying also to have these capacity buildings from around the world. And the idea is also to have local trainers and advocates from different One Health areas to create also a network of trainers that will be connected as well in this AMR burst. Next slide, please. So as you see, this is a bit of what is happening. And I'm talking also on behalf of all the youth that are super motivated on the AMR space. If you want also to get to know more of the activities that are happening around AMR and youth, I encourage you to follow on Instagram, Youth Voices for AMR. We're also trying to centralize different youth initiatives on AMR. Thank you so much.
Thank you so much, Pablo. I think you're the expert beyond youth to present this topic. It's a pleasure to have you here. So we're going to move on to the last topic, which is digital transformation and the future of UHC. And it will be presented by Alejandro Areora Rodriguez from Transform Health. Alejandro.
Thank you so much. Hi to everyone. Pretty happy to be here. Pretty happy to be another voice for the youth. And I would like to start with our slogan from Transform Health. Health for all in the digital age. And that's quite a challenge. Health for all. This involves youth, as we can see. So we thought, how can we solve this challenge? How can we make sure that youth voices are being heard and are being taken in account? So, as we already know, young people, we our young people are living in realities of digital transformation, but our perspectives, our ideas, our needs, and our experiences are not being taken in account. So that's quite a problem because right now we are shaping the future of medicine. Right now we are shaping the future of policies that we're going to live in it. And our perspectives and our point of view probably are not being taken in account. For example, right now, global strategies as the WHO New Global Digital Health Strategy for 2027 must include diverse youth voices. So in Transform Health, we thought, what will happen if we include or we reach hundreds of youth voices to listen to them, to understand their desires, their needs, their point of view, their experiences. So we didn't stop there. We did it. And the result was something called Youth Call to Action that you can see right there. You can scan the QR code. And in this Youth Call to Action, what we did basically was during 6 months, we gathered more than 300 opinions of youth people. But these opinions came from 6 different countries and 3 different continents: Kenya, Senegal, India, Indonesia, Ecuador, and Mexico, of course. So the results were very interesting because we captured young people digital barriers, opportunities, and priorities. And we found out that young people care about digital health because we believe it. It directly shapes how we access, experience, and influence health systems in a rapidly changing world. As I already told you, we're going to be diagnosed, we're going to be treated, we're going to have follow up from these policies, and we have to shape them uh, correctly. We believe that digital health offers a pathway to bridge the healthcare access gap, enabling more inclusive, youth-friendly, and responsive services. So we reflected some realities from clinics to classrooms, was a wide variety of opinions, from online platforms to innovation labs, and we revealed what truly matters to us. These themes include, first, data rights and privacy. As you know, ensuring data protection ensures people protection. And if we ensure people protection, we ensure their trust, which is kind of really, really important. Second, sustainable and equitable financing of digital health. Third, leadership and coordination of digital health. Fourth, equitable access to digital health. 5, digital literacy and meaningful youth engagement. We don't only want to have access to digital tools, we want to know how to use them. Quite important. And finally, we want to be included. We're not just some consultants, we're not just participants, we're action takers. So that's the future of youth in this matter. And that's it. Thank you.
Thank you so much, Alejandro. And with this, we close the presentations and move on to the main point of this side event, which is networking. Next slide. And next slide. Okay, perfect. So here are the 4 groups that we're going to divide into. As you can see, they're relevant to the presentations before, so we can continue the discussions and you can ask any questions that you might have. So the first one is strengthening health systems for access and equity. The second, integration and inclusion in UHC. The third one, youth leadership on AMR and global health challenges. And the fourth one, digital transformation and future of UHC. We will be divided in this room, and then we're going to rotate. So don't worry, you don't need to go all in one group from the beginning. Please divide, and then we're going to change again. The purpose of this session is, of course, to get to know each other. So please don't be shy. Introduce yourself. Talk to the person next to you. Talk to the moderator. Share your ideas on the topic. And let's see what will be brought in the discussion. After that, we're going to have a small briefing. So try to remember some things. So strengthening health systems is going to be here. The first one, we're going to go clockwise. The second one about integration is going to be near the door. AMR is going to be near the camera over there. And then digital transformation is going to be over here. Is everything clear? In Nate's group, you're going to have 7 minutes, and then I will announce that you change. Everything clear? Strengthening health systems here. Integration on the door, AMR near the camera, and digital transformation here near the stage. If you are confused, please approach me. Perfect. Your 7 minutes are starting now.
do some storage one have a better system because national those national insurance systems. So it will be high coverage about 99.8 percentage of people can get the systems. However, sometimes we are going to the some emergence and innovative medicines. There will be some kind of challenges. Then there will be that's very high. So not everyone can get it in their first life. So that will come to the business insurance system to cover that. And there was some coverage requirements, such as you have to have some hospitalizations. So you cannot look at the one, not to take the ID one. So that will be another issue in the one systems. So how we can address this one? We can have some other beneficial issues to our government. Let them know why the sub to one will be much more necessary for them. Such as, for example, the narcotic drug, because I'm more familiar with the HIV and AIDS. In HIV and AIDS, we can find some PrEP system, PrEP regional PrEP, the prevention, especially the long-acting women, that will be more high effectiveness than males. Female can take PrEP on demand. Women can. Because of the gender has a multilateral issues, they can use the oral treatment in the maybe 2 or 3 days. It will take every day. So there will be highly requirement on their adherence. So we just share our government to sponsor the women in the very beginning. And if the program will be success, they will can export to other populations. So that's just our strategy. That's my sharing. Thank you. Yes.
Hi, everyone. Please close up the discussion. Finish the sentence that you're saying, of course. But then please change groups. Thank you. You're not moving. The rest are moving. Yeah. Try to move clockwise. Try to move clockwise, please. Try to move clockwise, please. Sorry. Okay, your time starts now. 7 minutes.
Why? And what does that mean? Like, doctors will often say, well, you're not healthy or you're unwell. Actually, I'm able to be healthy and well and safe. Like, we have to unpack what we think health looks like. We're more likely to become sick before the age of 40 than after. So actually, like again, it's internalized shame because we don't want ourselves to be by not becoming sick in the way that we use the world as so language actually has this really interesting dynamic on how people discriminate. If you're met with language that is welcoming, they're more likely to seek care, and sometimes seeking care is sort of cultivates that essential shame towards it.
One minute left. Time is up. Please summarize. Change groups clockwise. Hi everyone, please change groups. Please go to your groups. The time is starting now. You have 7 minutes. 1 minute left. Please wrap up. 1 minute left. Okay, time is up. Please go to the next group. Please go to the next group so we can close up the session afterwards.
It's fine. No more groups.
Okay. Because I think you're having too much fun in your groups, please sum up what you're saying and take a seat. Take a seat so we can have a discussion all together. Okay. Please, everyone, take a seat. Yeah, but it takes too much time to change between you. Okay, let's go back to our seats. Perfect. I want one of the moderators of each group to come here with me. One of the moderators of each group can come here to do a small debriefing. Yeah, yep, it's you. So we can do a very, very short debriefing about what you discussed with the people in your groups. And at the same time, Laura is going to give you some post-its. Just keep them. We're going to explain later what you're going to do. So please pay attention to the debriefing. Who wants to start? We can start with the first group, strengthening health systems for access and equity.
So we actually only had one discussion round. Oh, you had a second one, then you go ahead.
Okay, so we had two discussions. So the first one, we went around and gave other people a chance to explain what they're advocating for and what their experiences on strengthening health systems for access and equity. So we got a lot of inputs about health financing and pharmaceuticals and how it's affecting the way patients receive their care. And so and then the second group, the last group, so we only had the first and the last group. So the last group that came in is also we discussed about how rare diseases are not often prioritized, and access and equity in healthcare services, which actually is really which is quite disheartening for in achieving universal healthcare. The second and the last group that we had was when we discussed the different healthcare systems around the globe. So we had one from Canada, UK, and Mexico. So we discussed the different challenges that were faced, despite having a universal healthcare. You know what I mean? Yeah. So yeah, and we were able to connect with each other after that, of course, and foster some partnerships to like push the advocacy forward. Thank you.
Thank you so much, Rina. And group one. So we're going to to continue to integration and inclusion in UHC. Who was? Yep, perfect.
All right. I don't know how many groups we had. I'm already failing at this job. There was some key like actionable takeaways and recommendations. We had multiple conversations around like what are the issues with integration and how do we increase equity, but I'll focus on some recommendations that came out of the discussions. One was the importance of language. How can we learn from wins on equitable language in healthcare professionals, but also within community horizontally? The Language Matters movement came up, and like having a tangible tool like the Language Matters movement, where it's a chart of commonly used phrases in a healthcare setting with more patient-centered, human-centered replacements for each phrase. This is important for all of us to use. Another thing that came up as a recommendation is how do we reach folks that are, I hate saying hard to reach because actually they're not hard to reach. We've just created a society that isolates them. So how do we reach folks that have been isolated by society? Well, you cannot be who you do not see. So how do we equip other folks in that community to be leaders, so that you see someone who looks like you or has the same condition as you and you can reach out to them instead of maybe reaching out to the healthcare system, which is much more traumatizing. We talked about how do we get more youth into these spaces. If you're invited to be a youth speaker or a youth participant, asking for 3 free tickets when they invite you. If they say no, ask for 1. If they say no, ask for a co-presenter. It's very hard to be the only young person or only XYZ in a room. Same thing goes for committees. Ask if you can share the spot with someone that has a shared identity as you. It makes the space safer for you, but it also increases representation. Besides that, we just said that it sucks right now, but it's gonna get better.
It's gonna get better. Thank you, group 2. And we continue with AMR. Pablo.
Thank you. So we had really interesting discussions. We also saw that there's a mix and diversity background on also the awareness and knowledge of AMR, but we concluded that still it's a topic that is super related, not just for human health, but the One Health approach was really needed. That's something we had to work towards. And something that we also identified with the last group is that many times we're working in silos. So for example, when we were working or talking about AMR, we cannot talk about AMR if we're not talking about UHC. So we cannot advocate just for one and trying to pull for each side, but actually give a step back, kind of see the bigger vision of where the common barriers, the common also goals that we're trying to approach, and trying to break those silos. And for that, at least my personal conclusion is that having these networking spaces also is really useful to see these views. And probably one last conclusion is that we've been focusing a lot on the health professionals' views, the human health, but we needed also to hear the patients' views, those living on the first line and have the lived experience whenever we're talking about these discussions. So it was great takeaway that apply both for AMR, for UHC, and I would say any youth engagement and advocacy. Thank you.
Thank you, Pablo in Group 3. And now, last but not least, digital transformation and Alejandro.
Right. So we found out many things in the conversation. First of all, biggest problem is that health systems are really fragmented, not interoperable silos. For example, in Mexico, in Brazil, public health versus private health normally, which blocks continuity of care. For example, in Kenya, this is a big example. We found out a key risk. Dependence on external temporary implementers can lead to loss of systems and records when they leave. What works for in other countries, we found out that targeted digital programs, for example, SMS, like text messages, or TB adherence for tuberculosis, AI imaging confidential helpless, show impact but don't scale without coordination. So this demonstrates that it's really important to take in account how we are including everyone in the health system. What's needed? We need strong government-led governance, sustainable financing, data rights privacy, digital AI literacy, equitable access, and real community decision power. In conclusion, digital health won't transform care through apps alone. Only coordinated, interoperable rights-based systems with sustained funding and literacy will deliver universal coverage. And well, I believe that's it. Thank you.
Thank you so much, Group 4. And after we summarized everything, we would like to ask you to use the post-it that you received and write a key message that you took from today's session, and if you want both, an action that you're going to take after today to support UHC and youth engagement. And in the meantime, if someone wants to share their thoughts on these questions, please raise your hand and I will pass you the mic. I have one too. Sharing is caring. Please provide your pen to the person next to you if they don't have.
Hello everyone, I'm Walter from the International Pharmaceutical Federation and the Health Diplomacy Alliance. And I'm also a HIV and AIDS advocate and professional in Taiwan. And I think if we can make the universal health coverage, what's the next step? Next step will be fighting the stigma. Why? Because stigma is an issue for impact of people's health, especially mental and physical health. Why physical health? It will impact your adherence. If you have some stigma, internal stigma, you might refuse to take a doctor, refuse to visit a doctor, so you won't get the drugs. In Taiwan, we have we may know the UN Act with triple 95. The first one will be diagnosed. The second one will be treatment, accessibility. The next one will be viral suppression. We do great on the second one and third one. However, in the diagnosed, people refuse to take a screening and testing. Why? Because stigma. So the stigma will be the next step, I think so. So that will be my reflection. Thank you.
Thank you so much. Anyone else would like to share?
Hello, my name is Ednan. I'm from the United Kingdom. And I suppose my reflection after all that we've spoken about today is a little bit selfish, but it's to focus on how countries like mine, like Canada, like the USA, potentially could look at their system and say, oh, well, maybe not the USA actually, could look at their system and say, we have universal health coverage, and we do not need to. So, for example, in the UK, the NHS is free, and governments don't necessarily want to prioritize this push for UHC because they think that there is already universal health coverage. But a lot of the stuff that we've spoken about and what I've heard from people here is about access and accessibility, and the things that stop people from accessing healthcare also count in the push for universal health coverage. So for example, it's the example I use all the time, childcare costs, transport costs, living in rural areas and different places where you actually can't get to the doctors even if the doctor is free. So it's just to be holding governments accountable or systems accountable where the healthcare is technically free. There are still issues within there that we should be advocating for. Thank you.
Thank you. And one last.
Just because Canada gets a lot of compliments for our healthcare, I need to sober us up a little bit. Canada has universal health care, no universal pharma care, and you can't have universal health care without access to medicine. No one goes to get diagnosed if they have no hope of affording their medications. So before we even go to things like we were talking in some of the groups, like clinics need to be physically accessible and socially accessible. But why get diagnosed if you can't get your treatments? So there is no UHC without pharmacare either.
Thank you so much. And with this, we're going to go to closing remarks. But before that, I would like to say that if you feel comfortable, please leave your post-it for us to keep so we can collect all the actions that we're going to take and all the outcomes from this session so we can possibly also display them and show what was today's impact and maybe also reflect in the future to see what has happened. Uh, and don't forget to take your video. As we said earlier, there's a booth outside. So we're going to pass to short closing remarks.
Thank you, Anna, and thank you so much all for like the participation today. And yeah, I'm glad also to hear a lot of different testimonies and the highlight. Also, thank you for the health cost that even like it's not really implemented fully in countries. So yeah, again, we have like a health cost hurt campaign. You're free if you want to share your stories by videos or with us. Sharing this lived experience matter a lot when they are compiled because then government cannot ignore the problem or the issue. So the more we have, the more diverse, the more geographical diverse too, the better. I'll hand over to my dear colleague from Transform Health for the closing remark, and then we'll welcome you at the front for a quick photo and close the session. Thank you.
So thank you so much. As we come to the end of today's session, I'd like to sincerely thank you for all the speakers and also the partners and youth advocates and participants for the powerful discussions, reflections, and also the meaningful ideas shared today. We have so much conversations right now, and I think that I would just like to remind that us that UHC it's not merely about the healthcare system, technology, or policy. It's about people. It's about the fundamental right to live healthy lives without fear of financial hardship and fully accessible for everyone. And this is why health equity cannot wait, and this is why youth voices matter now, and this is why advocacy must move beyond conversation into actions. And I hope from this discussion will resonate more about the leadership must access at every level, from the communities into global levels, and also the representation in decision making matters, because I could see there's a lot of youth and also representative from rare disease, AMR issues, or many issues like HIV, sexual and reproductive and mental health, and many more. And I believe that we have should conduct more and collaborations toward toward achieving the UHC 2030 by involving all the issues, and then ensure that lived experience matters, and health systems will crumble if we fail to invest in people and all of the communities. And young people are not only leaders of the future, they are leaders of today. So before we leave this room, I think I just want to remind you that we could just share the sticky notes, and then we could just take a group photo together in front of the this room, and then maybe we also have several properties here if you would like to take a photo from your own groups and also organizations. And from and again, thank you again for your energy, your voices, and your commitment to advancing universal health coverage for all. Thank you so much. So let's go to take a photo in front of here. Okay. Okay. So we'll take the picture. Oh, no, no. The first will be conducted here. Okay. So yeah. Okay, please everyone gather in front of the room. Hey, thank you.
Yeah, let's go.
Please kalian.
Let's go. You should be. Oh, okay.
Maybe you could just take